high yield systems, starting with CVS, embryo. So heart morphogenesis, first functional organ in vertebrate embryos. Four spontaneous beats spontaneously by week 4 of development, right? So you can remember week 4 by thinking about the cavities in the uh, heart. So there's like two ventricles, two atria, so that's four cavities. uh, Cardiac looping, primary heart tube loops to establish left right polarity, begins in week 4 of development. Okay. uh, Defect in left right dynein, involved in left right asymmetry, right? So that's when you have dextrocardia. That's when you have the heart on the other side, or the epic. You can feel the epic beat on the right side on the fifth intercostal space instead of the left. It as seen in Cartagner syndrome. That's the one where you differentiate between this and cystic fibrosis. Septation of the chambers. Okay, so uh, right, so four chambers, not cavities, but four chambers. So week 4, it starts beating. Atria. Septum primum grows towards endocardial cushion, narrowing ostium primum. So this is septum primum right here, and this is your endocardial cushion. So first thing that happens, it goes to this goes towards that, and wait, yeah. So septum primum, and this is called the ostium primum between the two. This will change as it goes, as it develops, right? So this is called different names. But for now, it's ostium primum and septum primum goes towards endocardial cushion. That's it. Second, ostium secundum forms in the septum primum due to cell death. Ostium primum regresses. Okay, so after there's a development here. Let's make that green. Right. So after this thing goes and grows over here like that. Get it a little thicker. Too thick. Okay. So after that grows, what happens? Some parts of the septum primum, uh, apoptosis happens, so it cell death happens, and when cell death happens, the gaps now are called ostium secundum. Okay. Okay. So now you have ostium secundum. So ostium secundum forms in septum primum due to cell death. Ostium primum regresses. Then 3. Septum secundum develops on the right side of the septum primum. Okay, so again, septum secundum develops on the right side of the septum primum as ostium secundum maintains right to left shunt. Okay, so again, right to left shunt means this one is going to push over here, right? Because you have to remember it's still a fetus, right? So they don't have all the cardiac muscles built, so majority of the blood coming in. Okay, so majority of the blood coming in are from the superior vena cava and the inferior vena cava. So the force of that is going to build up the right to left shunt for now, okay? Until the baby is born, and then the left ventricular. There's less resistance in the lungs, and there's left ventricular mass, like the muscles that will work as well. So that will change the polarity of the shunt. But for now, it's going to be right to left shunt. So this is important. And fetus, there's right to left shunt because of the blood coming in from the thing, and there's too much resistance in the lungs, so it can't go through the pulmonary artery, so it goes through the ostium secundum. Okay, so as ostium secundum maintains right to left shunt, then what happens is septum primum. So now we have this septum secundum forming, and we have ostium, right? So what we're gonna have now is, let's do this blue. So this is gonna grow towards the cushion as well, and this is going to come up here as well, right? And we already have ostium secundum. So septum secundum develops on the right side. This is the right side of septum primum. That's the septum primum. As ostium secundum maintains the right to left shunt. So as this is developing, right, there's still some gap here, so the blood's still going to flow through here to here. Okay. So over here now, we have septum secundum expands and covers most of the ostium secundum. Right, so this was ostium secundum, so it's going to come in and block that up to there. The residual foramen is the foramen ovale. So it covers it, but it's not attached to this yet, the septum primum, right? Then you have the remaining portion of the septum primum forms the one-way valve of the foramen ovale. So now you have this septum. So this thing now is a valve, right? So this thing is a valve. So when this thing is coming in, this is going to open up and let it flow through and then come back, flow through, come back, flow through, come back. Okay. Why is that there a pulse? It's not that it's pulse more so. It's just that the mother's pulse is pushing the blood through, so that pulse is going to transfer. That's why, it goes like that. It's very minute. So, okay. So septum secundum expands and covers most of the ostium secundum. Then the residual foramen is the foramen ovale. Remaining portion of the septum primum form the one-way valve for foramen ovale. That just means that it can go from here to here, but that's it. It can't come from here to here, because when it does that, it's going to push septum primum against septum secundum and closing the valve, so it can't do that. So it's a one-well valve. Septum primum closes against septum secundum, sealing the foramen ovale soon after birth because of increased left atrial pressure and decreased right atrial pressure. So why is there decreased right atrial pressure? It's because the lungs have opened up now. So right atrium can go into right ventricle, and then right ventricle can enter the pulmonary arteries. Okay. That's why there's a decrease of this. And now there's before there was like zero pressure in left atrium, but now there is some pressure coming in from the lungs as well, because now it's pushing the blood into it, right? Although the pressure is not going to be too much, because remember, they're not like big vessels, it's just small. So it's going to be like 5 mmHg of pressure kind of thing. Okay, compared to aorta is 190. Okay, septum secundum and septum primum fuse during infancy, early childhood. Okay, so in the early childhood, you still have this valve functioning. Not functioning, but it's still open, right? It's not fused to septum primum. So they're saying that it fuses during infancy or early childhood. So this happens after birth. Okay, so forming the atrial septum. If for some reason there is a cyanosis of some kind, we try to keep this open, or we try to keep the PDA open, or one or the other, to maintain the circulation. The common patho, I guess. So yeah, so now we have degenerating septum primum. This one we don't need that, and this make the valve, and then after they get fused, it's closed. Then no blood goes by. Okay, so patent foramen ovale, that's caused by the failure of septum primum and septum secundum to fuse after birth. Okay, so most are left untreated, can lead to paradoxal emboli, venous thromboemboli entering the systemic arterial circulation through right to left shunt, as can occur in atrial septal defect. Right, so what does that mean? Say there's a question about a person who was on a road trip, or he's been traveling to tropical islands because he's not a doctor, so or a student, so he can travel and enjoy his life. So he takes the plane, right? So what's the number one thing that can happen for step one if you're on a plane? It's DVT, right? So deep venous thrombosis. Then that gets detached and becomes an emboli, and then it goes through the system, right? So normally the emboli uh, goes through the system from the right atrium to right ventricle to pulmonary artery and gets stuck there, and that's why you have respiratory distress and respiratory embolism. But sometimes what happens is it doesn't just end up in the uh, it doesn't end up in the lung. Instead, it ends up in the brain. So how does that happen? Because it's hard to get through the lungs, right? Because it has a lot of narrow arteries, so it's impossible to get through that. It's kind of acts like a sort of a filter, right? So what happens is it goes through this. So sometimes when um, they're they're sitting down and then they get up, so there's a reduction in venous return, so that can make the shunt go from left to right to right to left, right? Or any activities that does a temporary reversal of the shunt. So then this thing, if it's not fused, the embolism or embolus will come in and then flow through here, right? So it comes from superior vena cava. Sorry. Okay. So it can come from superior vena cava or the inferior vena cava, right in here, and then the embolus can just stay here somewhere and just keep flowing over here, or it can go through, right? But there could be chances that while this is here, you do something or some kind of activity that makes this go from a left to right shunt. So left to right is just going from this to this, or left ventricle throwing the blood into the aorta. Instead of that, it's going from the right atrium to left atrium, right? So it flows through that to there. Then this goes after everything's normalized again. Then this goes from left atrium to left ventricle, and then through the aorta, and from aorta to the coronary to cerebral, right? And then you have a embolus in the brain causing stroke and ischemia, right? So that's how that happens. So that's what this means, that it can lead to paradoxical embolus, emboli, venous thromboemboli entering the systemic arterial circulation. So now, since it came from SVC or IVC, that those are veins, right? Not arteries. So that's why it can enter from venous blood into the oxygenated or arterial blood, right? Which is going to be in the left atrium. So it can lead to paradoxical emboli, which is venous thromboemboli entering the systemic arterial circulation through right to left shunt, as can occur in our atrial septal defect. Okay, so remember, so atrial septal defect happens because there's a failure of fusion between septum primum, the green one, and septum secundum, the blue one. Okay. Heart morphogenesis continued. Okay, so now we're doing ventricles. So how does the ventricle develop? So where we ended up was this septum right here has been made, and this is the endocardial cushion. Okay, so now we have the so let's read one muscular interventricular septum forms. So now this is the muscular interventricular septum right there. Oops. Right there. Right, it's between the two ventricles, right there and there. Then we have aorticopulmonary septum rotates and fuses with muscular ventricular septum to form membranous interventricular septum, closing the interventricular foramen. So we have the interventricular foramen right there. Okay, so what happens is the aortical septum rotates, right? So this is the aorticopulmonary septum, And then what this is gonna go, actually it's gonna go the other way. So this is attached to this, and imagine there's a wall right there, right? So a wall that's attached to this is now being twisted, right? And it's on the back there, so you can't see this side on over here. But then you have this side and twisting it. So now this side is behind here, and this is a new side here, right? So that's how it's twisting, if you can make that understanding. So just imagine you have like a, I don't know, let's say a piece of clothing that's crumbled up. So you rolled up the piece of clothing, right? So when you're rolling it, that's twisting it, right? So that's how it twists over here, right? So imagine your hand is here and your hand is here, and this hand is rolling forward and this hand is rolling backwards. So that's the kind of twist that's happening here. Okay, so aortical pulmonary septum rotates and fuses with the muscular ventricular septum. So these are the muscular ventricular septum, right? This is the interventricular and this is the muscular ventricular septum. So this one attaches to this side and this end attaches to this side. So with muscular ventricular septum to form membranous interventricular septum. Okay, so it does that and then it makes this as well. So this is going to attach to this, right? So that's how it's going to be attached to muscular and interventricular septum. Okay, closing the interventricular foramen. Since this is the foramen, so if you can imagine if this is attached to this from here to here, all of this going to be covered up with, you know, the septum. So there's no foramen now. That is ugly. Okay. So now we have growth of endocardial cushions separates atria from ventricles and contributes to both atrial septation and membranous portion of the interventricular septum. Again, growth of so that's the endocardial cushion. Separates atria and ventricle. Okay, so it separates the atria and the ventricle and contributes to both the atrial septation and membranous portion of the interventricular septum. So this, you can imagine, is the important structure, right? Because this is the structure that divides the atrias and the ventricles. That's all it's saying. So it separates atria from the ventricles and contributes to the atrial septation. So it also divides the two atrias, and because that's right atrium, that's left atrium, so it's going to divide those two. And now that it's over here, it's going to divide the two ventricles as well, and ventricle and atria and ventricle as well. Right? So what happens when this doesn't fuse to this, right? So you get a ventricular septal defect. Most common congenital cardiac anomaly usually occurs in membranous septum. So when this fusion doesn't happen, this is the interventricular foramen stays open, right, on this side. This is fused, so you won't have RA and RA and RV or LA and LV, but you will have LV and RV communication, right? So again, ventricular septal defect, most common congenital cardiac anomaly, usually occurs in membranous septum. So that's your membranous septum. Okay, and that's the end of the hard part. Outflow tract formation, neural crest cell migrations, which leads to truncal and bulbar ridges. So since we need to know what those are, let's just bring this over there. Okay, so when it's made, this is what the thing's going to look like, right? So okay, so you have neural crest cells, cell migration. Remember, there's epiblast, hypoblast, and then it turns into like bilaminar disc, turns into the three layers, endoderm, mesoderm, and epiderm, or whatever, ectoderm. Sorry, right? So the biliary disc, this is where it comes from, neurocrestal migrations, right? So then you have truncal and bulbar ridges that spiral and fuse to form aortico pulmonary septum. Okay, so that's this part right here. And then you have ascending aorta and pulmonary trunk. So after this thing twists around like that, these arrows are showing you the twisting of it. So this doesn't move. It's the this part that moves. So that's the way. That's why it causes a, you know, again, imagine you're holding on to this end, right? You're holding on to this end, and then you're holding on to this end, and this is not moving, but you keep twisting it this backwards, right? Or the way the air is going. So what's gonna happen? You're gonna have a roll of clothing that's gonna end up like knots with like a little rolled knots, right? Like that. So that's how the heart is formed. Ascending aorta and pulmonary trunk. So you have, this is the truncus arteriosus. So that's the truncal, and this part is called the bulbar part. Okay, or and then the ridges would be the bulbar ridges. So that spiral and form fuse to form aortical pulmonary septum. It leads to ascending aorta and pulmonary trunk. Uh, just to be thorough, this is what I mean. So roll clothing. Hopefully nothing bad comes up. So yeah, some kind of like that, right? So not this, uh, you know, organized, but like just a random, say, a towel, right? So when you roll it and then you hold one end, the other end, and then you keep rolling this end, but not move this, you're gonna get a little knot that looks like the heart, like that, right? Okay. Conotruncal abnormalities associated with failure of neural crest cells to migrate. So you're gonna have transposition of great vessels. Okay, that means rather than having, let me just go with that part. Where'd it go? It's still in physio. Okay, so transposition of great vessels. Rather than having the pulmonary arteries in the right ventricle, you have the aorta in the right ventricle. And rather than having the aorta in the right ventricle, you have pulmonary arteries in the left ventricle. Sorry. Rather than having it in the left ventricle, you have pulmonary arteries in the left ventricle. So you can imagine that this is a closed system, right? Because the blood comes from the lungs, enters the left atrium, goes to the left ventricle, then this pumps it out into the pulmonary artery instead of the aorta, right? Then it goes back to the lungs, comes in, and that. So you're gonna have cyanosis, right? Cyanosis is basically no oxygen. Okay. Tetralogy of Fallot is a triad of four things. We'll do that as well. Persistent truncus arteriosus, we'll do that as well. Okay. Valve development, aortic. So these are just the outflow formation abnormalities. Okay, these three at least. Then you have valve development, aortic pulmonary, derived from endocardial cushions of outflow tract. Mitral and tricuspid, derived from fused endocardial cushions of the AV canal. That's atrioventricular canal. That would be your mitral and tricuspid, right? And these are your aortic and pulmonary valves. Valvular anomalies may be stenotic, regurgitant, atriotic, for example, tricuspid atrasia, or displaced, for example, Epstein anomaly. So stenotic is it's stenos, so there's no flow, or it increases pressure, and that's when it opens up. And then you have regurgitant backflow of the blood, and or atriotic, like tricuspid atrasia, so you don't have a valve there. Or displaced, like Epstein anomaly. So it's the tricuspid gets there's atrialization of the ventricles, right? So what that means is normally you say this is your uh, right ventricle and this is your uh, right atrium, right? And then you have a valve there. But now what's happening is your atrium in Epstein anomaly, it extends into the right ventricle, and now your ventricle that used to be like that, now is like this. Okay, so it has atrial part is in the ventricle, so it's called atrialization of the ventricles. Okay. Hold on, let me check. Atrialization of the ventricle, it means, right? Okay. Now we're doing aortic arch derivatives, and they develop into the atrial system, right? So first is max. That's the maximum number you can have in a classroom, I guess. So part of maxillary artery, branch of external carotid. First arch is maximal, right? So maxillary artery is a branch of external carotid artery. Side note, you guys should know the branches of external carotid artery. They're like 8, right? So you have, starting from the top, you have facial artery, then the tongue lingual artery, then the thyroid, so superior thyroid, and behind it you have ascending pharyngeal artery, and then you have the ears, so posterior auricular artery, and behind it you have occipital artery, superficial temporal artery. So part of this would be the maxillary artery, I guess. Right. So maxillary artery, external carotid artery. First arch is maximal. Then you have second stapedial, S for S, so stapedial artery and hyoid artery. Second stapedial artery. Okay. Okay. So where is that? So we have external carotid, and you have internal carotid here. You have common carotid coming in and making this. We don't have first here. We don't have second here either. Okay. So the third is common carotid artery and proximal part of the internal carotid artery, right? So this would be the proximal. This anything above would be distal. So when you're doing proximal and distal, you're always thinking in terms of where the core is in your body, right? So anything near the core would be proximal. Anything away from the core would be distal. So that's what it means. Common carotid artery and proximal part of the internal carotid artery. So that would be this part. C is the third letter of the alphabet, so you can remember it like that. So the third arch is derived from C for common carotid artery. Okay, and then you have the fourth aortic arch, right? This part on the left aortic arch. On right, it makes the proximal part of the right subclavian artery, right? That thing right there. So fourth arch, 4 limbs, systemic. This is the important one, the fourth, because it's not the same on both sides, and the sixth as well. So this is the proximal part of the pulmonary arteries, and on left only. Okay, so this is the left side, so it's only on the left, and this is the one that makes the ductus arteriosus. That's why it's the important arch. So sixth arch equals pulmonary, and the pulmonary to systemic shunt. That's the ductus arteriosus. Okay. So why does this exist? Right? Maybe they tell us here. But yeah, they'll tell us over here, so we'll do it there. Okay, so again, revision. First is the maxillary artery. Second is the stapedial artery. Third is the common carotid artery. Fourth, on the left, it makes the aortic arch, and on the right, it makes the right subclavian artery. And on the sixth is it makes the ductus arteriosus. Only on the left. Okay. Nothing on the right. So here you have right recurrent laryngeal nerve loops around product of fourth arch. Okay, so the fourth arch, right subclavian artery. So right recurrent laryngeal nerve goes around it or loops around it. Remember that. It's part of an anatomy question. And then you have left recurrent laryngeal nerve. Okay, so this was right recurrent laryngeal nerve, and this is the left recurrent laryngeal nerve. That's easy to remember because it's right and left. And it's laryngeal loops around the product of sixth. That's the important one. Okay, ductus arteriosus. Okay, and this would be the arch by the fourth, right on left. It makes the aortic arch. Cool. With that, heart embryo. So embryonic structures, and it gives what it gives rise to. Okay, so. Okay, so truncus arteriosus, ascending aorta, and pulmonary trunk. Okay, that's the initial part of the thing that goes like, so see, this is the heart, this is the aorta, right? So it's this part. This is called the ascending, and this is like the whole aorta, right? So this is descending. This is the aortic arch, and the thing that attaches this to the heart. Between the arch and the heart, it's the ascending aorta. Okay. So the truncus arteriosus, it's in the name, right? It makes the two trunks. The trunks for the aorta and the pulmonary trunk. Then bulbous cordus. This is the smooth part, outflow tract of left and right ventricles. Okay. These are the ventricles, and left and right smooth parts are made by bulbous cordus. Primitive ventricle, that's trabeculated part of the left and right ventricles. Okay. You have primitive atrium, trabeculated part of the left and right atria. Then you have left horn of sinus venosus, coronary sinus. Okay. Then you have right horn of sinus venosus. Okay. Smooth part of right atrium. I'm going through this because they don't really test you on these. So endocardial cushion, atrial septum, membranous part, or the interventricular part. We already did that one. Endocardial cushion, so it makes the septums, and the AV and semilunar valves, right? So atrioventricular and the semilunar valves. Then you have right common cardinal vein and right anterior cardinal vein. This makes the superior vena cava. Posterior cardinal, subcardinal, and supracardinal veins. That's inferior vena cava. Okay, and then you have primitive pulmonary vein, which makes the smooth part of the left atrium. There's no point of spending time on this because we probably forget it as soon as we're like on the third page, right? But the ones you should remember, I'll just go over that one. If they ask you, they'll ask you about the truncus arteriosus because that's an easy one. They might ask you about what makes the superior vena cava and the inferior vena cava. I don't, and maybe this too. Left, no, they don't ask this. So, yeah. do these on your own time because I'm not going to bother with them. Okay. Fetal circulation. So this is an important topic. Um, the questions can come like, okay, so how which vessel takes out the deoxygenated blood from the fetus, or which one brings in the oxygenated blood from the mother, uh, or which artery travels through the fetus that carries the oxygenated blood, or vice versa. So these are the type of questions they'll ask, and they might even ask what is the first. No, wait. What did they ask? Which? Okay, a blood that comes through the umbilical vein. Uh, it'll come to me as we go along. So let's read this. Blood in the umbilical vein has a PO2 of approximately 30 mmHg of pressure and is 80% approximately saturated with O2. Umbilical arteries have low O2 saturation. To get this is why mothers during pregnancy have increased blood volume, have hypertension, increased GFR, and all that stuff. It's to reach this. So they increase blood mass, blood volume, everything to have this happen. And they also hyperventilate during pregnancy, right? Normally it's around, maximum is around 20 breaths per minute, but for pregnant ladies it goes higher up. Their heart changes as well, it remodels a little, all that stuff. And so that the fetus can have 80% saturated oxygen. If I said baby, I'm sorry. I know that's a controversial topic. Okay, three important shunts. First is ductus venosus. Okay, so what's the importance about this? It's blood entering fetus through the umbilical vein is conducted via the ductus venosus into the IVC, right? Bypassing the hepatic circulation. Okay. So it's again, you don't need this kind of circulation because you don't have anything in your abdomen, right? So you don't need the portal circulation yet. The splenic systemic circulation, right? You don't need that. So initially what it's going to do is just going to bypass it because you get your nutrients and stuff in the fetus from the mother anyways, so you don't need it from here. So there's no blood there either, and obviously the fetus is not having chips or pizzas or anything, so there's no point of that either. So it bypasses the whole hepatic circulation. So it goes from here, so it starts from here again, the placenta comes in the umbilical vein, 80% saturated oxygen. Remember, it's flipped around. It's vein, but it's still oxygenated blood. So it bypasses this. And how does it do it? It does it through ductus venosus. After it bypasses it, what happens? It goes into the IVC. Okay, and this is, I think, the one that they ask. The umbilical vein, which one after the first duct it passes, or after it travels through the duct, which vein does it go into? So it's the IVC, not the superior vena cava, the inferior one. Okay. Most of the highly oxygenated blood. Oh yeah, they also ask which chamber will have the highest oxygenated blood. So that's the question I was looking for. Okay, so they ask in a fetus which chamber will have the highest oxygenated blood. So that would be your right atrium. Okay, normally in a normal person it's the left atrium, right? Because it comes from the lungs after getting oxygenated. So right atrium first, and then it goes to the left atrium second, and then the left ventricle, and then through and through. Why? Because there's no point of going into right ventricle. Even if it does, it's going to be backed up by the resistance of the lungs, so it's going to be backflow of, or like, stagnant blood kind of thing. Not stagnant, but it's very less amount of blood that goes into the lungs. So most of the highly oxygenated blood reaching the heart via the IVC is directed through the foramen ovale into the right atrium, right? So it goes through that. Then we have, so that's another thing that happens in a baby that doesn't in a normal person because it's fused. Which ones? The septum primum with septum primum with the septum secundum, and this is a one-way valve, right? And with a right to left shunt. We have deoxygenated blood from the superior vena cava, passes through the right atrium, goes to the right ventricle, and goes to the main pulmonary artery, right? And so why is this not stagnant, right? I said that there's resistance in the lungs and everywhere. So what happens to the blood that goes through this? If the blood doesn't keep moving, it's gonna clot, right? So what happens is there is a bypass over here going from the pulmonary artery straight into the aorta, right? So that bypass is called this ductus arteriosus. So SVC passes through the right atrium, so it comes from up here, so it has a momentum going downwards, right? So it goes down through and through, whereas IVC has a momentum going this way. So this momentum is going to take it to the right ventricle into the pulmonary artery, and from the pulmonary artery, it's going to go through the ductus arteriosus, right? So main pulmonary artery to ductus arteriosus to the descending aorta, okay? And the shunt is due to high fetal pulmonary artery resistance, okay? So the lungs are creating the resistance. And then after it reaches that, it just goes through and through, downwards. Cool. At birth, infant takes a breath. So when that happens, the lungs inflate, and then the resistance against the, because how does the resistance happen, in case you can't make that out? So this is the vessel, and the lung is, so imagine all the vessels are like this, right? And it's in the lungs, right? And lungs are deflated, right? So it's pushing downwards onto the vessels. So when it's inflated, what happens is now it's inflated, and now the vessels are not getting pushed external force, right? By external force. So now the resistance is decreased because of that. So decrease in resistance in pulmonary vasculature leads to increase in left atrial pressure, right? Okay, so let's get rid of these. Okay, so at birth, a decrease in resistance, increase in pulmonary vasculature, so increase in left atrial pressure. So normally, since there was nothing coming from the lungs into the left atrium, it was just the amount that was coming through here, right? Which wasn't much. So now there's increase in pressure because now it's getting it from the lungs itself, right? So that's why there's increase in left atrial pressure versus the right atrial pressure. So now the shunt is gonna reverse. Okay, so left atrial pressure is increased versus the right atrial pressure. So then the foramen ovale closes, now called fossa ovalis. Okay, so increase in O2 from respiration and decrease in prostaglandins from placental separation will lead to closure of ductus arteriosus. This is an important line. Okay, so you need a decrease in prostaglandins for that, and you need closure. You need increase in oxygen. and decrease in prostaglandins to close the fossa ovalis. Okay. That's why if for some reason there is a patent or patency, we give NSAIDs, for example, indomethacin, ibuprofen, or acetaminophen helps close the pain ductus arteriosus. Okay, didn't talk about ovalis. So in case there is, for some reason, cyanosis, because of some abnormality, we would try to keep this open by giving them prostaglandins. Okay, so as long as you keep giving the prostaglandins, these two won't fuse, and that is one of the methods we keep the circulation saturated. Okay, okay. So say this thing, prostaglandin. Sorry, the ductus arteriosus stays patent. That's called patent ductus arteriosus, so PDA. We can help it to, you know, regress or close by giving indomethacin or ibuprofen or acetaminophen, which help close the patent ductus arteriosus. How? It decreases prostaglandin. So ligamentum arteriosum, remnant of ductus arteriosus. So after it's closed in adults, it's known as ligamentum arteriosum. So the fate of PDA or ductus arteriosus, just ductus arteriosus, is called ligamentum arteriosum. Okay. Endomethacin ends the PDA. So prostaglandin E1 and E2 keep PDA open. So we also try to keep this open as well in case of cyanosis. So whichever one, one or the other. I guess it's usually this one, not the ovalis, fossa ovalis, but it's going to be this one that you try to keep open. They won't test you on the ovalis one, I guess. So we give prostaglandins to do that. Okay, fetal postnatal derivatives, fetal structure. How much time do we have? Okay. Fetal postal derivatives, fetal structure, postnatal derivative, and notes. Ductus arteriosus, ligamentum arteriosum, near the left recurrent laryngeal nerve. Ductus venosus, so that will turn into ligamentum venosum. Oh yeah, remember, on this side it's this, and on the subclavian side it's going to be right recurrent laryngeal nerve, right? That was over here, this part, that told us about that. And this was a derivative of fourth arch, whereas on the ligamentum arteriosum is product of sixth arch, or PDA was product of sixth arch. Okay, foramen ovale is called fossa ovalis. Then you have allantoin. This is an important one. It's called the median umbilical ligament. We'll come across this in GIT as well. Uricus is a part of allantois between bladder and umbilicus. This is important because if there's some bits that didn't fuse and others did, then that'll create a cyst with urine inside. So that's what's important about that. Allantois turns into uricus. Okay, so patent allantoin or patent uricus, I guess. One or the other. Umbilical arteries, medial umbilical ligaments. So that's what that turns into. And then you have umbilical vein, turning into ligamentum teres hepatis, round ligament. This is an important structure as well. It's contained in the falciform ligament. So we'll do at least like 3 of these in GIT, or repro, I forget now. Probably GIT, because that one is on like the liver, in front of the liver. Okay, we have anatomy. Oh yeah. So before we go on, LA mass, myxoma, amorphous extracellular matrix, mobile mass, and then you have thrombus, which creates the atrial fibrillation or flutter. Uh, the difference between the two is that this one is adherent to the cardiac endothelium. Remember this? Just recently on the group, someone put up a picture on from Twitter. Not a picture, but a video. So I think I have that open here. So this is a myxoma, the one that looks like Casper the Friendly Ghost. Right. So that's hypnotizing. But so that thing right there, the vegetation or like whatever, the growth here is called the myxoma, right? So the definition of it is that it's amorphous extracellular matrix, okay? And it's a mobile mass; it moves. Whereas the adherent one would be, say, this is a valve, and then this is a mitral valve with the atrium like that, right? So myxoma would be attached to one of the valves over here, right? The one that moves. But the thrombus would be like somewhere here, inside this layer over here, attached to that, or but it's not gonna move with this. But what's it gonna do? So say when this opens up, the blood goes here, right? Normally, if this wasn't here, but now that this is here, when this opens up, this is gonna create a different type of suction. So now there's a turbulent flow. Right now, that it's gonna go like this, and then this, and then it's gonna go through because of this. So that's what it creates, which is not good, because that will lower your diastolic as well and mess up your whole rhythm, to the point where it creates arterial fibrillation or flutter. Okay. Also, you have pulmonary veins coming in here, and near that you have the AV valve or so. No, not AV valve. Sorry. You have something there. We'll do that then. Anyways. Okay, so anatomy. Heart anatomy. You have left atrium is the most superior part of the heart. So that's left atrium. Uh, Normally, this is how you're going to see it. Okay, and this is how you're going to see a photo on a chest scan. So left atrium will be the one closest to the aorta. Okay, it goes pulmonary vein, then this thing, and then aorta, and on the middle you have left atrium. Left atrium, again, just imagine yourself, the one outside, touching the outside wall is the right ventricle, and the side wall is going to be the left ventricle, and the one like right behind your throat is going to be the left atrium, and the one on your back is going to be the right atrium, right? So left atrium is the most posterior part of the heart. Enlargement of the LA or left atrium, for example, in mitral stenosis, can lead to compression of the esophagus or dysphagia, and or the left recurrent laryngeal nerve, a branch of the vagus nerve causing hoarseness, Ortner syndrome. Sorry. So this is your esophagus, right? This thing. So what it's saying is, say this thing, there's a enlargement of left atrium. So instead of this, it becomes as big as this, right? So what's it gonna now do? It's gonna push onto this esophagus, right? So what does esophagus do? It travels. It's your food passage, right? So if something's pushing against it, you're gonna have a hard time swallowing. So that's why it causes dysphagia. And there's also, remember, there was a left recurrent laryngeal right there, because this is aorta, and then it goes from here, from the right side to the left side, like that, right? The aortic arch, or I got that, like that. The aortic aortic arch right there, and the aortic arch has left recurrent laryngeal nerve, so that's gonna to the other color. Right, so aortic arch, so that's also gonna get affected right there, I guess, because that's where the recurrent laryngeal nerve is. It's around the sixth one, or the PDA. Okay, so right ventricle is the most anterior part of the heart. Okay, again, that's the one that touches your chest wall or thoracic wall. Uh, right ventricle is the most anterior part of the heart and most commonly injured in trauma. They will test you on this, so remember, this is the most posterior part. Okay. Then you have right ventricle is the most anterior part of the heart and the most commonly injured in trauma. So if someone gets punched in the chest, this is the one that gets damaged first because it's the closest one to the wall. Left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. Okay, so left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior. Right, so on the bottom, so this is the bottom right here, and this is your diaphragm from here to here. Right, so that's your diaphragm. So the surface of the heart that's touching this diaphragm, and that's what it's talking about. So left ventricle touches about like 2/3 of it touches the diaphragm, and for right ventricle only 1/3 of it touches the diaphragm and the cardiac surface. Okay, we'll continue this. I believe we were here. Pericardium. It consists of 3 layers from outer to inner. So it has fibrous pericardium on the outside, then the parietal pericardium, and then on the inside you have epicardium, visceral pericardium. Right. So that's the fibrous on the outside, the parietal and the pericardial over here, and then this is the epicardial or visceral pericardium. You have the coronary vessels on the inside, right between the myocardium and endocardium, and between the myocardium and the epicardium, right? So the pericardium has 2 layers basically, right? With a space, so it has fibrous and the parietal pericardium, right? These 2 layers. On this side, you call that pericardium as well, visceral though, or you can call it epicardium. So between the epicardium and myocardium, you have the coronary vessels, and all the way on the inside of the part is endocardium. This is the one that would touch the chambers. Okay, so pericardial space lies between the parietal pericardium and epicardium, right? This and this. And pericardium innervated by phrenic nerve. This is important. Why? This is the reason why if you do have a heart attack or something, people feel pain in the arm, because phrenic nerve goes from the diaphragm to the shoulders, if you remember the dermatomes. Then you have pericarditis. It can cause referred pain to the neck, arm, and or one or both the shoulders. Often it's the left side. Okay. Coronary blood supply. So out of these, you need to know these 3 at least, and then all the other ones are just there. Okay, so coronary supply. Okay. Left anterior descending, so that would be this one right here. Okay, so when you think of this, think of it like on your own self, looking down at the heart, and then it will be easier to think about it. So this would be on the anterior side, right? If you hold your arm out in an anatomical position for the heart, and then just follow it with the finger. So this is the anterior, left anterior descending artery. Okay, and then right. So LAD and its branches supply anterior 2/3 of the interventricular septum. This is important. 2/3 on the top. Basically, on the inferior side, it's going to be this inferior or posterior side, right? So that's what that is. So anterior 2/3. So see, this is the septum. So it's going to be uh, if this is the septum, it's going to be this area. So 2/3 of that area. So I guess that much is supplied by LED, right? Anterolateral papillary muscle is supplied by that too. Uh, those are the ones that support the valves, right? So it's the one that looks like this around the valves. So these are like your papillary muscles around the valves. Anterolateral papillary muscles and anterior surface of the left ventricle. So that's easy. Most commonly occluded, right? So when they have ischemia or something, it's going to be this artery. That's the most common artery that gets occluded. Then you have PDA, which is posterior descending posterior 1/3 of the interventricular septum. So if you're still in your anatomical position with your hand, you just pull it out a little forward and then you can see the back of the heart. So the back of the heart is going to look like this. Now your thumb's going to be on that side, and then you have your arm coming in with the pinky here and your middle finger here and like that, and like your thumbs like that. Okay, very demented hand. But yeah, so on the pinky side you have the PDA, posterior descending artery, right? So it supplies the posterior 1/3. So that's this 1/3. Okay, so now the interventricular septum is like this on this side, right? So now it's going to be the bottom part. It's going to be this bottom part right here. Sorry about that. Or that bottom part that's not covered. Okay, so it supplies the posterior 1/3 of the interventricular septum, posterior 2/3 of the 2/3 wall of ventricles, right? Okay, so the ventricle itself, its walls, it's going to supply, and posteromedial papillary muscle. So this one also supplies the valve muscles. Okay, the posteromedial one. So this is the posterior medial, and this is the anterolateral. So it's important to know this difference because they might give you like I don't think they'll give you an ECG, but if you have to figure it out from an ECG or something, or they'll just tell you that there's an occlusion in the anterolateral part, so which artery is it and what other structures can get affected, then you need to know that's like PDA, and the structures that get affected are the posteromedial papillary muscles, 1/3 of the interventricular septum, and the posterior walls of ventricle, around 2/3 of it. Yeah, right, so like that. Right coronary artery supplies the AV node and SA node. That's important. Okay. Infract may cause nodal dysfunction. So if there is a thrombus in there or an infarct or something around this area, that will cause decrease in supply to AV and SA node, and that will cause nodal dysfunction. So then if that happens, you get bradycardia or heart block, right? The right acute marginal artery supplies the right ventricle. Okay, that's this one, anterior marginal artery. Okay. Yeah, so that comes from the RCA, which is the right coronary artery. Okay, so don't confuse your cornea with carotids and cerebral arteries. Okay, so RCA is for right coronary artery in the heart. Okay, so EMA. Again, this is on the, if you still have your hand out as an anatomical position and put it like that, it's on the side of your thumb. So where your thumb is, that's where that would be. Because your thumb would be right here. So, okay. Bradycardia, that about covers that. Now, sometimes this artery right here, it can get supplied by this one instead of this one. Okay, so we'll read about that. So dominance, right dominant circulation, most common. So most people will have this kind of circulation. So PDA arises from RCA. Sorry, I meant this instead of this can get from that. Okay, so PDA. So that again, this is posterior descending artery. Okay, it's on the back side. This would be like right above your pinky here. So right there. Then you have, yeah, so this one is coming from orange, and the orange one's right here. So if you look at it that way, this orange will go keep on going, and then you turn it around. If you flip this, it's gonna be like this, and then the orange comes in with the PDA, right? There's also left dominant circulation, right? So they might tell you that they checked the patency of RCA and it was clear, but then there is PDA that got occluded. So how is that possible? It's possible because the PDA here is getting supplied by the left dominant circulation or the left circumflex artery. So LCX is the circumflex artery. So that's this one right here. So LCX is this thing right here, the green, and that comes from. If you flip this over, it's right here. So LCX is coming from the left coronary artery, right? So the pink one. So the pink one's coming from here, from the, I guess, origin of the aorta to travels at the border of left atrium, and then it goes behind the left atrium, and then that's where the left circumflex artery can turn into posterior descending artery in some people. And then you have obtuse marginal artery. So that's this thing right here. That's just another name you have to remember, but they won't ask you about that. What you have to remember is left circumflex artery. Okay, so if a thrombus was to come over here, how is it going to travel? It's going to travel from coronary sinus to or whatever gets supplies this. Left carotid artery to left circumflex to posterior descending, or it can come from right coronary artery and go straight into PDA, posterior descending artery. Right? And then there's some people who have both of the circulations. So they have PDA arises from both left circumflex artery and the right coronary artery. Okay. Coronary blood flow. Okay, so if you weren't aware of what I meant by anatomical position. No one's holding it up. Yeah, that's the anatomical position of the heart right there, right? So that's how you would hold it. So just pretend like you're holding it like that, and then the thumb part would be the interior and the pinky would be the posterior. Okay, then you have coronary blood supply from the left ventricle, so that's where it comes from. Left ventricle and interventricular septum peaks in early diastole. Okay, sorry, never mind. So coronary blood flow to left ventricle and interventricular septum peaks in early diastole, and coronary sinus runs in the left AV groove and drains into the right atrium. Okay, both of these things are important. So what it means is, let's see, when the say the heart starts pumping, right? So when it pumps, what happens is it's using up all its energy, and all the energy it uses up, the muscles are going to require what? It's going to require blood that's oxygenated, right? So all the blood gets, and there's increase in resistance because it's contracting as well, right? So that's why when it relaxes and or it's in diastole, in ventricles, that's when the resistance decreases and the blood flows to uh, through the coronary vessels, right? So coronary blood flow to left ventricle and interventricular septum peaks in early diastole. This is also the time when it's gonna be the most oxygenated you're gonna find in coronary blood flow, because when it goes into systole, all the blood becomes deoxygenated right away, and that's why coronary sinus contains most deoxygenated blood in the body. Okay, because it gets used up by the heart right away. So there is a question, and that's me telling you the answer for it. So they're gonna have, okay, so which part of the body contains the most deoxygenated blood during systole? During diastole or systole, one or the other, and then they're gonna give you option like the brain, the kidney, medulla, uh, splenic flexure, stuff like that, to make you think it's a watershed question, but it's not. It's a heart that uses the maximum amount of oxygenated blood. Okay, and then you have coronary sinus run in the left AV groove. You need to know this location because they will ask you this, and they'll be like, okay, so where does coronary sinus drain? Right, it drains into right atrium. Okay, so right there, it would drain. Okay, so let's get rid of all of this. Okay. So remember, right atrium has the right coronary artery, left atrium has the left coronary artery. Right atrium goes into the back and then turns into posterior, posterior descending artery. Left coronary artery goes around the left atrium as left circumflex artery, and then it could turn into the posterior descending artery. But RNR is the most common one. Sorry, PDA, RP. So RCA and PDA is the most common one. It could be that it's both of this, or it could be just the left. Okay. The bottom of, okay, so what it supplies is left anterior descending artery supplies the anterior 2/3 of the interventricular septum, the anterior side of the left ventricle, and the anterolateral part of the papillary muscle. Okay. The posterior descending artery does the posterior side of the interventricular septum, 1/3 of it, the posterior wall of the ventricles, 2/3 of it, and posterior medial papillary muscles. Right, and then you have right coronary artery, the most important one, which supplies the AV and SA node. Infract may cause nodal dysfunction, bradycardia, heart block, and then you have right acute marginal artery supplying the right ventricle. Okay. Now we're on to physiology. Cardiac output variables. Stroke volume. Stroke volume is affected by the contractility, afterload, and preload, right? So increase in stroke volume is caused by increase in contractility, for example, anxiety or exercise. Increase in preload is, for example, is in early pregnancy, right? Because remember, blood volume increases. And then decrease in afterload also causes increase in stroke volume. Okay, so this is basically how much is left over after systole, right, or that. Then you have that's how you remember it, stroke volume affected by contractility after load and preload. Okay. Failing heart has decreased stroke volume. So systolic and or diastolic dysfunction, right? Because a failing heart would have what? Decrease in contractility. So that would decrease in this. So if we were to put it into a formula, that would be SV equals contractility and preload over afterload, right? So, because I guess it would be times here. So, if contractility goes up, stroke volume goes up. If preload goes up, stroke volume goes up, because there's more to go give in cardiac output, right? Even contractility will help with the cardiac output. What won't help is like if this goes up, this goes down, right? So afterload goes up when there is oh, it's raining outside here. Cool. When there's leftover fluid after the systole, right? So if there's leftover fluid, that means that much fluid didn't add to the cardiac output, so stroke volume is lowered, right? So you can think of it that way. Okay. Contractility. So there are certain things that can increase and decrease it. So which ones increases it is contractility and stroke volume increases with catecholamine stimulation of beta 1 receptor. Remember, beta 1 is the heart one, and it increases heart rate, contractility, increases renin production as well, right? So activated protein kinase A. Okay. So phosphorylation, active calcium ATPase increases in calcium storage in sarcoplasmic reticulum. Remember that from biochem, I think. But similar concept here too. Yeah, I'm not gonna be able to find it right now, but I hope you remember that one. Okay. And then you have activated protein kinase A, which increases calcium. Remember the GS protein and all that? That's what I was talking about. That's what that is. Increase in calcium storage in the sarcoplasmic reticulum. So activated protein kinase A, calcium channel phosphorylation, increase in calcium entry, increase in calcium-induced calcium release. Okay. Again, calcium is the most important ion for heart because this is the one that causes contractility, right? And heart has its own supply of calcium intracellularly, unlike the other ones where calcium needs to come from outside. But in heart, they have a vesicle that contains calcium and it has receptors on it. So those receptor gets depolarized by sodium. So to say increase the amount of calcium intracellularly, we give digoxin, right? So what does digoxin do? Digoxin blocks that channel, the sodium potassium pump. Potassium always goes out and sodium comes in, right? So when you block it, what happens? Sodium stays inside the cell. I hope you're following this. So see, this is the cell, and then you have one that contains calcium, right? So this contains calcium, right? And these vesicles have calcium receptors here, and then you have Na coming in through the sodium potassium channel, and sodium potassium. So potassium's gonna go out, and sodium's gonna and I'll just write Na comes in, okay, and then potassium goes out. So when you give digoxin, it blocks this pump, right? It blocks that pump. So what happens? The sodium you have inside is not going to be able to go out, okay? It blocks the active channels, so it can leave through like passive ones, but there's so much that's going to be negligible difference. So as long as there's sodium inside, it's going to keep attaching to this and keep the calcium coming out for longer times, and that causes increase in contractility. That's why we give digoxin. Okay, that's why calcium is really important for heart. Uh, and this vesicles that I said, it's sarcoplasmic reticulum. Okay, so that's what that is. So we give catecholamines to increase storage of this, so this becomes bigger, so you can fit more calcium in it. And I got a message. Oh, thanks. Yeah. Okay. So someone sent my own notes to me, and I appreciate that. Let me send it here. So this thing, the GS protein, GI protein, so this is where the sarcoplasmic reticulums are, right? So through the whole this thing, and the depolarization actually happens because of sodium. So you just end up with this. So with this thing, uh, calcium from the sarcoplasmic reticulum then gets activated. This is it activates protein kinase C, but here we're talking about protein kinase A. That's this one, right? So this is the one that's going to act on it. Again, they both do the same thing. Remember, this also activates calcium. Remember from biochem, I think, or I don't know. I remember right now, but yeah. So this thing will go on to. This thing goes on to activate calcium release from intracellular sarcoplasmic reticulum as well. Okay, this one inhibits this. Okay, the GI one, but this one activates it. Okay, so activated protein kinase A, calcium channel phosphorylation happens, calcium enters, and you have increase in calcium induced calcium release. So you have intracellular calcium increase and decrease in extracellular sodium, right? That's this whole thing I just said. So when you have decreased extracellular sodium, that means there's more intracellular. So there's decrease in activity of sodium calcium exchanger as well. Okay. Digoxin, so it blocks the sodium potassium. Okay, they gave it here. Digoxin, it blocks the sodium potassium pump. So you have increased intracellular sodium. So decrease in sodium calcium exchanger activity, right? So okay, so when I said that, they also exchange for uh, calcium. So calcium will come in through this, and sodium. Sorry, no, I said the opposite. So sodium comes in and calcium goes out. Okay, that also happens. So there's calcium coming from outside as well as inside, I guess. Okay, so oh, no. Okay, I got it. It's not this, it's this one. It's talking about this one. So increase in intracellular sodium, so there's decrease in sodium calcium exchange activity. So okay, so when they block digoxin blocks this as well. It blocks this and it blocks this, I guess. No. Okay, forget everything I said after I made sense and I stopped making sense, so don't listen to me when I stop making sense, okay? I'm confusing myself now. So increase in intracellular sodium will cause decrease in sodium calcium exchange activity, which increases this. This is the main thing you gotta remember. There's increase in intracellular calcium, and intracellular calcium causes contraction. We'll do that in musculo, but there's like myosin and all that stuff, right? Troponin C and all that stuff that does the contractile. It's similar to that. Okay. Then you have contractility and stroke volume decrease with. So these are the ones that decrease the stroke volume. Okay. So you have beta 1 blockade. So if beta 1 is responsible for increasing heart rate, increasing contractility, increase in renin, and there was a third thing I don't remember. Uh, but so if you block that, what's going to happen? Heart rate will go down, uh, contractility will go down. So if that goes down, stroke volume goes down. Heart failure with systolic dysfunction, acidosis, hypoxia, hypercapnia, a decrease in PO2, increase in PCO2. Okay, so hypoxia, hypercapnia. Then you have non-hydropyridine calcium channel blockers. Okay, we'll learn about this in the pharmac section of CVS. Okay, so when you have decrease in oxygen, okay, this is an important concept too, because remember up here we just talked about coronary vessels. They require oxygen to function and to have left ventricle contract. So if you don't have oxygen, there won't be ATP. If there's no ATP, there won't be any contraction happening, because in that whole complex of troponin, myosin, and all that, you need ATP for contraction to happen, right? And you need oxygen for that as well, because oxygen goes into the electron transport chain into the mitochondria, and mitochondria makes ATP. Okay. So when that's decreased, you won't have contraction, so that will decrease contractility, thus decreasing stroke volume. Okay. Acidosis, just remember that. They won't test you on CVS for acidosis, they'll test you on renal and respi, mostly for that. Okay, so heart failure with systolic dysfunction. Again, heart failure is what? It could be compensated or decompensated, right? If there's systolic dysfunction, that means it's decompensated, and that will cause decrease in contractility. In compensated, their contractility ejection fraction is preserved, and decompensated, it's, it can't compensate for the loss of that. Okay. Preload approximated by ventricular and diastolic volume, depends on venous tone and circulating blood. Okay, so end of diastole, right? So what is diastole? Again, this is your left atrium, this is your left ventricle. Okay, so is the amount of blood when this relaxes, right? So when this relaxes, the aortic valve closes and the mitral valve right here will open, and when that opens, the blood from left atrium will go into left ventricle, and this process is known as the diastole. So the amount of blood that comes in here is known as preload. Okay, so everyone has preload and it's normal. The only time it's not normal is right here. So preload, approximately that, it depends on the venous tone. So if the venous tone is low or the circulating blood is low, right? So the blood that's coming in, the venous return is low, then this blood going in here will be lower. It could be that there's also in aging, I think. I'm not sure. We'll do the changes in age. I forgot. That will lower up the cavity as well. Hypertrophic cardiomyopathy might also lower it. We'll see. I'm not sure. Don't quote me on that just yet. But just understand what preload is, right? So it's the blood coming in. If the blood coming in is lowered, preload will be lower. If the blood coming in is higher, like in pregnancy, blood volume increases, so preload will be increased in that. Okay. So it depends on venous tone and circulating blood volume. Vasodilators, right? So vasodilators are going to do what? They're going to dilate the systemic vessels, right? So when that dilates, the blood starts pooling in at least the veins, right? Because they don't have the valves. So when they start pulling there, what's going to happen to the venous return into the inferior vena cava, right? Just imagine this RA now. Right atrium, this whole thing. So this is going to decrease, right? Because now it's pooling in the veins. So if the blood coming in is decreased, it's gonna do what? Decrease your preload, right? So nitroglycerin, this is important. We give this in heart failure as well, because in compensated heart failure, you'll have basically hypertension or increase in blood volume. That and since your heart is already working overtime, you don't want to increase the workload. So for that, we decrease the workload by giving them nitroglycerin. Okay, heart load, afterload. Sorry. What is afterload? So afterload approximated by mean arterial pressure. So what happened? Let me start again. Okay, just ignore that part. Okay, so mean arterial pressure, just so you know the formula. I don't know, have they given it? I don't want to end up doing a formula and then they give it. Okay, so that's what it is right there. It's 2. Okay, I don't like how they wrote it, so I'll write it out. So MAP, M-A-P equals systolic volume plus 2 was it 2? Yeah, 2 diastolic volume. Let me just confirm I'm not giving you a wrong one. Yeah, and it's all divided by 3. All divided by 3 because there are 3 values, right? So this is what they wrote. So they wrote 1 over 3 for systolic and 2 over 3 for diastolic, I think. 2 over 3 for diastolic plus 1 over 3 for systolic, right? So I write it like this because it's easier to comprehend for me. So systolic plus 2 diastolic divided by 3 gives you mean arterial pressure. Know this formula because it could come in handy if they're asking a question for this. So afterload, again, afterload approximated by MAP, okay, so mean arterial pressure. Increase in wall tension per Laplace's law, increase in pressure, and increase in afterload. So LV compensates for increase in afterload by thickening hypertrophy in order to decrease wall stress. Okay. So left ventricle compensates for increase in afterload by thickening or hypertrophy in order to decrease wall stress. Okay. So when I say what's left over, that's not ideally what you should be thinking of. So what is wall stress? So say this is your left ventricle, okay? And it's like that, okay? And then when blood comes in and it's all end of diastolic, right? After end of diastolic, what happens? The coronary artery is going to supply the oxygen to the muscles of this left ventricle. It's going to use up, and then it's going to contract. So when the contraction happens, so think of it like a link, like this, like that, right, and then like that, similarly. So the muscle fibers will link up to each other, and when that contraction happens, all this will get pulled in together, right? So when that gets pulled in, this goes inwards, right? This goes inwards, so that all the blood can go through the aorta over here, and through the aorta, right? So that's contraction. So the amount of wall stress it takes in, or the muscle fibers they're in, the amount of work it can do is what the afterload is based on. So if it can't take in that much stress from the blood, basically, then the afterload will increase. If it's nothing for it, it's like, oh, dude, I can just do this in my sleep kind of thing and just push the blood out the aorta. That means there's not going to be any afterload. Okay. So is the increase in wall tension. So wall tension happens when the muscle fibers, something's wrong with those. Okay, so increase in wall tension, per Laplace law, increases pressure. Okay, and this increase in pressure will increase afterload. Okay, so what can happen to this? It can get fibros due to ischemia or something like that. Like, MI. So LV compensates for increase in afterload by thickening or hypertrophy. Okay, so now that these muscles are not able to, uh, you know, pick up the pressure from the blood inside or pick up the load, what's it going to happen? These things are going to get trophied. And remember, trophy, you like them big, so hypertrophy means bigger cells. It doesn't mean cells get multiplied. That's hyperplasia. Don't confuse that. Okay, so see, this muscle fiber is now going to get hypertrophy like that and like that. Right, the muscle fibers are now from that to this. So and you can imagine you have like hundreds and thousands of these in your heart, and if they all get big like this, what's going to happen to this border? It's going to get bigger, right? Like that. So that's called hypertrophy. In hypertrophy, I guess the cavity stays the same, but it's going to be just this side. This side is going to stay smaller. It doesn't affect the interventricular septum because they don't push the blood. What pushes is these fibers right here, so these are the ones that are going to get big. Okay. This is a important distinction because this is how you're going to distinct it from a hereditary hypertrophic cardiomyopathy to hypertrophy of right and left ventricle. Okay, this is it. And the hereditary one, the interventricular septum and the left ventricle, they both get big. Okay. Hopefully that clears that up. Left ventricle compensates for increase in afterload by thickening or hypertrophy in order to decrease the wall stress, so it can handle this. Arterial vasodilators. Also, if there's increased systemic resistance, that's also gonna increase your afterload. I don't have to give that here, because then this has to work harder, right, to get the blood flowing outside. So to do that, because the vessels are now a little smaller, because of the systemic vascular resistance increase, so that means the heart has to work harder. So that will also create increase of myocardial cells. Okay, so atrial vasodilators, for example, hydralazine, decreases afterload. So what do these do? This is a hypertensive drug, right? So it's gonna decrease the systemic vascular resistance. So if that is decreased, my bad. If that is decreased, what happens? Again, this one doesn't have to work as hard now, so it will decrease the afterload. ACE inhibitors and ARBs decrease both preload and afterload, right? Angiotensin converting enzyme inhibitors, because this also causes vasocontraction, right? Angiotensin receptor blockers. So if you don't have angiotensin 2, right? Angiotensin 2 is a vasoconstrictor, so you're going to block that. So that will also cause decrease in both preload, because there's going to be decrease in venous return, and afterload, because there's going to be decrease in systemic resistance. Chronic hypertension, increase in MAP, will cause LV hypertrophy. Again, this is MAP, systolic plus 2 diastolic divided by 3. So if or you can just think of it like, so in chronic hypertension, what happens? Again, this is a different concept than this, but similar. So in a vessel, right, say this is a vessel, and you constantly have blood flowing through it, right? And the blood is now getting increased. It's pushing harder and harder. And then the vessel now, remember, vessels also have muscles in them. They're called what? Intima, medial, and external, right? So it has three layers. Let me go into that. Okay, so it's called tunica intima, tunica media, and tunica externa. And just like any muscles exercising, uh, if there's a lot of pressure coming to it, it's gonna get hypertrophied, right? So that's what happens to vessels as well. So uh, when these get bigger, what's gonna happen to the vessel? The systemic resistance get bigger as well. At first, it's gonna take all the pressure because it doesn't have the muscles to fight it, but eventually it's gonna grow muscles, and then it's gonna increase the systemic resistance. So when we don't need that now. So when we have this, there is an increase in systemic resistance. Uh, what happens to the afterload? It increases. What happens after there's increase in afterload? Uh, there is increase in wall stress. So increase in wall stress will then the LV will compensate for it by making its cells bigger, so hypertrophy. So that's why you have left ventricular hypertrophy because of that. Okay. And I keep doing that. Make it smaller and black. Cardiac oxygen demand. Myocardial oxygen demand is increased by increase in contractility. That should make sense now. Increase in afterload proportional to the arterial pressure. That should make sense now. Increase in heart rate. Okay, we didn't do it, but we sort of did it. Right. Increase in diameter of the ventricle. So that will also increase wall tension, and this happens in during decompensated heart or dilated cardiomyopathy, right? So when you have dilated cardiomyopathy, that will increase wall tension as well, because now it's trying its best, but it can't, contract to the same diameter it used to. Okay, so all of this will increase oxygen demand. Coronary sinus contains most deoxygenated blood in body. Okay, there you go. So this, I guess I wrote it up there, but this is important here. Coronary sinus contains most oxygenated blood in body. They will, there will be like a question on it, and now you know what the answer is. Wall tension follows Laplace law. So wall tension equals pressure times the radius. The bigger the radius, the bigger the wall tension. That's why increase in diameter of ventricle has increase in oxygen demand. Increase in pressure also increases wall tension. That's why we have increase in afterload causing hypertrophy as well, right? So wall stress is proportional to pressure times radius divided by 2 times the wall thickness. Okay. These formulas not really that important. Just know what the Laplace law is, or even if you don't know, just know the physics that I just taught you, and you'll be good. Cardiac output equations, equation and notes. Okay, so now we're doing stroke volume equations for all of these. So stroke volume is equal to end diastolic volume, that's the ventricle filled up to the brim, minus end systolic volume, that's the empty ventricles to the bottom, right? So how much is it filled minus how much is left over is what your stroke volume is. So yeah, so you can imagine if the leftover is more, then you have a decreased stroke volume, right? Because that's a bigger minus than a minus number, or a number you're subtracting is bigger, right? If you have a higher end diastolic volume but a zero end systolic volume, then you can imagine stroke volume being increased because cardiac output is increased now, kind of like that. Okay, because remember, cardiac output is equal to stroke volume times heart rate. So if stroke volume is increased, cardiac output is increased. These two are attached to each other. Similarly, in 1 minute, say a person has a heart rate of 60 compared to a person who has a heart rate of 80. So the 81 has an increase in cardiac output than the one that has 60, right? So like that. So stroke volume equals EDV minus ESV and systolic volume. Ejection fraction. Ejection fraction is systolic volume divided by diastolic volume. Okay. Which is equal to diastolic volume minus systolic volume divided by again diastolic volume. So ejection fraction is an index of ventricular contractility, decrease in systolic heart failure, usually normal in diastolic heart failure. Okay. So this is important because this is how you're going to differentiate between compensated and decompensated heart failure. Okay. That's the only time this is going to be important anyways. So ejection fraction normally is around like 55 to 65, I think. So anything lower than that would be like decompensated. Okay, so ejection fraction is an index of ventricular contractility. That's what it determines. Okay, so a decrease in systolic heart failure. So systolic heart failure, what is that? It's when left ventricle can't push, right? It can't push the blood out. That's the systolic heart failure. So if that can happen, then stroke volume is going to be lower, right? If a stroke volume is lower, then cardiac output is lower. Cardiac output is lower. That's a heart failure. Right? Why is it normal in diastolic heart failure? That's a filling problem, right? It's not a whatever is filled in. The left ventricle can still push it out. Whatever is filled in. So ejection fraction is preserved there. That's what it means when I say EF is preserved. I'll just say EF because for some reason I feel like this is a tongue twister for myself. So EF is preserved in diastolic because left ventricle is still functioning, right? To like, it can push out blood. It's just the diastolic heart failure. So the blood coming in is the problem. Maybe it's not enough blood coming in, or too much blood coming in, or something like that. Because diastolic is depend on two things, right? Where'd it go? Preload. So preload approximated by ventricular and diastolic volume depends on venous tone. Yeah, so venous tone and circulating blood volume. So venous tone is like the veins, right? If you have hypertension, then you're gonna have this problem right here. Okay, now you have cardiac output, which is stroke volume times heart rate. Okay, in early stages of exercise, cardiac output maintained by increasing heart rate and increase in stroke volume, and then in later stages, the cardiac output maintained by increase in heart rate only, because stroke volume has plateaued. Like once every single muscle fibril or cardiac muscle fibril is used up, is activated basically. You can't activate more because there are a limited number of cells. So then the stroke volume is going to plateau, right? But you can still increase heart rate, okay? As they all sync up, there will be increase in heart rate. Okay, sync up. Why? Because of the AV node signals, electrical signals. Okay, so diastole is shortened with increase in heart rate. Okay, because if it's beating so fast, there's not enough time for it to fill up. So again, this is the ventricle, and then this is your atrium, like an ice cream cone. So if this keeps on beating really fast, like boom, 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 what's gonna happen to the feeling? It's gonna be, before it's even like filled up, touches the bottom, it's gonna get pushed out the aorta, right? Again, fill up, pushed out the aorta, fill up a little, push out the aorta. So the filling is decreased now compared to when it was normal. it would fill up for like a whole half a second or whatever, and then get pushed out, right? But at this point, it's beating so fast that it's really low and then gets pushed out. Okay, so diastole is shortened because of that when there's increase in heart rate. For example, ventricular tachycardia. So there will be decrease in diastolic filling time, which decreases stroke volume, right? It affects stroke volume because cardiac output is lower too now. There's less blood going out. Pulse pressure. Pulse pressure is systolic blood pressure minus diastolic blood pressure, right? So it's basically, say you have 135 systolic and you have like 89 or just 90 diastolic. And then you take the systolic, subtract the diastolic from it. So that would be, say this is the baseline. This is diastolic, this is systolic number. So you, at this point, I'm just teaching you math for some reason. Yeah, so when you take that out, this part is what's left over, and that's called the pulse pressure. Why is this important? Because pulse pressure, they'll probably tell you. Pulse pressure is directly proportional to stroke volume and inversely proportional to the arterial compliance. Okay. So what that means is, what's better, if it pulse pressure is higher or lower? Higher is bad, lower is bad as well. They both are bad. It should stay normal, within the normal range, which is what? So 120 minus 80, that's the normal. So increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, increase in sympathetic tone, anemia, exercise transient. That's just transient. So pulse pressure decreases between these two, right? Because increases between the two, because diastolic is going to be decreased, preload will decrease, but heart rate and contractility increases. So systolic blood pressure will be much higher than diastolic. So this will be much lower, and this will be much higher. So this thing. This will be much higher, right? Okay. Increase in pulse pressure. Okay. How much time do we have? 3 minutes. Okay, let's just take a break here. And we'll come back. Okay, let me finish this pulse pressure actually. Okay, so increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, increase in sympathetic tone, anemia, and exercise transient. The decrease in pulse pressure happens in aortic stenosis, right? Cardiogenic shock and cardiac tamponade, and advanced heart failure. So aortic stenosis is when LV can't put out the blood into aorta fast enough because the aortic valve is stenosed, so it's blocking it, it's obstructing it, so it has to increase the pressure to push it out, kind of thing. The systolic blood pressure will be decreased in aortic stenosis, so it's going to be closer to the diastolic blood pressure. Sorry. Cardiogenic shock, that's just your heart muscles not functioning properly. Cardiac tamponade, that's the pericardial space has fluid, so it's pushing in pressure into the epicardium and then myocardium and into the myocardium, right? So that's what that is. It increases the diastolic volume, I guess. Okay, and lowers the systolic volume, blood pressure. Sorry, not volume. And then you have advanced heart failure. We already discussed that. So that takes care of the pulse pressure. Okay, we'll come back after the break. So they will give you a question by telling you that the venous return oxygen content is like, say, 5%, and then arterial oxygen content is like 98% or something, right? So then you have to figure out what this number is, and they'll give you the rate of oxygen consumption, right? They'll give you all these three things, and then they'll ask you what is the cardiac output or something like that. So you have to remember that we have a formula for that. So the formula for that is rate of consumption goes up, and then you figure out how much oxygen is, used up basically from the time it left ventricle and by the time it returned to the right atrium. Okay, and so that number will go down here, and then you can figure out cardiac output with that. Another way is stroke volume and heart rate. Q is the flow, I think. But okay, so Starling curves. Here we have stroke volume. Here we have ventricular end diastolic volume on the x-axis, so that's going this way. So the higher number will be here. So this is the normal preload, and here it's decreased, and here it's increased, right? And then this is the normal stroke volume. The stroke volume here is increased. Here it's decreased, but it's higher than here. That's also decreased, right? So Starling curve. So force of contraction is proportional to the end diastolic length of cardiac muscle fiber, right? So say you have a balloon, right? So you have a balloon and you fill it up. So a balloon that was this small, and then you fill up fluid inside, and then it's gonna grow into this thing, right? It's gonna grow into this. So now you have blood all over in here. Okay, so this thing is gonna push onto this layer, or fluid that's gonna push onto the layer of the balloon. Okay, and now the recoil. Heart has the recoil muscles or the contractile muscles, right? So the more you push outwards, the more it's gonna push inwards, right? The more you push outwards, the more it's gonna push inwards. So that's what they're talking about. The force of contraction is proportional to the end diastolic length of cardiac muscle fibers. So those muscle fibers, if this increases, they will stretch more. So when they do go into contraction, that's how much work is increased, and they'll contract more, right? So more fluid, more contraction. So it's proportional to the preload and the thing. Okay. Increase in contractility with catecholamines, positive ionotropes, that's dobutamine, milrinone, digoxin. Okay. Some way or another, they'll increase calcium. Okay. In the intracellular bleed. Decrease in contractility with loss of functional myocardium, for example, MI, beta blockers acutely, non-dihydropyridine, calcium channel blockers, and heart failure. So again, this thing we know is heart rate, contractility, and renin. Remember, renin's not appropriate here, but it's just so you don't forget that it has action on that as well. So beta blocker will decrease the contractility, we know that. With loss of functional myocardium, right? So for example, MI, right? If these are fibros, this fiber right here, that's not going to function, so you're going to have decrease in contractility. Non-dihydropyridine calcium channel blockers, these are the ones that act on the heart, and they stop the calcium receptors. I forgot where it was. These things right here, so calcium don't come out. Okay, so I think that's what it is, but we'll check it out in farm after. Okay, resistance, pressure, and flow. Now volumetric flow rate, Q. So that's cardiac output is equal to this. Okay. So Q equals to flow velocity times cross-sectional area. Okay, so what that actually means is just, how much, if the cross-sectional area is increased, or like a big one like that, you're gonna have a bigger flow rate. If the cross-sectional is decreased, like this one is gonna have lower flow rate than a vessel that's this big, right? Because there's gonna flow more, so that's what it is. So that's the cross-sectional area and the flow velocity. So even if it's small but high flow, then you're gonna have more flow rate. Whereas if you have a big one but a small, really slow flow rate, then that's gonna decrease it as well. So it depends on both of these things. Resistance, driving pressure, or delta P over Q, and you have whatever this is times length, viscosity times length divided by pi r to the power of 4. Okay. In this formula, you need to remember this thing, that it's resistance divided by r, pi r to the power of 4. So whatever you have, you gotta, I think you have to do it times by itself 4 times, or they'll give you a radius, and then you radius is going to be like 2 mm or something, right? And then you multiply it by itself 4 times, or 2 to the power 4, you would get 16. And usually that's the answer. That's going to be always the answer, because they only pick those 2 numbers when they're asking about resistance. So they'll ask you, there's a artery and it was clamped halfway, so only 50% of it was open or something, right? So when you decrease the thing, resistance increases. So if resistance increases, the radius has decreased, right? So when the radius decreases, they're going to ask you how much of it was decreased or something. So it's going to be 16 times lower, kind of thing. Okay. So if length increases, resistance increases, right? If length decreases, resistance decreases. Viscosity increases, resistance increases. Viscosity decreases, resistance decreases. For this question, if you find a question on UWorld, you can share it on the group and we'll go through it if you don't understand it. Yeah. Okay. But remember, you have to get to 16, so just plug in the formula and you'll reach there. All of this stuff doesn't matter because they don't test you on it. They test you on your knowledge on the radius. If they clamp it down by this much, how much resistance is increased by? So it's increased by 16 if it's half. Okay, so total resistance of vessel in series. Okay, so if it's in series, the length is going to be increased, right? So if you add R1 length to the R2 length to the R3 length, it's going to keep increasing, right? Because again, length and resistance is proportional. But what if the length is divided? So now this length of whatever flow was going through this R1 is now split into 3, right? So now it's 1 over R1, 1 over R2, and 1 over R3. So that means what? It's decreased. Resistance is decreased, right? And this is what happens in capillaries and reticular network of vessels, right? Flow is proportional to the R4. Resistance is proportional to 1 over R4, right? So if you increase the radius or diameter, you increase the flow. If you decrease the diameter or radius, you increase the resistance. Okay. Capillaries have highest total cross-sectional area and lowest flow velocity, right? Because again, capillaries split the vessel up, so the resistance is going to be low. If there's a blockage here, it's just gonna flow into this one and into this one. It's not gonna, if unless there's a blockage here, then it's gonna back up and increase pressure and resistance. So that's how that works. Pressure gradient drives flow from high pressure to low pressure. So if there was here, then this is high pressure, so this blood goes into the low pressure one, kind of like that. Arterioles account for most of the total peripheral resistance. Okay, veins provide most of the blood storage capacity. This is why venous return decreases when you give them vasodilators. Viscosity depends mostly on hematocrit, right? The more hematocrit, the increase in viscosity. Viscosity increases in hyperproteinemic states, for example, multiple myeloma, polycythemia, and then viscosity decreases in anemia. Cardiac and vascular function. So this is the cardiac function curve. You have cardiac output and venous return on this side, in red and blue, and then you have the right atrium pressure. Similar here and similar here. So first graph is about inotropes. So effect is change in contractility, increases in altered stroke volume, altered cardiac output and venous return, and right atrium pressure. So when you have a cardiac function like this and decrease in inotropy, it goes down and cardiac output, and if you increase inotropy, then it contractility basically increases, so cardiac output increases. But the venous return stays the same, and this is your mean systemic pressure. Okay. So for example, for this curve, you give catecholamines, dopamine, milrinone, digoxin, or exercise even, right? They all increase cardiac output. But say you have heart failure with reduced ejection fraction, so decompensated heart failure, narcotic overdose, or sympathetic inhibition inhibitor, negative? I don't know. Okay, so anyways, but it makes sense that the cardiac output will go down, right? So inotropy is decreased. Then you have venous return. Okay, on this one, so changes in circulating volume, altered right atrium pressure, so altered stroke volume as well, because whatever's coming is what's going to get put out. So change in cardiac output. Okay, so the cardiac output is normalized here, but venous return can increase or decrease according to the volume. So if there's increased volume of venous return, then there's increased volume and venous tone. That's this chart. And then if there's decreased volume and venous tone, then it's this chart. Increased volume happens because of fluid infusion, sympathetic activity, atriovenous shunt, and then for decrease you have acute hemorrhage and spinal anesthesia. Okay. Acute hemorrhage and spinal anesthesia. Okay. Then you have, because that'll cause vasodilation as well. Okay. Total peripheral resistance. So change in total peripheral resistance, altered cardiac output, change in right atrial pressure. It's unpredictable. Okay. So vasopressors, so vasoconstrictors basically. So 5, if you vasoconstrict, what's going to happen to the cardiac output? There's more systemic resistance in the aorta, so the left ventricle has to push harder, right? So cardiac output is going to be lower because of that resistance. Remember, the left ventricle hasn't acted yet. This chart is showing before there is compensation for that. So increase in vascular resistance would give you this chart. And then 6 is exercise or atriovenous shunt. So exercise increases your cardiac output rate. And then what happens to venous return? To That's unpredictable, right? That's what they're saying. So if total peripheral resistance is decreased, you'll have venous return, but then the preload is also going to be lower. So if preload is lower, cardiac output will be lower, then you would have, you know, decreased venous return. So there's that too. And atriovenous shunt. So that's AV shunt is basically, rather than going through the capillaries, the blood from atria goes straight into the veins uh, without going through the capillaries. That's what AV shunts are. Okay, changes often occur in tandem and may be reinforcing. For example, exercise increase ionotropy and decrease TPR to maximize cardiac output or compensatory. For example, heart failure, decrease in ionotropy will lead to fluid retention to increase preload to maintain cardiac output. That's how it tries to compensate for it. Okay, again, maybe report. So exercise in ionotropy and decrease in TPR to maximize cardiac output. That makes sense. Heart failure and decrease in ionotropy will lead to fluid retention. To right, okay. That's basically so in heart failure, this thing is not working. So decrease in ionotropy, the contractility is not that good. So how is it gonna compensate for this when all the whole body needs, you know, blood? So it retains the fluid to increase preload to maintain the cardiac output, right? Because since it can't go out, what it's going to do is it's going to keep this level filled up. So whatever then comes in gets pushed out, and then this much blood will stay in the cavity. But at least that much blood is going to go around and come back, you know, and come back. And then again, same thing happens. So that's how it takes care of that. So at least some blood is flowing rather than none. Pressure volume loops and cardiac cycles. Okay, so let's first go over this. Here you have the mitral valve close. Okay, so let me just draw you guys up. So that's the right ventricle. Thanks. Pretty. Right ventricle. Then left ventricle, then left atrium. This is going to be your aorta. Let's not involve that. Okay. So that's left atrium, right atrium, right ventricle, left ventricle. Okay. So the mitral valve is over here. Tricuspid valve is here. This is going to be your pulmonary artery, and this is going to be your aorta. So this will be your mitral valve and your tricuspid valve. Okay. Okay. So mitral valve closes. Once diastole happens, this thing closes. So this is end of diastole. Okay. So that's right here. So end of diastole. Mitral valve closes. Then what happens to the pressure inside the left ventricle? It increases. Okay, it increases. The aortic valve hasn't opened up yet, so this keeps on pushing inwards, right? And this keeps on pushing inwards, so until, you know, the pressure is built up to the max. So when that happens, it goes all the way up to here, and that's called isovolumetric contraction, right? Once it goes up here, there's enough pressure to open up the aortic valve. So once this opens up, the pressure here starts declining, right? So that's the decline in the pressure and the volume, basically. So we're following the volume here. Okay, so the volume stays the same, but the pressure increases right here. And here, the pressure first increases in the left ventricle, right up to here, and then it's pushing. And since it's pushing through a little tube, the pressure still increases up till here, and then up till here, right? And then it starts declining after each of this, because then you gotta remember this thing comes inwards, right? So then you have this much left ventricle left, and then this much blood going through the aortic valve through that. So until here you have the pressure increased, but the volume is decreasing, right? So that's why it's going in a loop this way. First you had volume up to here, then isometric contraction happened, and then the aortic enough pressure was there to open up the aortic valve, and when it's opened up, the blood rushes through, and there's a low increase in the pressure as well, but decrease in the left ventricle volume. So it goes this way, and then from here it declines. Okay, so when it reaches this area, there's not enough blood to keep the aortic valve open or the flow, right? So then it closes here. Okay, as this closes, what happens is there's, isovolumetric, because the volume stays the same. That's this right here, right? So this stays almost the same. So that's called isovolumetric relaxation. Okay, so that goes down, and then this is gonna, then you have the mitral valve open up, right? Now there's enough volume, enough pressure in here to be pushed down by the left atrium, because left atrium doesn't have that much pressure. This one has a higher pressure. So when this relaxes, this gets pushed down because there's a lot of pressure in left atrium at this point. So that's going to push down the blood. So mitral valve opens, and when it pushes down the blood, the volume of left ventricle increases, right? So that's what this chart is. Okay. So the black loop represents, I should get rid of all of this now. Hopefully that makes sense. The black loop represents normal cardiac physiology phases. Left ventricle 1, isovolumetric contraction period between mitral valve closing and aortic valve opening. This is the period of highest O2 consumption, right? Coronary arteries are supplying the oxygenated blood, right? So by the time it reaches the blood from coronary arteries reaches the coronary sinus, it's gonna be fully deoxygenated, right? Okay, so aortic valve, and also it drains into right atrium. So aortic valve opening, period of highest O2 consumption 2. So that was this, and now we're talking about this one. So systolic ejection, period between aortic valve opening and closing. So this opening and closing, so that's number 2. Isovolumetric relaxation, period between aortic valve closing and mitral valve opening. So that much right there. The pressure needs to be almost like, at 20, I guess, to have the mitral valve open. Then you have the rapid filling, so that's this part right here. Period just after mitral valve opening. So the rapid filling is up till like here, and then you have the reduced filling. Now it's gonna, like, after it's filled up, the left atrium is going to contract as much as it can to fill up the last little bit. So that's reduced filling. So period just before mitral valve closing. Okay. So now let's talk about the chart itself. So the changes in the chart, it can be this side. This part right here is the end of diastolic volume. So if the end of diastolic volume period is extended, that happens in increase in preload and causes increase in stroke volume. Okay, that causes stroke volume increase, but this happens because of increased preload, or it causes, that's why you get that. Okay. The distance between the two lines right here is known as the stroke volume. And that's why the stroke volume also increases, because this distance increases from here to the green line over here. Okay, so you gotta remember that's preload. This right here, even though it's not written, this is the compliance, and that's how it is. So if it was like this, sorry, and it's between this and this one is increased, right? So this increase in compliance, and if it's down here, then it's decreased in compliance, right, from the original one. This happens in dilated cardiomyopathy. The compliance increases in that. Okay. Then we have, let's see, afterload. So the top part would be the afterload. Right. So if you have extension of the top part, that's this part, that means the afterload is increased. Okay. So that's this part right here. That's the afterload. So if you see it go like the blue line, that means there is increase in afterload. So there will be increase in aortic pressure, right? Because that's basically the systemic pressure, and the systolic volume, stroke volume, is going to be decreased since there is total increase in total peripheral resistance. For example, your stroke volume decreases in that, and then you have increase in end systolic volume. At the end of systole, there will be fluid left, so there is increase in end systolic volume. When you have this increase, that's what that means. Decrease in stroke volume, increase in end systolic volume, and increase in aortic pressure. This line right here is known as the contractility, right? The brown thing right here. So the curvature is here instead of here, so that means the contractility has increased, similar to how compliance was from here to here kind of thing. Right, so the compliance increased here, so here the contractility increased. Okay. So when what this means is that there's also increase in stroke volume, this thing right here, right? Because the distance from this line to this line has increased, so stroke volume has increased, so you get increase in stroke volume. The ejection fraction is increased because again stroke volume is increased, contractility increased, then you have increase in ejection fraction as well. And you won't have any fluid left after at the end of the systole, right? So there's decrease in end systolic volume as well. Okay, now that that's done, we can move on to the heart sounds. So you have ideally you have two heart sounds, right? In kids and athletes, you might have three. Okay, so the first heart sound is lub, and then comes the dub. So the lub is the closing of AV valves. So those are your tricuspid and mitral valves. So mitral valve, when it closes, here we can see that it's S1. After S1, you have aortic valve open, that doesn't have a sound. What does have a sound is when your semilunar valves close. So those are your pulmonary aortic. So here the closing of this will create S2, or also known as dub. So you get lub at S1, which is at the end of diastole, and then you have dub over here at the end of systole. Okay. Then you have two more sounds, S3 and S4. S3 is the one for high volume, and then S4 is for hypertrophic, right? So when you have a stiff wall and you splash water against it, it's gonna make sound compared to you splashing water against a bed of sheet that's hanging, right? So I think that's the best analogy I can come up with for that. And then S3 is just the the sound of high volume. So we'll learn about that over here. Okay, we're done with that. Heart sounds. S1 is mitral and tricuspid valve closure. Loudest at mitral area, because that's the closest, right, to the lateral wall. You should know this by now from your internship, at least, if not your clinical rotations. Clinical theory stuff. So S1, mitral and tricuspid valve closure, loudest at mitral valve area. Sorry. S2 is aortic and pulmonary. It's important to know where this is because a shift in the area also represents what? Hypertrophy of left ventricle, and that way you can deduce what's happening. S2 aortic and pulmonary valve closure, loudest at left upper sternal border. Sorry. Okay. If you remember, if this is a person with the arms like that, and that's his torso, that's arm, and then this is the sternum, right? Then you do A, B, 2, and then you have men right here. So it's that's how I remember it. Ape to men. Right? So ape is aortic. So aortic would be over here on the right side. That's what they're saying. And pulmonary is on the left side, and T is over here on the border of the sternum, and then you have mitral at like 6th intercostal space, or 5, between 5 and 6. Sorry, so 5th intercostal space. Okay. So aortic pulmonary valve closure, loudest at left upper sternal border. So it's loudest over here for dub, and for lub it's loudest over here. S3 in early diastole, during rapid ventricular filling, best heard at apex with person laying on his side, associated with increase in filling pressure. For example, mitral regurgitation, aortic regurgitation, heart failure, hydrotoxicosis, and more common in dilated ventricles, but can be normal in children, young adults, athletes, and pregnancy. Okay, so when I told you that you can hear 3 sounds in children and athletes, this is what I meant. It's normal in children, young adults, athletes, and pregnancy. So if they tell you that you hear a third heart sound in a pregnant woman, what does that mean? They'll give you all these disorders, and then last one will be like, it's a normal finding, right? And then you're gonna do your deduction for all the 3 or 4 of them, and you're gonna second guess yourself and pick a wrong one. Don't do that. It's normal in pregnancy, athletes, young adults, and children. Turbulence caused by blood from LE mixing with the end systolic volume. That's this thing right here. So that's how you get the S3. It's usually because of high volume and high resistance, right? Then you have S4 in late diastole, atrial kick, turbulence caused by blood entering stiffened left ventricle. Best heard at apex with patient in left lateral decubitus position, high atrial pressure associated with ventricular non-compliance, for example, hypertrophy, right? So I already explained the S4 bit. Okay, can be normal in older adults, considered abnormal if palpable. Okay. Why? Because in older adults, you get increase in the left ventricular wall as well, and the interventricular septum as well. But the same finding can, if found in like a young person, it's hypertrophic cardiomyopathy, HOCM or something like that. Okay, so, and then you have this jugular venous pulse. So we'll do that after this diagram. So this diagram, know this diagram, at least this bit right here, that's what's going to be tested on. They will, so this thing is the most important thing, and it's what they ask, okay? We'll do the ECG bit later. So it starts off with mitral valve closes. Okay, so that's your lung. So when the mitral valve closes, you have isovolumetric contraction, right? It contracts until so that's your isovolumetric contraction right here, right? And then you have aortic valve open. When the aortic valve opens, you have rapid ejection, right? So the pressure increases during that time, and then you have decrease in pressure after that. And then when there's not enough pressure, again, it took this much pressure to open it, but it's taking, you gotta have at least a pressure higher than here to keep the valve open. Similarly here, uh, you need this much pressure to open it, which is a lower amount of pressure to open it, but you need at least this much pressure to keep it open. Anything lower than that will close the aortic valve. So uh, remember this difference of pressure here, and you're seeing it over here as well. Okay, because when we do it here, it might make more sense. Okay, so rapid ejection here. Okay, and then when the aortic valve closes, then what happens? There's relaxation of the ventricle, right? So that's called the isovolumetric relaxation, because the volume stays the same, it's just the pressure decreases. Okay, up till here, when the mitral valve opens. So when it opens, there's a little bit of fluid or blood coming in from the left atrium into the left ventricle. So when it opens up, the pressure actually decreases, right? Because I guess the suction, you can think of, there was a suction mechanism going on with the isovolumetric relaxation. So when there's a hole that opens up, that means there's basically the load of the pressure is being shared now with between two chambers. So that's why there's a decrease in this low pressure right here. So then after all of it is filled up, again, left atrium doesn't have that much pressure to begin with, and even when it contracts, it only goes up to, like, I think 12 maybe. That's it. So it's not too much pressure. So here, after it fills up, it uses all of its 12 mmHg pressure and to get you up to here with the pressure, right? And yeah, so right before the mitral valve closes, the left atrium is like, from this big thing, it's gonna be like this little thing right here now, right? So not too much pressure left. So that's the decrease right there before it closes. So when it closes, that's when the isovolumetric contraction begins again, and this whole cycle happens. Okay. So what happens to the aorta? Okay. So in the isovolumic contraction, it's closed, right? So it's closed. It stays the same volume right here, and the pressure is the same. When the aortic valve opens, then it's basically about the same systolic pressure as the left ventricle, right? That's why it goes parallel to it up till this pressure, this amount of pressure. When this pressure it goes below this pressure, aortic valve closes. When it closes, there's a slight increase. It's known as the dicrotic notch. This increase is basically happening because of the way the valve closes, right? Because imagine the valve is like that, oh no, and like that, right? In the aorta. So this is your aorta, and then this is your left ventricle, right here, right? So it's going up into this. So when it's going like that, it's the same as this. But now what's going to happen is when these valves close, they don't close like that. They close upwards, right? They're going to go from here to here, like that. And this valve goes from here to here, like that. So when that happens, they're usually tricuspid, so it happens on like three different sides. Um, the last bit of pressure over here, when it closes, it pushes up. So this pressure is generated from this these valves rather than the muscles of left ventricle, right? That's what this pressure is made from. It's adding to whatever the pressure was from here to here, plus whatever this valve can create. So that's your aortic valve closing pressure. And this is also conveniently your S2, right? That's why you get that dub sound. That's what the S2 is. Okay. Okay. Yeah. Okay. So yeah. So we did the S1, the closure of mitral valve closes, and then S2 as well, right? S3, if there is you know and systolic volume, then you have S3 because of that. Over here in the rapid filling stage. Rapid filling, again, that's after the mitral valve opens, right? And mitral valve opens, the fluid comes in from left atrium into the left ventricle. And then you have S4 over here. S4 is at the end of systole, right? So atrial systole. So end of that right before the mitral valve closes. Okay, you need to know this as well because uh, they will give you a clip of audio sound of a murmur, and then the murmur will have like a S3 or S4, and so you'll make out what lub dub is, and then there will be a sound between dub and lub. So lub dub lub, right? So before that, so it would be lub dubs lub dubs lub dubs lub dubs, like that. So that so you have to focus on when you're hearing that sound. So if it's lubdubs, 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 that's S3. But if it's lubdubs, lubdubs, lubdub, that's S4. Okay. For this, just Google up the murmur clips and you'll find it on YouTube. There are enough of it. Or you'll also hear it on UWorld. But learn to differentiate between them because they'll ask you something simple like that on STEP. They won't complicate it. Also on steps, they're gonna give you a body. Okay, so it's gonna be a guy laying like that. I don't know why the guy looks demented. Uh, but they'll give you a spot here on the A and the P and the T and the M side as well. So they'll give you four, or like they might give you one more over here for some reason to confuse you. So they'll give you these areas you can click on. So you can click on this, and then it'll play a sound over here, what you would hear on a stethoscope over here, or they'll give you a sound over here. So if you click it, you'll hear what you hear on a pulmonary side, or like the lateral side of the septum on the left side, or the mitral area, right? So then you'll hear at some places a murmur louder than say here if the murmur is in mitral, right? But yeah, sometimes that's all they give you. They don't even give you the history if they're testing you on the sound itself. But they might just give you the history and the sound together. So if they tell you that the sound is radiating to axilla, it's probably going to be something to do with mitral valve, right? So that would help as well. Okay, so we did these. Now we gotta know what's happening to the left atrial pressure. Okay, so when the mitral valve closes, after it closes, it gets filled up from the pulmonary veins, right? The blood comes in during the isovolumetric contraction. That's for just 10 minutes left. Okay, so it's that comes in. From there, it creates that left atrial pressure, and mitral valve opens, and then that's it. Yeah, so when it opens, obviously the pressure is going to decrease because all of its pressure comes from the fluid, and the fluid is getting leaked into the left ventricle. That's why it gets lowered after mitral valve opens. Okay, so know this, and then you gotta know why there are these waves. Okay, So the waves, we're gonna do that now. So the A wave comes from atrial contraction. Okay. So the atria contracts, uh, absent in atrial fibrillation. Okay. So when the atria contracts, mitral valve closes. Oh, right. Okay. So right before mitral valve closes, what's gonna happen to the right or left atrium, right? It's gonna push, so it's gonna create the pressure increase, and that pressure is this, and you'll see the pressure increase in left ventricle as well, right here before it closes, right? That's why it's only this much, right? Okay, got it. So then after it closes, it's fine. It does its own thing, left ventricle, and then the left atrium does what? Uh, it gets the blood coming in from the lungs, so it increases a little, but then that will stop as well, right? Why does it this decrease? Because in the heart, in the left atrium, that's the left atrium, and that's the left ventricle. When the fluid rushes out of the, when the aortic valve opens up, basically, right? Wait, no, I'm wrong. Okay, let's not confuse ourselves. We got it this far. That's good enough. Okay, so C is right ventricular contraction, closed tricuspid valve bulges into the atrium. Okay, so yeah, so when this valve closes, and before this valve's opened up, the so just imagine this is right atrium now, and right ventricle, and this is the pulmonary valve right here. So before this opens and this close, after this closes, what's gonna happen? This thing is gonna press inwards, right? It's gonna contract inwards. So what happens to this is that it this pressure is going to push onto this valve on the tricuspid, and that's going to create your C wave. So that's the C wave. That's where it comes from for the left atrial pressure. Okay. You have X descent. That's atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection phase. Okay. So atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection phase, reduced or absent in tricuspid regurgitation and right heart failure because pressure gradients are reduced. They're not going to ask you about this. They might ask you about this or this, but not this. Then we have V wave. That's increase in right atrium pressure due to increase in volume against closed tricuspid valve. So that's V wave. That's over here after the mitral valve, right before it's closed. So right atrial pressure due to increase in volume against closed. Okay, so that is what it says it is anyways. Y descent is right over there. Right atrium emptying into the right ventricle, prominent into constrictive pericarditis, absent in cardiac tamponade. Okay. Why will you'll understand it when we do this, but right atrium. Oh, right. So what actually happens is, remember I told you, it's when the pericardial space is filled with fluid, so it's already creating pressure in the atrium, into the atrium, because atrium doesn't have that much pressure to start off with. So whatever pressure change was detected here is covered up by the pressure that's coming in from the outside due to the fluid in the pericardial space. Okay, so we're done with that. Now we're gonna do questions about these two in this page after the break. Percentage, they're always gonna tell you it's half. Okay, so a 49-year-old woman with coronary artery disease undergoes coronary arterography that shows a 50% decrease in the lumen of LAD, or left anterior descending. Hold on. left, no, LAD, it should be what was LAD again? What am I skipping on this? Left anterior descending artery. Okay, right. That messed me up. Okay, so for any AV pressure gradient, the flow through this artery compared with normal wall decreases by a factor of which of the following, right? So that's the question. So let's go through that question. Okay, so we know that whole formula, the Postulate's law or whatever, right? So it was that thing. It's okay. What was the Postulate's law? Let's see. I'm probably pronouncing his name wrong, obviously, because I butchered the pronunciations. So it was resistance equals the 8n or viscosity times length divided by pi n r to the power of 4, right? So we are only concerned about the radius, and we don't have the other formulas, so it's r to the power of 4, right? Okay, and what do we put up here? What we know is that at the starting the artery was wide open, and that's the reference point, right? So we can just assume that the artery was at 100%. So one number, so we put that 1 over there, and 1 over 1 is 100%, right? And then they're telling you that it shows a 0.5, right? Or 50%, which is of a half of 100%, or also known as 0.5, right? So you can put, instead of 1, you do 0.5, and that is your radius, right? So then all you do is 0.5 to the power of 4. Okay, so we have a calculator here. 0.5 times 0.5 times 0.5 times 0.5. So you get that, and then you do 1 divided by 0.625. And you get 16, right? And that would be the answer then. 16. Cool. Yeah. So that's how. Very simple. Lumen is reduced by half's the size, therefore this and this. The flow through that is decreased by the factor of 16. That's the Poiseuille's law, is this. So the factor changes from that to that. For multiplication. And I showed you that in case you want to pause it and watch that later. Okay, continuing. Okay, so we did the left atrial pressure and the heart sounds. Ventricular volume, they won't test you on that, but it's basically up to the isovolumetric contraction. You have the volume over here, and then it decreases, right? And then you have mitral valve open, and then the volume comes in from the left atrium, and so it increases until again aortic valve opens. Okay. Then you have right atrial pressure curve. That's jugular venous pressure, right? Or JVP. So up till here it's the same, right? So atrial contraction happens, so this one goes up, right? And So just imagine the superior vena cava, if not the jugular venous, right? So you can just think of SVC. What's gonna happen to SVC when atrial contraction happens? So absent in atrial fibrillation. Basically, it's pushing against the tricuspid, right? So there's going to be rise in backflow of into the superior vena cava. So backflow of that will cause backflow of jugular venous pressure as well. So that's why there's an increase in jugular venous pulse as well, or RAP, sorry. Then it opens up, right? Mitral valve closes, it's up, and then the ventricle is gonna stop pushing into it, right? So right ventricle is gonna stop pushing into the atrium, and instead it's gonna go into the pulmonary artery. So the pressure decreases because of that. And the X is the descent, atrial relaxation, downward displacement of the closed tricuspid valve, right? So that's what causes that. And then you have the V, RA pressure, again, it's contracting, right? Isovolumetric relaxation of left ventricle causes isovolumetric contraction of the left atrium. So that's, you have that up there. And then Y is the descent again. That is right atrium into right ventricle empty. Okay. ECG, I'm sure it's given somewhere else, a better one, but it's P is the atrial depolarization. Okay. And then you have the ventricular depolarization over this bit, and then you have the repolarization over here. Okay. And then that's the T wave, that's just resetting of things. And then that. So again, atrial depolarization, right? So that's going to be your atrial systole. Okay. So that's what causes that. And then you get it goes to the AV node over here. So once it reaches the AV node, the isovolumetric contraction starts, because AV node sends in the electrical impulses throughout the whole ventricle, right? And then it starts contracting, and the contraction causes enough pressure to open up the atrial valve, aortic valve, sorry. And then contraction happens, and then it goes back, basically behind. I forget what T was. We'll come across that later. Okay. And that. So before we do anything, let's do this and fill it up black. Oops. And let's put that here so we can talk about this. So without looking at the sides, what do we know about the stroke volume to start off with? It's decreased here, right? We are talking about aortic stenosis. Okay, that's when the aortic valve doesn't open. Okay, so what's going to happen when it doesn't open as fast as it needs to? Okay, so the stroke volume is going to decrease. Obviously, the cardiac output is decreased now, right? So stroke volume decreases. What's happening to this part right here? That was the afterload, right? If afterload is increased, what does that mean to the end systolic volume, basically, right? So end systolic volume was here, and now it's all the way here. So end systolic volume is decreased, right? No, increased, I guess. We'll make sure of that. The contraction is the same though, right? Because it's following the same curve like that. So the contraction, there's no difference in that. No difference in end diastolic volume either. So if diastolic volume comes from 100 to, I don't know what, I guess it's increased then, right? So it goes from 100 to 200. So if it's going from 100 to 150, it's increase in end systolic volume then. Okay, so that's increased, and that's all you can tell with this. But if you're given this chart, you should be able to recognize that this is a chart for aortic stenosis, right? Uh, so this is the pressure in aorta, the red line, right? Normally it follows up to here because as soon as the aortic valve opens, its systolic pressure of the left ventricle is similar to the systolic pressure of the aorta because this thing normally goes up here and then it makes a dicrotic notch, right? Like that. But this time it's all the way down here. So that means the pressure, the difference between the pressure, right? That's because of aortic stenosis. Even though after it opens, it doesn't open fully, so not all the pressure is transferred completely. So some of the pressure, the valves are gonna take a hit for that when it's going. So only a little amount, like a lesser amount of pressure is transferred to the aorta. Okay, and that's why you have this left ventricular pressure more than the aortic pressure. So there will be dicrotic notch when it closes, but the pressure is less. So if they just gave you a chart like this and they give you a aortic line like this, you should know that's because of aortic stenosis. That's like a giveaway. Okay, so let's see if we got that. So there is increase in left ventricular pressure, right? So that's left ventricular pressure. That's up here instead of here. There's increase in systolic volume. We already did that. Systolic volume is over here. Diastolic volume is on this side. So it went from here to here. So increase in systolic volume. No change in diastolic volume. That's over there. F mile. And there's decrease in stroke volume. We did that as well. Right. Ventricular hypertrophy will cause decrease in ventricular compliance and increase in end diastolic pressure for given end diastolic volume. Okay, so ventricular hypertrophy will do what? It decreases the ventricular compliance, obviously, and there will be increase in end diastolic pressure. Okay, for given end diastolic volume. We have aortic regurgitation. Now there's a backflow of fluid from the aorta into the left ventricle. So that will give you more volume in the ventricle during diastole than normally available there, right? So that backflow is going to cause increase in end diastolic volume. So it's over here now instead of here. So that's an increase in preload or end diastolic volume. There's also an increase in stroke volume, right? The contraction is the same. The pressure on top is like almost similar. So there's maybe a slight increase in the afterload if they want to mention it. Okay. The compliance is also the same. It always goes like that. So compliance contractility is the same. Over here we see that since it's regurgitation, there is a decrease in the volume, right? Normally it starts up over here and then that's where it comes in from, but there's a decrease in volume even before the aortic valve opens, right? Because there's regurgitation happening. So it's going back into the left ventricle until it opens up. Then the left ventricle pushes itself up again, right? And even this is skewed, right, for the left ventricle because it already has a little more volume than here. So normally the volume starts over here, but now it's starting all the way here. Okay. There's a pressure volume curve, right? Pressure volume loop. So you need to know what the line is. They don't tell you that. Okay, so the volume was increased even before it started, and then there's a decrease because of that. But then the left ventricle is working properly, so its systolic pressure is going to be the systolic for aorta as well, so it goes all the way up here. Then the aortic valve closes here. The closure will cause this little bump, but after the closure, because there's regurgitation, the pressure is not gonna keep sustained, right, as it is sustaining up here, because there's gonna be a drop in pressure volume, so that will lead to a drop in pressure as well. So large pulse pressure in here. So large pulse pressure is known for aortic regurgitation. Let's see if we got that right. No true isovolumetric phase, right? The volume keeps on, even during the relaxation, it keeps on adding to it. There's increase in end diastolic volume, we got that. Increase in stroke volume, we did that. And loss of dichrotic notch. So that little sustaining it doesn't do is loss of dichrotic notch. Yes. Okay. We have mitral stenosis. So here there's going to be a problem with the preload, right? So right off the bat, the preload is decreased. Preload was at 150, now it's at like not 150, like 185 or 180, and now it's at like 150. So that's a decrease in diastole. There's no afterload increase. LV pressure is a little less. The contract compliance is similar, but what has decreased is the stroke volume. Right. That's this to this. So stroke volume decreased, and diastolic volume has decreased. Okay. And here, blood pressure. The left atrium more than the left ventricle pressure, because that is the left atrium line, right? So the pressure in left atrium is going to be more because, again, left atrium doesn't have that much power to push. So it's going to use up all its energy to open up the mitral valve. Okay, so it's constantly under a lot of pressure because even after it opens up, it doesn't leak out all the blood. Some blood will still stay in mitral valve, and that's the reason you get thrombus formation in the left atrium in mitral stenosis, which can cause heart blockage or heart failure kind of thing situation for you. Okay, so nothing's wrong with the aorta, so it's just gonna follow the pressure gradient of the left ventricle. It's just a little smaller. Okay, so left atrium pressure increases in mitral stenosis. That's over here. Decrease in end-diastolic volume because of impaired ventricular filling, we did that. Decrease in stroke volume, we did that. There's a slight decrease in this little thing right here, so, and systolic volume as well. Okay, I don't know where this thing comes from. Like, I can explain it in words, but from the chart you just look at that and that. It's again after lunch, so I'm feeling sleepy now. Mitral regurgitation. Okay, so in mitral regurgitation you have increase in preload, so your diastolic volume increased, decrease in afterload, so this decrease and systolic volume decreased. And decrease in afterload as well. Okay. You have increase in stroke volume. The compliance is the same, so it's following the same curve like that. The contractility is decreased, I guess. It was up here, and now it's up here. So contractility decreased. Okay. Over here we see that after the mitral valve closes, the mitral valve is leaking through. So blood from left ventricle is going back into the right atrium. I mean left atrium, right? So that's why you get the leakage back into the thing. So that's why this tall V wave you have over here. Because normally it's down after mitral valve closes, right? But now you have blood coming in as this is happening, isovolumetric contraction is happening. Since it can't go through aortic valve, it's going to go through the mitral valve into the left atrium. So that's why you have this pressure gradient going up for that. Everything's same for this. Upper part, left ventricle, aorta, both function normally. Right, so let's see if that makes sense. There is no true isovolumetric phase because it can't go through aorta, but it can go through the mitral regurgitation. So that there's decrease in end systolic volume due to the decreased resistance and regurgitation. So when it does manage to push through aorta, it doesn't mean it's going to push everything through the aorta, right? Now it also has the mitral valve that's regurgitating. So when the left ventricle pushes into the aorta, it also ends up pushing a little bit through this thing. So that's why you have decrease in end systolic volume due to the decreased resistance and increase in regurgitation into the left atrium during systole. So this thing is going to push it in. Okay. Then you have increase in diastolic volume. We did that over here, right? Due to the increase in left atrium volume pressure from regurgitation. So now that the volume is this much plus the volume that normally it carries, there's increased amount of volume altogether, right? So all of that is going to come back into the left atrium. So the end diastolic volume is going to be increased because of that. And then there's increase in stroke volume. We did that. Forward flow into the systemic circulation plus backflow into the left atrium. Know these curves, know the defining features and the distinctions. If the pressure is low in aorta, it's always going to be aortic stenosis. If there's a loss in aortic dicrotic notch, it's always going to be because of this. And also make sure you look at this bit right here, because if that tells you that there is no isovolumetric phase, contraction phase, and that only happens when there is a regurgitation of some kind, right? So it could be aortic regurgitation or it could be mitral regurgitation. Not mitral. Okay, so it can only be that. Okay. Mitral won't have proper contraction. That's what it won't have because it's going back into the left atrium, not the thing. Okay. For mitral stenosis, defining feature was this right here, the left atrium curve. So it starts all the way up here instead of down here. Okay, so mitral stenosis increases the pressure in left atrium, and mitral regurgitation at the end. You need to know this thing. If it's like that, it means that there's mitral regurgitation. You can figure this out on the spot if you know what the graph means and everything. So, but it's faster to just memorize it and then you can just go with that. Okay. They didn't talk about contraction here, so I don't know why, because there's a difference in contraction as well. And it would make sense because mitral regurgitation makes some kind of remodeling of the heart. Okay, so now we're doing splitting of S2. Physiologic splitting. That's just normal. So inspiration leads to drop in intrathoracic pressure, which causes increase in venous return, which leads to increase in right ventricular filling, which causes increase in right ventricular stroke volume, which causes increase in right ventricular ejection time, and this causes delayed closure of pulmonic valve. So what does that mean? Just okay. I'm not sure. So what does that mean? So basically, it's saying try breathing right now. So what's gonna happen when you're breathing? There's a negative pressure in the thorax, right? So a drop in intrathoracic pressure, because your outer chest wall is pulling outwards, and it's creating negative pressure in the lungs, right? So negative pressure in the lungs will cause intrathoracic pressure. Sorry, it's gonna cause decrease in venous return, like that. Okay, and then you have, I don't know why I'm redacting this information. Okay, so drop in intrathoracic pressure when you're breathing, right? This happens. So intrathoracic pressure decreases by diaphragm, right? So your diaphragm pushes upward, and then like you can just think of like abdomen is pulling in the blood basically. So that's why you're decrease in venous return. So when you have decreased venous return, you'll have decrease in right atrium filling, and then that will cause. Sorry, wait. No. I was right initially. Okay, so negative pressure in the lung will pull in more blood. So when you pull in more blood, you have decrease in increase. Sorry, I keep saying decrease for some reason. Increase in venous return. So increase venous return in right atrium to right ventricle filling, and then right ventricle will put out more pulmonary output, right? So that's your stroke volume, and then this will increase the RV ejection time, because it has now more volume to push instead of the normal one that it was pushing, because now there's increase in venous return, right? So this little amount of time is why there's a delayed closure of pulmonic valve. On the other side, the aortic valve has already closed, right? So that's the difference. The sound of closing of aortic valve and the pulmonary valve, there's a difference between like a little amount of time between the two. So that's the sound that they're talking about. That's called splitting, physiological splitting. So decrease in pulmonary impedance, increase in capacity of the pulmonary circulation also occurs during inspiration, which contributes to delayed closure of pulmonic valve. Okay. Then you have wide splitting. So that's S1 and that's the S2. And during expiration it's the same, but during inspiration pulmonary valve closes a little later. Okay. You have wide splitting seen in conditions that delay RV emptying. Okay, so that's your pulmonary stenosis or right bundle branch block. If you don't know what bundle branch is, it's these things right here would be your right bundle branch. Okay, right there. So right bundle branch is pointing towards it. So from here, the electrical impulses come from here, right? But say there's a block, some kind of block over here, and it's not able to do that, then you're gonna have a delay in that too. Oh, don't want that. Okay. Alright, so it's seen in that right bundle branch block, and pulmonary stenosis causes delayed pulmonary sorry, causes delayed pulmonic sound, especially on inspiration, and exaggeration of normal splitting. Okay, so normally it's going to be a little wider apart, but even with inspiration it's going to be even wider than that. So in a question stem they'll just tell you that a wide splitting is heard of S2, and that should just give you a hint to what the answer is going to be. It's going to be one of these two. Okay. So for this, the mnemonic is a wiper. Wiper. Wide and then PR for pulmonary stenosis or right bundle branch block. Then you have fixed splitting that's heard in ASD, right? Atrial septal defect. Mnemonic for this is first aid or FA. Okay, so in fixed splitting, it's FA for ASD, atrial septal defect. Okay, so atrial septal defect will lead to left to right shunt. Right, because left side is stronger than the right side, so it's gonna push the blood through the septal defect, and then you have increase in right atrium and right ventricle volumes. So this volume then it increases flow through the pulmonic valve, and which causes the delayed pulmonic valve closure independent of respiration. So respiration doesn't have an effect of this on this, and that's why it's going to be fixed. Okay, so fixed is for FA, which is ASD. Then you have paradoxal splitting, and this is your PAL. Okay. So paradoxical splitting, if they give you that, it's heard in conditions that delay aortic valve closure. So you have aortic stenosis for that and left bundle branch block. Okay, and this is on the left side now instead of the right side. So wiper, FA, PAL. Okay. Normal order of semilunar valve closure is reversed. In paradoxal splitting, P2 occurs before E2. On inspiration, P2 closes later and moves closer to E2, paradoxically eliminating the split. Okay. And on expiration, the split can be heard opposite to the physiological splitting. Okay, so this is a normal one, and then this is the other one. So normal order of semilunar valve closure is reversed. So in paradoxical splitting, P2, so pulmonary closes before the aortic. On inspiration, the pulmonary closes later, right? And that's why it sounds closer to the delayed aortic closing. On inspiration, P2 closes later, moves to the aortic, so paradoxical, eliminating the split. Okay. Normally the split is not heard during expiration, and then it's heard during inspiration, but here during inspiration it's not heard, but it's heard during expiration. So that's why it's called paradoxical. So remember, PAL for paradoxical aortic stenosis and lateral branch block. FA is for fixed splitting that happens in ESD, and wide splitting happens in wiper. So P for pulmonary stenosis and right bundle branch block. Okay. This is again evolution goes from ape to two, sorry, two men. So, A on the right side, and then you have P on the left side, T on the left side, and M on the over here. For the aortic area, it's only going to be stenosis. Same thing with pulmonary, it's only going to be stenosis. And then you have the tricuspid area with the regurgitations. And then this middle area where left sternal border, where you're going to have the aortic and pulmonary regurgitations. And the mitral valve is going to have both of it. Okay, so now aortic area, systolic murmur, aortic stenosis, right? So aortic stenosis there. You can have the flow murmur. This is physiological murmur, and then you can have aortic valve sclerosis. Okay, and then pulmonary area, systolic ejection murmur. That's this area. Pulmonary stenosis, atrial septal defect, and flow murmur. Right. So again, these two are the stenosis ones. Okay, and then you also have atrial septal defect can be heard over here. Okay, because you won't hear it coming from the right to left. You're gonna hear it from going from left to right. That's why it's on this side. And then you can have the flow murmur there. Then you have this left sternal border. So that's this part. This is the sternum right here. Right, and then the Ziphy process or whatever. And then on right over there you have systolic murmurs. So all of these were systolics, okay? So systolic murmurs in these areas, you hear stenosis, S for S. S for S. And here, left sternal border. So you won't hear any diastolic murmurs over these two areas. You'll hear it at the left sternal border though. And the first two diastolic murmurs you hear are aortic regurgitation and pulmonary regurgitation. So we are done with aortics and pulmonaries, right? So aortic stenosis in the aortic area, systolic murmur. In pulmonary area, systolic murmur is going to be pulmonary stenosis. In left sternal area, diastolic murmur is going to be aortic regurgitation and pulmonary regurgitation. For systolic murmur, it's going to be hypertrophic cardiomyopathy. That's because there's increase in interventricular septum, and then so what happens is imagine so imagine this is the aorta, okay, and normally this is your interventricular septum, right? But what happens is during hypertrophy this becomes bigger and it starts occluding this thing, the opening of the aorta. So before, when the thing was able to go through easily, now it's getting squished in by this. So now it's got the pressure is created here, and that's the murmur you hear. And during systolic, when the LV is pushing in. Right? So that's what the hypertrophic cardiomyopathy, how that creates systolic murmur. Okay. Then tricuspid area. Now you have hollow systolic murmur here. That's it could be tricuspid regurgitation or ventricular septal defect. So ventricular septal defect, you'll only hear it on tricuspid side, not this side. Okay. Then you have diastolic murmur there as well. So you have tricuspid stenosis for the murmur in diastole. So you gotta remember here the systolic murmurs were stenosis, and when you go down it flips around. Hey, that rhymes. And when you go down it flips around. So in tricuspid diastolic murmur is going to be tricuspid stenosis, and the systolic is going to be the regurgitation. And you have VSD there as well. For the mitral, it's similar. The systolic is going to be the regurgitation, but here instead of the VSD you have MVP. Okay, and the diastolic murmur is going to be mitral stenosis. So memorize those because these are like the giveaways if you remember this stuff. Which ones are diastolic? Which ones are systolic? Systolic is the one where it's emptying into the aorta, and diastolic is the one where it's filling up in the left ventricle. Just so you remember, and second intercostal spaces for aortic and pulmonary. Left sternal border at 2 would be this part right here, and at 4 intercostal space would be this part right here. And then this would be your 5th intercostal space for the mitral valve. Okay, now the maneuvers. These are important to know as well, and I'll try to clear up the image for this. How much time do we have? Okay, so maneuver. Cardiovascular changes, murmurs that increase with maneuvers, and murmurs that decrease with the maneuver. Okay, so when you're standing, what's going to happen? If you stand right away, it's going to create a negative pressure in your vein and vessels, right? So that will decrease the venous return. If there's a decrease in venous return, what does that do to the what does that do to the volume in right atrium? It decreases it. So if there's a decreased amount of volume coming in, that also means there's going to be decreased amount of volume in left ventricle. So that's why you have decrease in preload. Okay. For the Valsalva maneuver, the strain phase, that's when you are, Valsalva maneuver. Okay. So it's like this guy, right? You're pushing in like that, and that's a horrible picture. Grouping. Okay, that's for the vessel maneuver for the ears. We'll just try to figure it out like that. So when you're doing that, what's happening here is it's creating more resistance, right? It creates more resistance when you're doing the straining phase. Okay, so when you're creating resistance, that means what? You're gonna have decrease in preload as well, right? Because venous return is gonna be decreased because it's low. Right. So that's why you get decrease in preload when you can just try doing that, and you'll see. So when you have decrease in preload, what happens to the thing? Maneuvers. Okay, so what happens to the mitral valve if it's prolapsed? You'll have MVP decrease in left ventricle volume with earlier mid-diastolic click. Okay. Yeah, for this I'm just gonna remember it. At this point I just remember these, so I think I'll just confuse myself if I try explaining it. So just remember it the way it is. Okay, so we have MVP and hypertrophic cardiomyopathy that decreases the murmur. Sorry, that increases the murmur with this maneuver. Okay, increases. Decrease in preload. Okay, whatever. And then you have most murmurs, which is decrease in flow through stenotic or regurgitant valve. Okay, so these ones decrease. So know this whole chart basically. That's important. Then you have passive leg really raise, so that's gonna increase the venous return rate. So that's gonna increase preload. Then you have squatting. Here you're creating more resistance on the peripheral side, but you're also increasing the preload because now you're closer to your legs, so the blood can travel into your heart faster, right? So that will increase the preload, but since you're also creating resistance, uh, the blood going through the aorta is going to be backed up now because of the resistance. So that resistance is going to cause increase in afterload. Okay, most of the murmurs are going to increase because of this. So increase in flow through stenotic or regurgitant valve. MVP, increase in left ventricular volume with later diastolic flick, and HCV. So the ones that were increasing here are now getting decreased over here. Okay, for the hand grip, so when you're doing hand grip, what are you doing? So when they say hand grip, nope, that's not what they mean. That's not what they mean. I guess we gotta go back to Google for that. Basically, it's just two hands, pulling each other, kind of thing. That's the way I imagine it. I don't actually know what type that is. I forgot. But whatever you do, it's gonna increase the resistance, right? The peripheral resistance. So when that is increased, you're increasing afterload. Okay. And increase in reverse flow across aortic valve. So increase in left ventricular volume. Okay. Okay, that's what that means everywhere else. The left ventricular volume decreases, so when it decreases, you'll hear it a lot more because now there's more area in the chamber to make the sound in. Okay, that's why. But that could be true for these two, so I don't know how that would help you remember that. But yeah, okay. So most other left-sided murmurs, why left-sided? Because those are the ones getting affected due to the resistance. Right. So aortic regurgitation, mitral valve regurgitation, and ventricular septal defect. Even though remember, they said that this is on the left-sided murmurs, but it's actually on the right side you hear it, under tricuspid, ventricular septal defect murmur, holosystolic. Okay. Then you have atrial septal defect, aortic stenosis. That decreases because of this and grip, so you won't hear it because again, there won't be enough pressure to even, make the sound or whatever. And then you have hypertrophic cardiomyopathy for both of these things on this side. Then you have inspiration. Inspiration will cause increase in venous return to the right heart and decrease venous return to the left heart. So most right-sided murmurs, because that's where the blood is mostly, and decrease for most left-sided murmurs. Okay, let's wrap that up. Standing Vasova increases MVP and HCM murmurs and decreases most of the other murmurs. Why? Because it decreases preload, which decreases left ventricular volume. The passive leg raise will cause increase in preload, so increase in LV volume. And then you have squatting, increase in preload and increase in afterload, because you're increasing venous return but also increasing the peripheral resistance for the aorta. And then most of them you'll hear it, and then the ones you won't hear is MVP and hypertrophic cardiomyopathy. Hand grip increases resistance, increases afterload. Right, so most of the left-sided ones are the hurt ones, and you don't hear aortic stenosis and ACM for that. And then for inspiration, most right-sided ones, and you don't hear the left-sided ones. Okay, heart murmurs, aortic stenosis. Hold on, there's also one for nitroglycerin. So nitroglycerin would go here. Glycerin. It decreases preload because vasodilation, right? So that decreases venous return. Preload. Okay. It increases the murmur intensity for these, and it decreases left ventricular blood volume. Increase in S3 at end of expiration. I think that's for this. For something else. Okay. But remember, for NTG, it decreases preload. So when it decreases preload, you're gonna get something similar to this stuff. This one. Okay, heart murmur, systolic and diastolic. Okay, and then you have a continuous one. I like doing these backwards because it's once you get these, and then you just don't have to memorize the systolic ones as much. So let's go backwards. Continuous. So pain ductus arteriosus. You have S1, lub, and dub. Okay. Again, go to YouTube and listen to all of these because you need to know what they sound like. So lub dub there. This is closure of mitral valve. This is closure of aortic valves, or pulmonary, mitral and tricuspid over here. So this is the buzzword that they will use: continuous machine-like murmur. If you hear continuous machine-like murmur, it's going to be about PDA. The question's about PDA. You might just have to, figure out that it's this, and then you're done. So it's best heard at left infraclavicular area and loudest at S2. Or they might say that they heard this. What's the best way to manage this, or something like that? Again, to close this, we get what? Indomethacin, right? So, like murmur, best heard at left infraclavicular area, and it's loudest at S2. Okay. Often due to congenital rubella or prematurity. Right. Remember these causes. So congenital rubella is important because of PDA, and then you have prematurity that can cause this. So you need a patient for that machine. You need a patent for that machine. That's how you remember that one. For this one, it's just the operating system is Microsoft, right? So OS in MS. So if you hear opening snap, that's the one closest to S2. So it follows, and remember, all of these murmurs are going to be heard after the aortic and pulmonary valve closes, because it's diastolic, right? So follows opening, snap. Delayed rumbling, mid to late murmur, decrease in interval between S1 and OS correlates with increase in severity. So the closer this one gets to S1, because S1 is on this side, so this would be S1 again. So the closer this distance gets to this, the higher the intensity or severity, sorry. You need to know that. There are questions about that. they ask you how would you know how severe this is. Well, the distance decreases in severity. Okay, so this is clinical association and notes. Okay, so late and highly specific sequelae or rheumatic fever, chronic MS can result in LA dilation and pulmonary congestion. Atrial fibrillation, Ortner syndrome, and hemoptysis, right heart failure. Okay. Mostly it's going to be about the rheumatic one, but the chronic one can result in left atrial dilation because, again, we did that, right? So it was something there, this was something here, and then you had the aorta on this side. So this was your left atrium and this was the esophagus. So esophagus there, left atrium there. So if this gets bigger, what's it going to do? It's going to push into this, right? So you're going to get the Ortner syndrome over there. And the left atrium is dilated because of the pressure, pulmonary congestion. So if pressure is built up here, the blood coming from the lungs are going to be backed out. So that's why you get the pulmonary congestion. Then you have Ortner syndrome, hemoptysis. You bleed through there as well, in your mouth. Right heart failure, right? Because you get that Eisenmenger syndrome happening. We'll learn about that too. Not operating system, but opening snap due to abrupt halt in leaflet motion in diastole after rapid opening due to fusion at the leaflet tips. So left atrium pressure is way higher than left ventricle pressure during diastole. AR, aortic regurgitation. This is the one with the head bobbing and water hammer pulse. So only two diastolic murmurs. If they tell you that there's a diastolic murmur heard at the apex, it's going to be mitral stenosis. If they tell you that diastolic murmur is heard on the left side of the sternum in the second interventricular space, then it's going to be aortic regurgitation. And that's a dead giveaway because it can't be anything else, right? Just a sec. You probably heard all of that. Sorry. Okay. Early diastolic decrescendo. So this is crescendo. This is decrescendo. And then this is crescendo decrescendo. Okay. That's just the wave names for the waves from music. Okay, so early diastolic decrescendo, high-pitched blowing murmur sound, best heard at base. Okay, so aortic root dilation or left sternal border, valvular disease. So I already told you those. This one we don't have a location for it unless they tell you it's over here, but we have a location for this thing, so they'll give you that. And they might even use the word blowing, which would be a buzzword for this. Okay, so continuous machine like what's this, blowing is this, and then you have operating snap over here. Okay, so mnemonic for this can be something like assault rifle, so AR, assault rifle. I'm gonna blow people up with assault rifle or something. Hopefully I don't get FBI at my door now. Let me just not bother writing that, just remember it. Okay. So that could be a mnemonic for that. because it's the blowing one, and AR is assault rifle. If you are into guns or know anything about it. Okay. Cause includes BARE, so bicuspid aortic valve, endocarditis, aortic root dilation, or rheumatic fever. So rheumatic fever causes this and this. Right? It can cause both. Aortic root dilation happens, which causes this obviously, and endocarditis or bicuspid aortic valve can also cause this. These ones are a little tricky to remember, but these ones should be, you should know these for sure. These two. Okay, so pulse pressure, also known as water hammer pulse. You have the pistol shot femoral pulse. Oh, see, all these gun references. Then you have pulsing nail bed, or quink pulse. I guess they added this new thing. Okay, so pulsing nail bed, you get but if you know water hammer pulse, then that's probably the one they're gonna ask you about, because what does that do? It makes your head bob, right? So hyperdynamic pulse and head bobbing when severe and chronic can progress to left heart failure. Okay, that's it. And now we're going to do the systolic ones, the ones that cause murmurs due to ventricular contraction in the left ventricle. Okay, so you have aortic, left or right ventricle, but aortic is going to be your crescendo decrescendo, right? So crescendo decrescendo right here. Ejection murmur. Ejection murmur. Then you have loudest at heart base and radiates to the carotids. So if they tell you that it's carrying murmur into the carotids, it's going to be aortic stenosis. Soft S2 pulse, they give you this, that a soft S2 is heard. So that could also hint you that it's this. Eject with or without the ejection click. So that's easy. Right, so you have pulses parvus et tardis, weak pulses with delayed peak. Okay, so they're weak and they're late pulses, weak and late. Okay. In older, more than 60 years old patients, most commonly due to age-related calcification. In younger patients, most commonly due to early onset calcification of bicuspid aortic valves. So remember this because it's important. They might say that there's calcification of nodes in a 70, 80-year-old patient. What could be the cause of this? And you probably pick like rheumatic fever or something, I don't know. But pick the one that says it's normal in aging, it's due to age or something like that. So that would be the answer for that. It can lead to syncope, angina, and dyspnea on exertion. Sorry. Why? Because it requires more blood, and then this one's hampering that supply. So a hampering supply to the brain will cause syncope, to the heart will cause angina, and to the lungs will cause dyspnea. Because it has to come back as well. So left ventricular pressure is more than aortic pressure during systole. Then you have mitral and tricuspid regurgitation. These are your hollow systolic ones, so that's easier to remember. This and this is your hollow systolic. Mitral is going to be at the mitral area, tricuspid and ventricular are going to be at the tricuspid area, and they are going to be hollow systolic, right? So hollow systolic, high pitched blowing murmur again. So this blowing and this blowing. So if it's diastolic blowing murmur, it's gonna be AR. But if it's systolic, then it's gonna be this regurgitation and not the aortic regurgitation. But blowing only happens in regurgitation. Okay. So hus is like high pitched blowing murmur. MR, loudest at apex, radiates towards axilla. Right? That's a buzzword for axillary mitral regurgitation. They didn't say it over here, so yeah, for right, they're gonna say it for regurgitation. TR loudest at tricuspid area. MR often due to ischemic heart disease, post MI, MVP, LV dilation, and rheumatic fever. That's usually the one they test you on, because this one will lead to like other stuff too. And this happens in Marfan's, so remember that. Often due to RV dilation and either MR or TR, infective endocarditis. The aortic dissection, this thing was in MR. I mean Marfan's. It was either this or this. I don't remember right now. You can look it up, but definitely know that. Okay. Then mitral valve prolapse. So this is the one with the MC. Okay. So the mnemonic for this was just it's how do you spell it? MC for MVP, or MC for MVP or MC MVP. Okay, left crescendo murmur with mid systolic click. So this is important to remember that mid systolic click is part of mitral valve prolapse. Why does it happen? It's late crescendo murmur so it's late crescendo because it's after it opens up, right? So late crescendo murmur with mid systolic click that occurs after carotid pulse. Best heard over the apex, loudest just before the S2, usually benign but can predispose to infective endocarditis. Can be caused by rheumatic fever, chorda rupture, or myxomatous degeneration, primary or secondary to connective tissue disease. MC due to sudden tensing of mid-systolic click is due to sudden tensing of chordae tendineae as mitral leaflets prolapse into left atrium. Chordae causes crescendo with click. Ventricular septal defect, again hollow systolic. Just the systolic ones. Systolic harsh sounding murmur, loudest at tricuspid area. Congenital. Larger ventricular septal defect have lower intensity murmur than smaller ones. Okay, and that takes care of that. Let me read from my notes. So for aortic stenosis, I have in senile aortic stenosis due to dystrophic calcification by cell injury and death. Endothelial and fibroblast death. Infant bicuspid aortic valve is ES and SOS. Yes, okay, that doesn't make sense anymore. Then you also have slow and rising carotid pulse in this. You have mid-systolic murmur, fragmentation of the elastic lamellae in the aortic media. Okay, that's just the pathogenesis. So if you want to remember that, it's fragmentation of the elastic lamellae in the aortic media. Then you have gags in MVP. So you're gonna hear, and the sound sounds like lupadub, lupadub, lupadub. And dermit sulfate, dermatin sulfate. I wrote that way back when, but I don't remember anymore what that means. But I guess it's also part of pathogenesis of mitral valve prolapse. Oh, it's written in the old book. The MVP is found in Ehlers-Danlos and Marfan's. Okay. I know why they took that out from here. They should have put that in. So, okay. Marfan's and Ehlers-Danlos is found in MVP. I mean, MVP happens in these two things. And then, what was for this one? This one they wrote rheumatic fever for aortic regurgitation. Okay, so that takes care of that much. You can have Downs, Edwards, Patau's, Torch, and Cry-Duchet syndrome. In all of these syndromes can have ventricular septal defect. Down syndrome, Edwards, Patau's, that's trisomy of 13, 18, and 21. Torch and Cry-Duchet, they can have VSD. Then I have Waterhammer pulse. Demosit head bobbing, that's what it's called. Okay. Opening snap, Microsoft. Or opening systems. SLE mimickers left atrial is okay. MR is degenerative endocarditis. IHD here is okay. Tricuspid regurgitation, IVDA, Marfan syndrome, carotid, pulmonary hypertension. Acute AR is infective endocarditis. Chronic AR is bicuspid aortic valve and connective tissue disease. You'll figure this out. Just remember, and infective endocarditis is for AR, right? Bayer. If you remember Bayer, then it's part of the E. It's Bayer. Give me a second. Okay, so done with that. Cool. Now we're going to do myocardial action potential now. So there's phase 0, 1, 2, 3, and 4. This important thing to remember is that this is the one with calcium in it. Okay? This and this, but the skeletal muscle, they don't have calcium, right? So okay, so phase 0 is about intracellular sodium, so sodium coming into the cell, and that's going to create depolarization action potential, right? So depolarization is just a contraction, right? So contraction happens when it's depolarized, or depolarizing is called contraction, and repolarizing is when it relaxes. So relaxes, it's repolarization. So voltage gated sodium channels open up, it comes in. Then phase 1 we have after it reaches the threshold and the channels are depleted, the sodium channels are going to close down. Inactivation of voltage gated sodium channels, and then we're going to get voltage gated potassium channels to open up. So when that opens up, potassium always leaves the cell. That's just the way it is. So when that opens, it's going to leave. So the polarity that sodium built up with the potassium in the cell was positive, right? But now the positive ions, which are potassium, it's going to leak out. So the polarity comes down, so the graph is going to come down a little. Okay, that's why you have phase 1. So when you have phase 1, after that comes phase 2. The potassium channel is still open here in phase 2, and this is called the plateau phase. So while the potassium is leaking, you're losing positive ions, but then you have calcium coming in as well. So that's going to balance out the leakage of potassium with calcium ions, which is 2 plus. So this is why you have, one potassium going out while two calciums coming in, like 2 plus. So that's why you have like a balancing out and even like maybe a little rise because of calcium. So your calcium influx through voltage gated calcium channel balances out the potassium efflux. Calcium influx triggers calcium release from sarcoplasmic reticulum, right? Remember that diagram I drew? So this is the cell. There's a calcium channel coming in here. So it comes in here, and then also there's sarcoplasmic reticulum, which has calcium in it, right? So when this comes in, it attaches to the calcium receptors over here, which causes the release of these calciums into the cell. Okay. Sorry. Calcium influx through voltage gated calcium channel balances out potassium efflux. Calcium influx triggers calcium release from sarcoplasmic reticulum, and myocyte contraction then takes place. This is called the excitation contraction coupling. It involves calcium and ATPs. Okay, so now we're at the end of phase 2. So what happens in phase 3? This is called the rapid repolarization. So relaxation stage is this. This is where massive potassium efflux due to opening of voltage gated slow delayed rectifiers or potassium channels and closure of voltage gated calcium channels. So we have massive potassium leaking out due to the open voltage gated slow delayed rectifier potassium channels. Just basically the potassium channels are still open and it's leaking out, right? So that's what that is. But the calcium channels are closed now. Okay, so we got closure of sodium up here, sodium channels, and opening of potassium channel here, and then nothing about potassium so far. It's still open. But then over here at the start of phase 2 we have calcium channel open up. At the end of phase 2 we have calcium channel closing, and then it's going into phase 3 then. So throughout this thing, it's calcium is not coming in and potassium is leaking out. That's why we have downward projection of this graph, right? The positive ions are leaking through. Okay. Then we have phase 4, resting potential, high potassium permeability through the potassium channels. Okay, so even though this was about voltage gated channels, even if the voltage gated channels are, right here, they're closed. The potassium channels are closed. Now we still have some that are not voltage gated, and they're still permeable. So you have high potassium permeability through the K channels. So there are K channels over here as well. There are some with that require ATP, but some that do not. So they can flow in and out willingly, I guess, or out in this case. Okay. Again, phase 0. It starts with phase 0 on here. Don't confuse phase 0 with this area. Okay, it's over here. Phase 1 is over here. Phase 2 is here. Phase 3 is closing of all the channels, but the potassium non-voltage gated, so just the normal, channels are still open for that. And then you have phase 4, which is the resting potential. In contrast to, okay, so we went through that. Occurs in all cardiac myocytes except for those in the SA and AV node. These are called the pacemaker action potentials over here. So that's over there. In contrast to skeletal muscles, cardiac muscle potential, action potential has a plateau due to calcium influx and potassium efflux. Okay. Then cardiac muscle contraction requires calcium influx from extracellular cellular fluid to induce calcium release from sarcoplasmic reticulum. Calcium from outside comes in and attaches to this thing. So calcium comes from outside, attaches to the receptor here, that causes release of more calcium into the cell. Okay, so induced calcium release from sarcoplasmic this calcium-induced calcium release. Cardiac myocytes are electrically coupled to each other by gap junction. Okay. Now we are doing pacemaker action potential. It occurs in SA and AV nodes. Key differences from the ventricular action potential include phase 0, upstroke opening of voltage gated calcium channels. Okay, so here the phase 0 is about calcium. Okay, there is no sodium involved up till like phase 4. Okay, it's all about calcium and potassium. Here you'll have sodium funny channels, but here you have calcium. Important to remember that. Here it was about sodium. Here it's about calcium. So, but phase 0 also occurs at the upstroke. Okay, so that's not changed. So upstroke opening of voltage gated calcium channels. Fast voltage gated sodium channels are permanently inactivated because of the less negative resting potential of these cells, results in a slow conduction velocity that is used by the AV node to prolong transmission from the atria to ventricles. Okay. So fast voltage gated sodium channels are permanently inactivated, so you don't have sodium here coming in. When they're saying this, it's we'll talk about it later. Because of the less negative resting potential of these cells. Okay. So results in a slow conduction of velocity that is used by the AV node to prolong transmission from the atria to ventricle. So that's why AV node conducts electricity at a slower pace than SA. Not that it conducts slower, I think it does. It was Park Avenue, something, that thing. We'll do that later. But just remember that phase 0 is about calcium. Then phase 1 and 2 are absent, and then it goes straight to phase 3, which is repolarization. So that's the relaxation one. Inactivation of the calcium channels and increased activation of potassium channels. So then there's increased potassium efflux. So now, since calcium plus potassium positive ones make this more polarity towards the positive, now we have potassium leaking, so it's bringing it back down into the negative, right? You're losing positive ions there. So phase 4 now. The phase 4 are slow spontaneous diastolic depolarization due to funny currents or IF. So funny currents channels responsible for a slow mixed sodium inward potassium outward current, different from funny channels. Different from intracellular sodium in phase 0 of ventricular action potential, accounts for automaticity of SA and AV nodes. The slope of phase 4 in the SA node determines the heart rate. Okay, so if this is faster, it reaches the threshold faster, then it's going to be a faster heart rate. If it reaches slower, then it's going to be slower. So some of the drugs that we have act on this phase right here to prevent or induce heart rate. Okay, so acetylcholine and adenosine, these decrease the rate, right? So if you have someone with supraventricular tachycardia, or supra tachycardia, just like above, like, I don't know, 140 or 60, I think. That's when it has to be above a certain number before you can give this. So this will decrease the rate of diastolic depolarization and decrease heart rate, but catecholamines increases depolarization and increases heart rate. Sympathetic stimulation increases the chance that funny channels are open and thus increase heart rate, right? If they're open more, and then the sodium's going to come in faster, and initiate the threshold to have intracellular calcium come out of the will just come in and cause the action potential. Okay, so we'll learn about the funny channels more when we're doing the drugs, but just remember the difference between the two. So this one, phase 0, is about sodium. This one, phase 0, is about the calcium. That's majority of the time what they're going to test you on. Know about phase 4, that it has a funny current channel. It's just sodium channels and potassium channels, not just sodium. It's sodium inward and potassium outward, right? And this is the one that determines the heart rate, phase 0. Electrocardiogram. Okay, so this is what I was talking about. So don't they have a mnemonic here? They used to have a mnemonic here. Oh, there it is. Never mind. Well, okay. He parks at Ventura Avenue. That's what the mnemonic was. Okay. Electrocardiogram, right? This is a pretty good photo. So conductive pathway. Conduction pathway. So SA node is right there, right? It goes to the atria over here. Okay, when it does that, you get this rise, right? And then when you have this, that's the flat line, right? So when it basically what this graph is going to show is the lines going away or near the nodes, right? So when it's going from this node to this node, you get a rise, a positive line, okay? When it's going from this line, from SA node to AV node, since it's in the same place, you don't get a rise or a decrease in the markings, so it's a flat line. So because it's in the same chamber, it doesn't have to travel through. So when it's traveling through to the other atria, that's the atrial depolarization stage, right? Because this is the signal that's going to tell the atria to contract. Okay, so that's the SA node, and this is called the Bachman bundle, and it's near the, or it's like right next to the pulmonary vein coming into the left atrium. So when it reaches the AV node, right, that's the line. So AV node to, I guess, the bundle branches, that's going to be, wait, the colors are not matching up, but this part is where the AV node sends its signal to the first part of muscle that's going to depolarize, right? Okay, so after that it goes into the septum right here, or whatever, muscular septum. It's called the bundle of His. So from bundle of His, then it reaches the myocytes, right? And this is the myocyte. So that's going to cause a little, when it's going upwards that way, that's the signal going downwards, I guess. And then when it goes into the myocytes, and that causes the upward rise because it's going, into the myocytes over here and the myocytes on this side as well. And then as it reaches here and then comes back up, when it comes back up, that's the downward projection of this line. And then it comes back up and then around. So since it's going this way, direction towards this way, that's the upward motion towards it. Okay? It's not important that you know the components of this. Just know that P is the atrial depolarization. QRS complex is the ventricular depolarization. Okay, and this PR segment is PR interval at the time from the start of atrial depolarization to the start of ventricular depolarization, right? So this segment right here, before this blue line turns red, because red line is what ventricular depolarization is, right? So that's why this thing doesn't match up, but it does, I guess, because this is where it starts contacting with the first myocytes. That's why I was going on about that. Okay, so again, SA node to atria to AV node to bundle of His, right and left bundle branches, and then Purkinje fibers, uh, and ventricles. Right? So Purkinje fibers and then the ventricles. Left bundle branch divides into left anterior and posterior vesicles. Uh, that's just left anterior, and then I guess you have one going to the back, which is the posterior vesicles. SA node located at junction of right atrium and superior vena cava. So that's superior vena cava. So that's where you have SA node. It's important to know this. They'll test you on that. Okay. It's the pacemaker inherent dominance with slow phase of upstroke. Okay. Then you have AV node, which is located in the posterior inferior part of the interatrial septum. Okay, so this is the interatrial septum right there between the two aortas. I mean atrium, and then it's going to be right there. This signal goes through the foramen fossa ovalis. Okay, that's where this thing travels through. And just remember that this AV node is on the interatrial septum. So SVC is for for SA node, and then this one is for AV node in the interatrial septum. Okay. So AV node located in the posterior inferior part of the. So remember that too, because I think they also differentiate between which part of atrial septum. Um, Blood supply usually from right coronary artery. 100 milliseconds delay allows time for ventricular filling. Pacemaker rates. So fastest one is SA node, right? Because that's the one that decides it. So SA node, then AV node, then the bundle of His, and then the Purkinjes, and then the ventricles. So it goes just like that. SA node is the fastest, then the AV node, and then the bundle of His, then the Purkinjes, and then the ventricles. Okay, so speed of conduction is His Purkinjes. So this is faster than the atria, which is faster than the ventricles, because you can imagine ventricles are large, and the kind of ones controlling the ventricles are going to be AV, so that's going to be the slowest. Okay, so when they ask you a question about this, it's important that you comprehend what they're asking, and then they're going to give you some numbers, right? So the smaller numbers are the faster ones, right? So you gotta think about it. So don't rush into it just seeing a bigger number and you pick it, because they're asking about what's gonna be fastest. But the bigger number is not the fastest. The one that has the smaller number, because that's the distance. Like, how would I explain this? So say, because I don't have a question right now for it, but say this is the distance that the signal is traveling, right? So when they won't explain that this is the rate. So then they give you this, and then they give you maybe 0.2. Right? So obviously 0.2 is fastest, but then you have to, figure out that that's what they're asking. They're not asking about the rate, because you're going to think they're asking about the rate, but they're actually asking about the speed of conduction, which is different than the rate, right? So be careful about that. For the speed of conduction, This is a pretty good one that works. He parks at Ventura Avenue. But you can probably make your own one if that doesn't work for you. Okay. So P wave. We're doing this now. That's atrial depolarization. Then you have PR interval. Time from the start at atrial depolarization to start of ventricular depolarization. Normally 120 to 200 milliseconds. QRS complex, ventricular depolarization, normally less than 100 milliseconds. QT interval. Okay, so I'll go through all of them then. So P wave is we already talked about that. PR interval we talked about that. Is the it's important to remember the start of atrial depolarization to the start of ventricular depolarization. Okay. Then we have a QRS complex, which is the ventricular depolarization. These timings are not really that important if you just know what to look out for. But sometimes when you don't know, the timings do come in handy when you're looking at a ECG. But for steps, they don't make the ECGs too complicated, so it's okay. QRS complex, ventricular depolarization. Then you have the QT interval. Okay, so QT intervals, ventricular depolarization, mechanical contraction of the ventricles, and ventricular repolarization. Then what's T wave? It's ventricular repolarization. That's what that is. Okay, so T wave is inversion. Okay, so that's the part where it's coming back. So T wave inversion may indicate a ischemia or recent MI. And J point is junction between end of QRS complex and the start of ST segment. Okay. So the ventricular depolarization and then the repolarization. So this part right here is called the ST segment. Here they give us the QT interval, not the ST. So this is the ST segment. Isoelectric ventricles depolarized. So I guess when it's going back, have the backside, that's the one that's causing this. Isoelectric causes flat line, right? So that's what this line is. So up till here, it's the S, I guess, because it's going towards, like it has an axis upwards. That's why it's going downwards. And then this way, it's going to go that way. I don't want to confuse you with that because it's not important. They don't ask you about that. What they will ask you is this thing right here, pacemaker rates and speed of conduction, and you should know what these waves are because they will test you on the waves. If you should know how to figure out if it's a techie or not. The way I do it, I count the boxes between the R's. So let's see. So you have a ECG, something like this, right? And then you can just count between the boxes. So 1, 2, 3 and a half, right? So when you have 3 boxes, it's usually 100 100 beats per minute, so BPM, right? So basically, if you have 1 box, it equals 300 beats per minute. If it's 2 box, generally it's 150 beats per minute. 3 boxes 100, 4 boxes 75, 5 boxes 60, and 6 boxes is 50 beats per minute. Okay, that's like bradycardia then. So that's how you figure it out. So now we can see if there's a tachycardia ECG. So this is 2 boxes. 2 boxes is 150, right? You just count the number of boxes. So 2 boxes, 150. One box is 300, two boxes 150. Sorry, and three boxes 100. Sorry, so I think I messed it up. One box is 300 beats per minute, two boxes 150 beats per minute, three boxes 100, four boxes 75, then 60, then 50 for six boxes. Okay, you should know how to read that at least. All the other stuff is like you'll figure it out after. ANP, very important. This comes in a lot of systems because this is what controls the volume in our heart and body for that. So it's released from atrial myocytes in response to increase in blood volume and atrial pressure. It acts via CGMP. Remember what CGMP was? It's the one with NO in that diagram. This thing right here. So NO with guanylyl cyclase, GTP, CGMP. It activates protein kinase G. Okay. So CGMP causes vasodilation and decrease in sodium reabsorption. Okay, so it decreases that. It causes vasodilation, decreases sodium reabsorption at the renal collecting tubules. It dilates afferent renal arterioles and constricts efferent arterioles. Okay, so what does that do? Just real quick, you have afferent coming into the kidney, right? It does that, and then it goes, and that's the efferent arterioles. So if you dilate this, right, this, you're gonna have a lot more blood coming through, renal blood flow. But if you restrict this, that means there's resistance. So what does that mean? The blood is gonna pool in this, right? In this area. And it's gonna create a pressure, and this pressure is gonna, push this blood into the tubules for it. Filter, not blood, but like water is gonna get filtered and all that stuff. Because wherever NA goes, water goes with it, and that's how this ANP reduces blood volume, right? Okay. So it dilates afferent arterioles and constricts the efferent arterioles, promoting diuresis and contributing to aldosterone escape mechanism. You should know what that is, but we'll do that in renal. But real quick, it's just since you're losing this much, your renin's gonna get activated, right? So when renin gets activated, what does it do? It activates angiotensin. Angiotensin activates aldosterone. And what does aldosterone do? It reabsorbs sodium and it excretes some potassium, right? So that's why you have the escape mechanism. Even though you're losing sodium, you're not losing so much that it's affecting your, osmolarity, like that. You have just like that ANP. You also have BNP. It's similar to this, but this one is released from ventricular myocytes in response to increase in tension. Okay, so similar physiologic action to ANP with longer half-life though. So this one lasts longer than ANP. BNP blood test used for diagnosing heart failure. Very good negative predictive value. Okay. So if you suspect, CMI or something, the first thing you're gonna do is what? CKMB, right? Those are the cardiac markers for that. If this person is known to have heart conditions, then you're gonna do CKMB plus BNP just to figure it out. If you know this person's still suffering through hypertension and all that, then this is something you will, ask to get as well. baroreceptors and chemoreceptors. Uh, Also troponin, not just CKME, but also troponin. Baroreceptors and chemoreceptors, so afferents and efferents. Okay. This is an important thing as well because they test a lot about your understanding on this whole thing. So I'll go through this, and if I feel like there's something to fill in, I'll do that. Receptors. So you have aortic arch, transmits via vagus nerve. Okay, so that's the aortic arch. This is the vagus nerve, 10th nerve. Okay, and this is an afferent one. Okay. So aortic arch transmits via vagus nerve to solitary nucleus of medulla. Responds to changes in BP. Okay. Just a sec. Let me add something here, and then we can just look at that. Decrease stretch and decrease baroreceptor firing. Okay. This leads to sympathetic response. Okay. And then when you have increase in stretch and barrel firing, it parasympathetic response. Okay. Let's make this a different color. Okay. So that's just a guide, so we don't get confused when reading this. Okay. So this is afferent for aortic arch. Then you have carotid sinus. That's up here in the carotid. So carotid, you can imagine, is in your neck, right? So right before it enters the head, it splits into external and internal carotid arteries, right? And right before it does that, you have a carotid sinus. So carotid sinus, dilated region superior to bifurcation of carotid arteries, transmits via glossopharyngeal nerve to solitary nucleus of medulla, response to the change in BP. You have a question about this guy wearing a very tight collared shirt and then he's getting syncope. It's because of a stretch of this, right? So stretching of that causes what? Parasympathetic response, right? Because that means that your brain thinks that there's so much pressure in here that the vessels need to dilate to decrease this stretch. So it's what does dilation or relaxation of the thing is parasympathetic system, right? So that's why there's lower in blood supply basically, which causes the syncope, even though the person's not needing it. So that's why he feels that. If he was doing something that actually required, he wouldn't have the syncope, right? So that's where this comes in. So remember, that's because of glossopharyngeal and not vagus. For some reason, a lot of people pick this answer, but it's gonna be glossopharyngeal. Chemoreceptors. You have peripheral. Also, glossopharyngeal is typically known for the tongue and back of the throat supply of the muscles. chemoreceptors, peripheral, carotid, and also this is also there in the back of the throat. So this is I think afferent deferent for gag reflex. Alright, back to this. So you have chemoreceptors and baroreceptors. Chemoreceptors is about the chemical. So with chemical, it's about carbon dioxide. With baroreceptors, it's about the stretch and the pressure. So that's what that is. Okay. You have chemo and baro both at each site. So it's not like you only have baro here and chemo here or anything. You have chemo and baro at both the sites. Okay, so chemoreceptors, peripheral, carotid, and aortic bodies are stimulated by increase in carbon dioxide, partial pressure of carbon dioxide, right? So that means there is a decrease in pH because this determines what? The acidity, right? So decrease in pH is acidic of blood and decrease in PO2. So again, it's a closed system. If PCO2 increases, PO2 decreases, and vice versa. Then you have, so less than 60. Then central. In central are stimulated by changes in pH and PCO2 of brain, interstitial fluid, which in turn are influenced by the arterial CO2 as H cannot pass the blood-brain barrier. Do not directly respond to PO2. When it has PO2, it's pretty chill, right? Like, yeah, we got oxygen, we don't have to worry about it. But when it starts getting CO2, it starts panicking because, like, why is the waste product not leaking out, right? Or going through? Like, imagine you have a trash day and then the garbage pickup people don't come. You're gonna start panicking, right? Okay, that now you have to deal with more garbage in your house. So PCO2 is a waste product and brain wants to get rid of it, right? So central are stimulated by changes in pH and PCO2 of brain interstitial fluid, which in turn are influenced by arterial CO2 as H cannot pass, H ions cannot cross the blood-brain barrier. Do not directly respond to PO2. Right. Central chemoreceptors become less responsive with chronically increased PCO2. For example, COPD. Right. So in this case, it's like, okay, the garbage pickup people are not coming, right? So at first you're gonna panic for like a day or two, but then you're gonna get like tired of panicking, and then you're just gonna relax and it's like it's okay, whatever. I'm not even bothered, right? You're just gonna lie to yourself. For example, COPD, right? So then what happens is it then increase in dependence on peripheral chemoreceptors to detect decrease in O2 to drive respiration. Okay, so for central, that's what it's about. Then it starts going back to this, and because this one gets stimulated by increase in PCO2 and decrease in PO2, right? This one does not directly respond to PO2. It only responds to increase in PCO2, right? So that's why there's an increase in dependence of that and peripheral one for the central one in COPD. Hopefully that made sense. Baroreceptors, hypertension, decrease in arterial pressure will cause decrease in stretch and decrease afferent baroreceptor firing. Okay, so decrease in stretch and decrease in baroreceptor firing. Here, the brain's gonna think, why is there no blood in the vessels, even though there is blood, but there's no stretch, right? So what's it gonna do? It's gonna, do the sympathetic response, the fight or flight response. So it's gonna vasoconstrict and all that stuff. Whereas here it's about vasodilation. So vasoconstriction and all that stuff's gonna happen, right? So you have hypotension, so that is decrease in arterial pressure, decrease in stretch, which will cause decrease in afferent baroreceptor firing. Okay, So decrease in stretch means decrease in baroreceptor firing, right? This is important right here that you understand this. That's why I wrote this out. That decrease in stretch and decrease in baroreceptor will give you efferent sympathetic firing, right? Efferent sympathetic firing is the efferent ones coming in, like this dark green one, right? This one is parasympathetic. So this one's going to come in, it's going to go to the blood vessel to vasoconstrict, and it's going to go to the heart to pick up the heart rate and stuff. Okay, so increase in efferent sympathetic firing and decrease in efferent parasympathetic stimulation, right? So it inhibits this, basically, whatever this is doing, because this one's the one that relaxes you, or you have parasympathetic response when you're relaxed. So it's gonna inhibit that. So this will lead to vasoconstriction, increase in heart rate, and increase in contractility, and increase in blood pressure. Why blood pressure? Remember B1. B1 acts on heart rate, contractility, and renin. It acts on kidney as well, so that as well. And BP increases because of vasoconstriction as well, and the volume increases as well. Okay. So important in the response to hypovolemic shock. Okay. So this is the thing that keeps you going and during hypovolemic shock. Carotid massage. So what is that? It's increased carotid sinus pressure. So increasing afferent baroreceptor firing. So you get increase in AV node refractory period. So when you have decreased firing, it's sympathetic. So what happens for the opposite? If you have increased stretch and increased baroreceptor firing, it's going to give you parasympathetic vagus nerve response. Okay, so carotid massage, increase in carotid sinus pressure, increase in afferent baroreceptor firing through glossopharyngeal nerve. Okay, not vagus, through glossopharyngeal nerve. So increase in AV node refractory period leads to decrease in heart rate and decrease in cardiac output. That's your parasympathetic response. Also leads to peripheral vasodilation. Okay, because that's what it means to have a parasympathetic response there, right? Can cause pre-syncope or syncope, right? So this is the one I was talking about. A person wearing a tight collar, it's so tight that it's actually giving him a carotid massage, right? And when that happens, he's gonna end up with syncope or pre-syncope. Exaggerated in underlying atherosclerosis, prior neck surgery, and older age. They also do this for someone who has SVT, right? Supraventricular tachycardia. They tell them to do a carotid massage, so it lowers their heart rate. Okay. Component of Cushing's reflex, triad of hypertension, bradycardia, and respiratory depression. Increase in intracranial pressure constricts arterioles. Okay, the Cushing's reflex, we come across it in CNS as well. They explain it much better there. But overall, it's the triad of hypertension, bradycardia, and respiratory depression. So why does this happen? It's the increase in intracranial pressure which constricts arterioles, right? Because of this, when this happens, we give 100% oxygen to the person, right? And intracranial pressure increases, or even in damage by itself. As a EMT, that's what they would do. For paramedics, that's what they would do. If they found someone with a head injury, they give them 100% oxygen. Okay, so that it's not just that, it's also because of respiratory depression, so that's why. Okay, so increase in intracranial pressure constricts arterioles, which leads to cerebral ischemia, right? Because they don't have the oxygen now reaching, so they'll have increase in the waste product, which is increase in PCO2, and this causes acidosis, so a decrease in pH, which causes central reflex sympathetic increase in perfusion pressure or hypertension, right? Because now um, the brain's trying to send signals to, get some blood in here and get this waste product out. So it's going to increase sympathetic reflex response. Right? So this causes increase in stretch, though, and then what's that going to do? It's going to do peripheral reflex baroreceptor, and then that's going to induce your bradycardia. And that's how you end up with bradycardia in increased ICP. Okay. Uh, if this gets complicated, go back to this mantra, right? So decreased strength and decreased baroreceptor firing, sympathetic response. Increase in stretch and baroreceptor firing, that's parasympathetic. Because you'll remember if this is going to be stretched or not, but then you're not going to remember if this is, baroreceptor fire during stretch, or do they decrease in baroreceptor firing when they decrease in stretch. Okay. So just remember this whole thing. So increase in stretch and baroreceptor causes parasympathetic. Decrease in stretch and baroreceptor causes sympathetic. Okay. Now normal resting cardiac pressures. The values change from before. Okay. So this value changed. This value changed. Right. And these values, both of these changed. I think. It used to be 110 by 90 or something like that. Anyways, normal resting cardiac pressure, pulmonary capillary wedge pressure, PCWP, and mmHg is a good approximation of left atrial pressure, except in mitral stenosis when pulmonary capillary wedge pressure is more than LV, and diastolic pressure, PCWP, is measured with pulmonary artery catheter. Okay, so what this means, pulmonary capillary wedge pressure, it's basically just the pressure in left atrium. Okay, so right before it enters that, so right before it comes in over here, right? So this and then this and this thing, they look like wedges, right? Because of this empty spot right here. This, if you colored this up, it looks like a wedge. Okay, so that's where the name, I think, comes from. Don't quote me on it, but it makes sense. So whatever pressure is created here, it's, oh wait, this is going into the lungs, sorry. So similarly, just like this, when it's coming in, the pulmonary veins, it's gonna make, arteries are coming in like that, exact same thing. And it makes this wedge, right? So that's why it's the same pressure as left atrium. So for clinical purposes, they're the same. So to check that, what do? They put in the catheter in the pulmonary artery through the left atrium anyways. Okay, so that's why this is a good approximation of left atrial pressure, except for in mitral stenosis when left atrial pressure is more than the left ventricle's pressure and diastolic pressure. Okay, so it's measured with pulmonary artery catheter, and you need to know what these are. So this is gonna, a pressure in right atrium is gonna be less than 5. In right ventricle is a little more, 25. Systolic and diastolic is less than 5. Right. Obviously, diastolic is gonna be whatever this is, right? Because diastolic is the filling stage. So whatever pressure the atrium gives is gonna be the diastolic for the ventricle. Similarly here, if it's 12 here, diastolic is gonna be 12 here as well. Okay, so it goes in. The systolic is what's gonna push it into the artery, right? So the systolic here is gonna be the systolic in the artery as well. Similarly, systolic here is gonna be systolic in the aorta as well. Okay, so it pushes in, and the diastolic is a little more than the, a little more than this. Although, why its diastolic is low is because you gotta remember that it's getting split, right? There are two sides to it, so it's halved, plus the it looks big here, but actual chamber is like this big, and then this is gonna be your pulmonary artery, right? That big. So all this pressure going through here, that's what it is, and it's getting split. So the resistance in here is also going to take away a little bit of diastolic pressure. Okay, and then obviously it splits into like all these capillaries or like different pathways. Not important to know the whole thing about that, just know that these values. So 5, 25 5 by 5, 25 by 8 goes in. The capillary wedge pressure is anywhere from 4 to 12. It comes in but less than, 4 to 12 or less than 12. That's going to be the diastolic for the left ventricle, so 120 by 12, and that's how you get 120 by 80 blood pressure from the aortic arch. Okay, cool. Next. Autoregulation, how blood flows to an organ remains constant over a wide range of perfusion pressure. Okay, so organ factors determining autoregulation: lungs, hypoxia causes vasoconstriction. Okay, this is the only important one because all the other ones are going to vasodilate during hypoxia. And we'll learn about that in recipe. Heart, local metabolites, vasodilatory. That's nitric oxide, carbon dioxide, and decrease in O2. They're all gonna, vasodilate there. Brain, local metabolite, vasodilatory. CO2, we just did that. Kidneys, myogenic, stretch reflex of afferent arterioles and tubuloglomerular feedback. I don't remember this one. You have skeletal muscles, so local metabolites during exercise, vasodilatory, carbon dioxide, hydrogen, ion, and then you have adenosine, lactate, and potassium. At rest, sympathetic tone in arteries. Skin, sympathetic vasoconstriction, most important mechanism of temperature control. The pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction so that only well-ventilated areas are perfused. In other organs, hypoxia causes vasodilation. How much time left? 4 minutes. Okay. So this is important to know about the lungs because this is the only organ where vasoconstriction hypoxia causes vasoconstriction, because it has 3 parts to it, right? And the apex part has wasted ventilation, and the base has the wasted perfusion part, right? So when you're exercising, everything becomes 1-to-1 perfusion and ventilation, so there's no mismatch there, right? In hypoxia, what happens is there is a mismatch. So when you have hypoxia, the brain kicks in and it tells the lungs to vasoconstrict the parts that are not getting oxygen because they're pointless. Things are not getting perfused there or exchanging gas there. So then the parts that do get exchanged, the blood flow increases through that area, and that's why you hyperventilate, because you're trying to get in oxygen more into the bloodstream. That's why you hyperventilate. Okay, that's the only important one. All the other ones, they don't really ask about it. Just know the local metabolites during exercise. You have lactic acidosis buildup. You have carbon dioxide. You have acidosis, so wherever you have acidosis, you have increase in H ions. Adenosine is something you might not remember, so put an effort to remember that one. And then potassium, obviously, because it gets exchanged for H ions. Okay, intracellularly. This one, then in acidosis, I think there's a shift of potassium intracellularly for exchange of hydrogen ions. Okay, so capillary fluid exchange. Starling forces determine fluid movement through capillary membranes. Okay, so you have a capillary right here. There are 2 types of pressure. Okay, one is capillary hydrostatic pressure, and then you have hydrostatic pressure and you have oncotic pressure. Okay, oncotic pressure pulls the fluid towards itself, and hydrostatic pressure pushes the fluid away from itself. Okay, So when you have capillary hydrostatic pressure, it's moving the fluid away from the capillary. And when you have plasma or capillary oncotic pressure, it's pulling the fluid towards it. Okay. Similarly, interstitial is just outside the capillary. So if you have increase in interstitial hydrostatic pressure, this one is moving the fluid into the capillary, and interstitial fluid oncotic pressure is moving the fluid fluid out of the capillary, right? So capillary hydrostatic pressure pushes fluid out of the capillary. You have capillary here. This is the hydrostatic pressure going outwards. Okay, this thing right here. Okay. So if you have, this, I don't know how to read this, but I can explain this. So I already did that. It pushes fluid out of the capillary. Interstitial hydrostatic pressure pushes fluid into the capillary, right? Because this is from outside, so this is the interstitium, so it's going to push into the capillary. Then you have plasma oncotic pressure. So oncotic pressure is the one that pulls fluid into the capillary, because it's in the capillary. But if it was outside the capillaries, then it's going to pull the fluid outside of the capillary, because this is the interstitial fluid oncotic pressure, right? So the net fluid flow is just the Kf, which is the capillary permeability to fluid constant, and that times the capillary hydrostatic pressure minus the hydrostatic pressure of the interstitium. So whatever you have left over is the amount of pressure there's left, right? So say you have more here and then less here, then you're gonna have more hydrostatic pressure from coming inwards. But if you have more here and less here, then you're gonna have a positive number or whatever. Never mind. You just have the difference here, and then you subtract the oncotic pressure of the capillary and interstitial, and that's going to tell you which way the net flow is. Alright. They won't test you on the formulas, but they will test you on your knowledge of this. They will test about your knowledge on your understanding about the pressures, and this is going to come in renal a lot, in the glomerulus. When you have increase in renal blood flow, when you have dilated arterioles, and then afferent arterioles and constricted efferent arterioles in the renals, then what happens? The interstitial fluid increases, right? Or the capillary one increases, so then it pushes fluid out of the capillary into the interstitium. And then that's how that whole thing works. Okay, so Kf is capillary permeability to fluid, and then you have oncotic reflection coefficient, so measure of capillary impermeability to the protein. Okay. Edema, excess fluid outflow into the interstitium, commonly caused by increase in capillary pressure, right? That will increase the hydrostatic pressure. Increase in capillary permeability, so increase in Kf, which was the capillary permeability fluid. For example, toxins can do that, infection can do that, burns can do that. Right? Infection causes what? Increase in neutrophils. Neutrophils cause permeability to increase, so that then can be transmigration and all that stuff as well. Then you have increase in interstitial fluid oncotic pressure, increase in that. For example, lymphatic blockage. And then you have decrease in plasma proteins, and that is nephrotic syndrome or liver failure. Liver failure because liver is the one that makes or synthesizes the plasma proteins. Nephrotic syndrome because it's the leakage of protein, so you get proteinuria in that. And then also if you don't have any eat that much protein, so malnutrition because of that. Okay. So if you just remember, hydrostatic pressure pushes, and then oncotic pressure pulls, and then wherever it is, so capillary, it's going to push the fluid out of the capillary. If it's interstitium, it's going to push it into the capillary. If it's plasma, again, it's going to pull into the capillary, and if it's interstitial, then it's going to pull out the fluid. Okay. We're on to pathology now. We're going to do the shunts. So congenital heart disease, right to left shunts. These are easy to remember because it corresponds with the number 1, 2, 3, 4, and 5. Okay. So what is right to left shunts? It's early cyanosis or blue babies, often diagnosed prenatally or become evident immediately after birth, usually require urgent surgical treatment and or maintenance of PDA. That's patent ductus arteriosus, right? So this is when you would give what? Prostaglandins, because prostaglandin keeps it patent. So the 5 T's. One, truncus arteriosus, right? So let's read about that. Persistent truncus arteriosus. This is truncus arteriosus fails to divide into pulmonary trunk and aorta due to failure of aortico-pulmonary septum formation. So most patients have most patients have accompanying VSD. So this is why you would get mixture of both oxygenated and deoxygenated going into the system. Okay. 2, you have transposition. Okay. So truncus arteriosus. Let me just show you a photo of that. So this thing right here, right? So this it's supposed to divide between the two, right? This need to split, and then you would get different aorta and a different pulmonary artery. But here it didn't separate, so now you have both a right ventricle going straight into the aortic arch, right? Maybe a little going here, and then it's coming here, and then this will push in as well. But if it has VSD, then you get mixing of the two bloods as well, so it further gets saturated, like with deoxygenated blood. So then you get purple blood going through. That's why you get cyanosis. Okay. Then you have 2 for transposition, which is 2 switched vessels. So this is the one with closed system, right? Detransposition of great vessel arteries. So because of this, you would try to keep patent ductus arteriosus, because that's the only way you can get oxygenated blood going into the system, because right now it's a closed system. What this is aorta leaves the right ventricle, right, instead of the pulmonary artery anterior, and pulmonary trunk leaves the left ventricle instead of the aorta or the posterior. So separation of systemic and pulmonary circulations not compatible with life unless a shunt is present to allow mixing of blood, right? So VSD would do that too. That would cause mixing of blood. PDA would allow some blood to go into the oxygenated blood to go into the system as well, or patent foramen ovale. So that's between the atriums. That will also allow that. Due to the failure of the aorticopulmonary septum to spiral. Okay, so egg on a string. Appearance on chest X-ray. So that's what it looks like an egg, right? So yeah, without surgical intervention, most infants die within the first few months of life. Okay. 3, you have tricuspid atrasia. Okay, so tricuspid atrasia. Absence of tricuspid valve and hypoplastic right ventricle. Requires both atrial septal defect and ventricular septal defect for viability. Okay, so that's just absence of tricuspid valve and hypoplastic, because there's nothing to do, right? So what happens when a muscle doesn't work? It gets atrophied, right? So hypoplastic right ventricle requires both ASD and VSD, because then this way it's gonna go from right atrium, right atrium to the left atrium, then left atrium to left ventricle, and left ventricle to the right ventricle to go into the pulmonary trunk, right? So that's why you need both ASD and VSD for viability. Then you have tetralogy of Fallot. This is a famous one. You should definitely memorize this one. Caused by anterior superior displacement of infundibular septum. Infundibular septum. Most common cause of early childhood cyanosis. 1. So you get 4 things, right? You get pulmonary stenosis, you get right ventricular hypertrophy, overriding aorta, and ventricular septal defect, right? So the pulmonary stenosis is this one right here. So right ventricular hypertrophy is this thing right here, and then you have overriding aorta, right? So this is the aorta, and pulmonary trunk is going through it right there. So I guess that's what it is. Hold on. Overriding aorta, I need to check that one out. Yeah, okay. So pulmonary stenosis and okay, that's what it is. So this is the pulmonary trunk, this is the aorta, and then the VSD is right here, right? So when this thing pushes, it can go from here or it can go from here, and there's mixing of blood here as well. Okay, so that's what the overriding is. This thing is just too farther down, but essentially what it is that through the VSD it can go straight out as well. So to prevent that, what you do is squatting, because squatting does what? It does 2 things. It increases preload because it's closer to the legs, so legs venous return is increased, but it also creates a problem for the aorta because it increases systemic resistance, right? So systemic vascular resistance increases, so that will cause what? It will decrease this right to left shunt, and it will give some power because of the resistance to the left ventricle, because now instead of going through this, it's going to go through here. So now instead of going from here to here, it's going to go from here through here, because now there's resistance here, right? So it's going to go from here to here, and then now what's going to happen when this one goes and this one's pushing back, right? So it can't go through the VSD, it's going to actually go through the pulmonary trunk this time. Okay, and this is why people with or kids with tetralogy of Fallot, they squat and to make themselves feel better. Okay, so let's read this now. Caused by anterior superior displacement of infundibular septum, most common cause of early childhood cyanosis. Pulmonary infundibular stenosis, most important determinant for prognosis. Right ventricular hypertrophy, boot-shaped heart on chest X-ray. Remember this because they might just give you a photo of this, and don't confuse it with this one. Okay. Pulmonary stenosis, overriding aorta, and ventricular septal defect. Pulmonary stenosis forces right to left flow across ventricular septal defect, which causes right ventricular hypertrophy, hypertrophy. TED spells. This is important because they will describe what TED spells is, and they won't tell you that it's spells. It's often caused by crying, fever, and exercise due to exacerbation of RV outflow obstruction. Okay, so that's what causes TED spells. It's described as the baby or infant having cyanosis when they cough or cry or something like that. So again, it's squatting increases systemic vascular resistance, decreases right to left shunt, improves cyanosis. Associated with DiGeorge syndrome, this is DiGeorge syndrome, 22q11. Okay. Then you have number 5, TAPVR, 5 letters, right? So that's total anomalous pulmonary venous return. Pulmonary veins drain into the right heart circulation and superior vena cava, coronary sinus, etc. Okay, so pulmonary vein drain, SVC, coronary sinus, etc. Associated with atrial septal defect and sometimes PDA to allow for right to left shunting to maintain current. Let's look up a photo of this. Okay, so the pulmonary vein is coming in and it's going into the, okay, so it's going straight into the superior vena cava. That's what it is. Instead of going into, the left atrium, it's going into the superior vena cava, and it's mixing with the deoxygenated blood, and then that's the blood that goes into this part, and then it's going back in. Where's this blood coming from? Oh, okay, ESD, that's why. Got it. Cool. So it's associated with ESD then. Okay. And sometimes PDA to allow for right to left shunting to maintain the cardiac output. Okay. Epstein anomaly. Displacement of tricuspid valve leaflets downward into right ventricle. Artificially atrializing the ventricle. Associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. So we already went over this, but I'll show you the photo for this as well. Happens because of lithium. So now you have, normally this is where it is, and now it's down here, like that. That's truncus, but yeah. Everything else is similar. Left atrium, left ventricle, aorta is right there. Pulmonary artery is right there. And this is the right ventricle. So you see how big the right atrium is compared to the right ventricle. Normally it's the other way around, right? So atrializing, sorry. So displacement of tricuspid valve leaflets downward into right ventricle. Artificially atrializing the ventricle associated with tricuspid regurgitation, accessory conduction pathway, and right-sided heart failure. It can be caused by lithium exposure in utero. Okay. Now we're going to do the left-right shunt. So it's acyanotic at presentation. Okay, so they look normal. Cyanosis may occur years later though. Okay, and that's how you remember this. So frequency is VSD more than ESD more than PDA. So right to left shunts, RL is for early cyanosis and LR is for later cyanosis. So if you have a cyanosis in an infant, it's not going to be one of these causes. It's going to be one of these causes, right? So you can just make an assumption that it's a right to left shunt by the cyanosis is happening. But if the cyanosis is happening in like a 20-year-old or something, it's going to be because of this. Sometimes they stay asymptomatic as well, right? That's possible as well. So, okay. Ventricular septal defect. Asymptomatic at birth, may manifest weeks later or remain asymptomatic throughout life. Most self-resolve. Larger lesions, like that, That's where the septal defect is. So the blood from oxygenated blood from left ventricle is leaking into the right ventricle. So it's may lead to left ventricular overload and heart failure because it keeps on getting more and more and more fluid coming into left ventricle, right? So eventually the muscles are going to give up and then it's going to go into heart failure. O2 saturation is increased in right ventricle and pulmonary artery. Right, because now normally it would have like a 2% oxygenation returning from the venous return, but now it's getting this added to the venous right ventricle. So the oxygenation of saturation of RV is now increased to like 10. Right, they ask questions like that. That there's ESD, so where would you see oxygen saturation increased in areas compared to a normal heart, something like that. Atrial septal defect is right there. That's because of failure of septum primum and secundum or something like that, not fusing together, so the ostium secundum stays open, right? Okay, so defect in interatrial septum, wide, remember wide for wiper, fixed split S2, right? So that was FA. Okay, ostium secundum defects, most common and usually an isolated finding. Sorry, I was just trying to remember what this one was. W was for white. It was pulmonary something, right? Yeah, pulmonary stenosis. And FA is for ASD, fixed ASD. Okay. S2. Ostium secundum defects, most common and usually an isolated finding. Ostium primum detects rare and usually occur with other cardiac anomalies. Symptoms range from none to heart failure, distinct from patent foramen ovale, which is due to failed fusion. Right? Okay, so what I said was wrong. Distinct from patent foramen ovale, so which is due to failed fusion. Okay, so this one is ostium secundum defects, most common and usually is isolated finding. Ostium primum defect rare. Okay, so it's about secundum, so they might ask you that. And atrial septal defect, they might ask you what's the most common defect and cause or most common cause of this. So it's a defect in secundum. This one is rare, so but other cardiac anomalies. Okay, symptoms range from none to heart failure, so everything can happen or nothing can happen as well. Okay. Now O2 saturation is increased in right atrium, right ventricle, and pulmonary artery as well. May lead to paradoxal emboli. Remember I explained that. Systemic venous emboli use ASD to bypass lungs and become systemic arterial emboli associated with Down syndrome as well. You have pene ductus arteriosus over here. In fetal period, shunt is right to left, normal. In neonatal period, decreased pulmonary vascular resistance, so it leads to shunt, becomes left to right, progressive right ventricular heart hypertrophy and or left ventricular hypertrophy and heart failure. Associated with continuous machine-like murmur, you need a patent for this machine. Patency is maintained by PGE synthesis and low O2 tension. Right, prostaglandin. So you give endomethacin to close this synthesis and low oxygen tension. Uncorrected PDA can eventually result in late cyanosis in lower extremities, differential cyanosis. Okay, so you need to know this right here. uh, they will give you a patient who has blue toes but not, fingers, and then they'll tell you they did a Doppler ultrasound and they found no thrombus or anything, because that would be your first thought, right? That there's occlusion somewhere. But then they ruled that out. So then you need to remember, okay, so PDA does this, and it usually happens later in life. So there are chances that it's PDA. So it's how do you get there? It's that because uncorrected PDA can eventually result in late cyanosis and lower extremities. Okay, PDA is normal in utero and normally closes only after birth. Eisenmenger syndrome, uncorrected left to right shunt, VSD, ASD, and PDA will lead to increase in pulmonary blood flow, which leads to pathologic remodeling of vasculature, which leads to pulmonary arterial hypertension. Okay, so basically what's happening is because of this, there was left to right before, but then that built up, that made this work more, and then there was right ventricular hypertrophy, and now there's right to left shunt instead of the left to right. So uncorrected left to right shunt in VSD or ASD or PDA increases pulmonary blood flow, right? Pathologic remodeling of vasculature, this is the problem right here. Pulmonary arterial hypertension, right? So that's what you get because of more flow. So right ventricular hypertrophy occurs to compensate, which leads to shunt becomes right to left when right ventricle pressure is more than the left ventricle pressure. So then, yeah, when this thing has hypertrophy, that's what happens. The pressure in right ventricle becomes more than the left ventricle. This causes late cyanosis, clubbing, and polycythemia. Age on onset varies depending on size and severity of initial left to right shunt. So that's why, yeah. So Eisenmenger, if you have VSD or something, you have to keep this in mind that it could be Eisenmenger. So what happens in that? You get backflow. When you get this and this pushes, it also actually pushes into this as well. So you could have tricuspid regurgitation because of VSD as well. Okay. Coarctation of the aorta, aortic narrowing, right there. So near insertion of ductus arteriosus, so this is just ductal, associated with bicuspid aortic valve, other heart defects, and Turner syndrome. Hypertension in upper extremities, lower extremities are cold with weak, delayed pulses, brachiofemoral delay with age, intercostal arteries enlarged due to collateral circulation arteries erode ribs. This causes notched appearance on chest x-ray. Complications include heart failure, increase in risk or cerebral hemorrhage, berry aneurysm, aortic rupture, and possible infective endocarditis. Okay, you know what? I think this is the last topic I'll do for today because I keep zoning out now and I think I'm done for the day. So we'll start tomorrow from 306. I'll finish this and we'll continue from tomorrow. So again, this is an important topic, coarctation of the aorta. Aortic narrowing happens, right? So that's this thing right here. Okay. Let's see the photo for this. Okay, so ductus arteriosus is here, and coarctation is happening here after it. But if it happens before it, it's called preductal, and they both have different symptoms. So aortic narrowing near the insertion of ductus arteriosus, just a ductal, associated with bicuspid aortic valve and other heart defects and Turner syndrome. Hypertension in upper extremities. This is important, right? So why are you getting hypertension in upper extremities, right? And lower extremities are cold but with weak delayed pulses. Yeah, bicuspid aortic valve. It's actually right here, right here. The Turner syndrome. Which diagram? Over here. Oh, that would be down here. So if you were looking at here, this is the bicuspid valve right there. All right. Yeah. Okay. So no problem. Okay. So where was I? Right. So hypertension in upper extremities. Why do we get that? So when you have, it's because the upper limb is supplied by these arteries up here, right? Uh, so you have 120 mmHg of pressure coming in, and it's getting pushed into these arteries, right? And you have 120, and these are smaller arteries, so you're gonna have more pressure in there compared to these, right? Even though it's splitting, it's this is known as the great vessel, right? So that's why you have a higher uh, systolic pressure in the upper extremities or hypertension because of that. And all the pressure then, whatever is leaking through is going to be less than whatever is in here, right? That's why you have different pulse. There's a pulse difference between the upper extremities and the lower extremities, because there's the descending aorta goes all the way down up to the iliacs and then it splits, right? So that's why hypertension in upper extremities. Lower extremities are cold with weak. Cold because blood is the one that provides the warmth from the core. With weak and delayed pulses, because the pulse doesn't reach fast enough because the blood is not reaching fast enough. Okay. And delayed pulses, brachiofemoral delay. With age, intercostal arteries enlarge due to collateral circulation. Arteries erode ribs, right? So this is an important sign as well. So let me see if I can show that. Okay, so you're gonna get something like this, a photo like this, and then you gotta pay attention to this as well. They'll give you symptoms uh, that there are different. There's a pulse difference between the brachial and the femoral, and they'll tell you there's Doppler didn't even pick up any thrombus or something. Hold on. I'm gonna mute you for now, and then I'll unmute you after this. Okay. So they'll give you that, and then they'll give you that this is, sorry. Okay. So they're gonna tell you that the ribs they have cavitations inside or like linear uh, erosion in it, and this only happens because of this. The erosion happens because of this. The cord, sorry, the vessels forming there, because since uh, the pressure is not reaching to those areas, they're forming new vessels to make collateral circulation. Okay, and this is what's eroding the ribs. So you have the notched appearance on chest X-ray. Complications include heart failure, increase in risk of cerebral hemorrhage, because you have a lot of blood going back into the head, right? From the from here into the carotids, the common carotid to the stuff, and the head is not used to that much pressure. So, and you can have berry aneurysm, you can have aortic rupture, and possible infective endocarditis. Okay. I think that covers it. We'll look at a better picture for this though. So like that, right? They might give you a X-ray, or they might just describe it that the ribs are, they have some kind of thing going through it, or there's erosion of the ribs or something like that. They'll tell you that stuff. All right, I'll end it. Congenital cardiac defect associations. Uh, these come in handy when you gotta think quick for an answer, if you remember these. So associations and defects: prenatal alcohol exposure, fetal alcohol syndrome, uh, ventricular septal defect, patent ductus arteriosus, and atrial septal defect, and tetralogy of Fallot. Right, almost everything you can think of in the heart, you can have it in prenatal alcohol exposure. Congenital rubella, you get PDA, pulmonary artery stenosis, and septal defects. Uh, Septal defects. So that's also VSD and ASD, PDA, and pulmonary artery stenosis. Okay. Down syndrome is AV septal defect, endocardial cushion defect, VSD, ASD, again, septal defects. Infant of patient with diabetes during pregnancy. This is important. Uh, Transposition of great vessels, truncus arteriosus, tricuspid atresia, and VSD. But they usually ask about the GIT system. You'll see that the infant has enlarged pancreas, I think. We'll do that in GIT. Marfan syndrome, MVP, thoracic aortic, and also the infant's gonna be large. It's gonna be large for its age, kind of thing. Marfan syndrome, MVP, thoracic aortic aneurysm, and dissection, aortic regurgitation. Okay. All of these are important because they'll give you like one of these things in the question stem, and then you gotta figure out that this happens in Marfan's. MVP is the buzzword for Marfan's, as well as dissection, aortic dissection. This one is iffy, and this one is iffy. But MVP and dissection. And then you have prenatal lithium exposure. Prenatal lithium exposure that happens, that causes Epstein anomaly. Turner syndrome, bicuspid aortic valve, coarctation of aorta. This one's important too. This one's with the bicuspid aortic valve, right? Normally it has 3 cusps. In this one you get bicuspid, and then you also have coarctation of aorta. So either of these should hint that it's Turner's. But they'll also give you that the patient has short stature, web neck, or something like that. Williams syndrome, supravalvular aortic stenosis. Let's check that one out real quick. Okay, so it's the ELF one, because you have Will Ferrell in the movie Elf, and this is the one with the Elfian facial features. Supravalvular aortic stenosis. Then you have 22q11 syndrome. That's the DeGeorge syndrome with the thymic dysplasia. DeGeorge syndrome. In that you'll have truncus arteriosus and tetralogy of Fallot. So tetralogy of Fallot, you can find it in alcohol and DeGeorge. Okay. Marfan's MVP, mitral valve prolapse, and aortic dissection. When you have dissection, you probably end up with an aneurysm anyways, or vice versa. And then for Turner's, you have bicuspid aortic valve and coarctation of aorta. Okay. Hypertension. Persistent systolic blood pressure more than 130 mmHg and or diastolic BP more than 80 mmHg. Risk factors are age, increase in age, obesity, diabetes, physical inactivity, high sodium diet, excess alcohol intake, tobacco smoking, family history, incident greatest in blacks, then whites, and then Asian population. Features: 90% of hypertension is primary or essential and related to increase in cardiac output and increase in total peripheral resistance. Right? So, go to that. Remaining 10% mostly secondary to renovascular diseases such as fibromuscular dysplasia, characteristic of string of beads appearance of renal artery. So this is the string of bead appearance. If you see that, it's going to be this. Another place you'll see a string of bead is in vasculitis, pan. Right. So here you also see it in that. Same. That's the same picture, anyways, that they're using, but in this they use the same term. So it's buzzword. It's a buzzword for both of them. String of bead. So it's in here and in pan. Okay. Usually seen in adult females and atherosclerotic renal artery stenosis, or to primary hyperaldosteronism. Hypertensive urgency, severe, more than 180 or by more than 120 diastolic. Hypertension without acute and organ damage, right? So, and then you have emergency, formerly called the malignant hypertension. For this one, you need to know what it looks like because they might give you a photo of that. So that's what it looks like. Notice how there's only this much space left right now. You have hypertrophy of all the layers of an artery. Remember the artery anatomy that we looked at. So again, hold on, let's see. Like that, right? So you'll see an onion layer, and this is, you only see this kind of thing in a malignant hypertension. You won't see it in a normal hypertension, right? In normal hypertension, you only see like hypertrophy of one of the layers. Okay. That's malignant. That's malignant. That's not an artery. That's glomerular. This is well glomerulus. This is just one layer. You can make out the layer differences between the layers, right? So this is one layer right here. Then this is another layer. Then this is the third layer, the external or whatever. Anyways, whenever you see a sclerosing or like onion layer, it's going to be your malignant hypertension. Okay, so formerly called malignant hypertension, severe hypertension with evidence of acute and organ damage, for example encephalopathy, stroke, renal hemorrhage, and exudate papilla edema. This is one of the giveaways. They'll tell you that there's like papilla edema or increased pressure in the eye or something like that. If you have retinal hemorrhage, you gotta look out for that as well. But this also happens in like diabetes kind of thing. So, but not the hemorrhage, right? Oh, okay. I guess that one's like more about the macular degeneration. So retinal hemorrhage and exudates, papilledema, MI, heart failure, aortic dissection, uh, kidney injury, microangiopathic hemolytic anemia, and eclampsia. Arterioles may show fibrinoid necrosis, okay, predisposes to coronary artery disease, um, left ventricular hypertrophy, heart failure, atrial fibrillation, aortic dissection, aortic aneurysm, stroke, chronic kidney disease, hypertensive nephropathy, and retinopathy. So you need to know what hypertension can do to a body, right? Because it's very common, especially because in the packaged food uh, in first world countries, they always have a lot of salt in it to prevent, bacteria growth and to for the taste. So, hyperlipidemia signs, xanthomas, plaques or nodules composed of lipid-laden histiocytes in skin. Okay, so like that, especially the eyelids, like that. These are called xanthomas. Tendinous xanthoma, lipid deposition in tendons, especially Achilles tendon and finger extensors. Then you have corneal arcus. You'll get a photo exactly like this one, and then you gotta figure out that this is because of lipid, not because of something else. So lipid deposit in cornea, common in older adults. So this is called arcus senilis, but appears earlier in life with hypercholesteremia. Okay, so corneal arcus, tendinous xanthoma, xanthoma itself. Right, these are all signs of hyperlipidemia. Then you have arteriosclerosis. Okay, so they show it here. Hardening of artery. So this arteriosclerosis is different than erythrosclerosis because this one is dealing with the vessel itself, the artery. So it's the hardening of artery with arterial wall thickening and loss of elasticity. Arteriosclerosis, common, affects small arteries and arterioles. There are two types. There's hyaline and hyperplastic, right? So thickening of vessel walls, secondary to plasma protein leak into endothelium in essential hypertension or diabetes mellitus. So if you get a hyaline, let's see what that looks like. It's gonna be because of essential. Okay. Like that one. And this one counts as well. Okay. So the three layers, the tunica intima is okay. So the interior layer is the intima, then the medial layer is media, right? Tunica media, and then the last one is tunica externa. Okay, that's the anatomy. So in hyaline arteriosclerosis, you only have thickening of the intima, but in hyperplastic, you'll have it in the whole thing, and it looks like an onion, right? Like that right there, or right there. Okay. Hyperplastic onion skinning. That's this one, and so you can see the difference between two. Here, it's only one layer that's affected, and this is all the layers, and they're essentially just smooth muscles, right? And muscles is basically something. If you stress it, it's gonna grow. That's why you do bicep curls and stuff, right? So similarly, if there's a lot of pressure coming from the blood flow, it's gonna push onto the artery. So initially it's gonna take it, but that's also gonna build up a little bit of resistance, and then it's gonna keep building it up, and then eventually it's gonna start doing it to the other layers as well. That's why you get the thickening. So hyperplastic onion skinning and severe hypertension with proliferation of smooth muscle cells. Then you have Mockenberg sclerosis, also called medial calcific sclerosis, uncommon, affects medium-sized arteries, calcification of internal elastic lamina and media of arteries, vascular stiffening without obstruction, pipe steam, appearance on X-ray. So that right there. Okay. If you see that, it's gonna be Mockenberg sclerosis. So, vascular stiffening without obstruction, pipe steam, appearance of on X-ray, does not obstruct blood flow, intima not involved. Okay, so in here the intima is not involved. So pipe steam, I think that just means like on a chimney coming out, and then the smoke that you see, that's what it looks like. So you can think of a town, Mockenberg, up in the cold hills, and it has smoke coming through and from the chimney, so something like that, I guess. Then you have cholesterol emboli syndrome, microembolization of cholesterol displaced from atherosclerosis. Okay, now we're talking about atherosclerotic plaques. Okay, so microembolism of cholesterol displaced from a plaque and from atherosclerosis in large arteries, usually the aorta, results in end organ damage due to small artery emboli and an inflammatory response. Okay, so you can get livedo reticularis. Let's look at what that is. Okay. Digital ischemia, blue toe syndrome. This is usually the one that you're gonna find on the test, because that's what it looks like. And like I said, the first thing you're gonna think of is thrombus or embolism, right? When you get a extremity gangrene or necrosis. So if you don't, if it's sinus by itself in the initial stages, and they tell you they did a Doppler and they didn't find any thrombus, what's it gonna be? It's gonna be this, right? Because remember, hypertension, lower extremities are cold and weak, and with delayed pulses, so it can have that cyanosis there. Okay, so first you're gonna think of thrombus, but in the questions then they'll tell you that they didn't find any sign of thrombus or anything. Then the next thing you go to is this. The coarctation of aorta. So acute renal failure, cerebrovascular accident, and gut ischemia. Pulses remain palpable because large arteries are unaffected. Okay, so they might even tell you this, right? That the pulses are there, but there's cyanosis. So that could apply to the other one as well, and this one. So you can't rule it out just because of that line. May follow invasive vascular procedures, angiography, angioplasty, and endovascular grafting. Okay. Majority of the time, you're gonna get a microembolization displaced from a plaque due to a fracture or accident in your femur. So if they say the person had an accident and fracture femur occurred, and then like 2 days later he has difficulty in breathing, it's going to be because embolism traveled up to the IVC into the RV through the pulmonary artery, and it got stuck there, and that's why they have difficulty in breathing. Okay. So atherosclerosis, very important. We need to know how this plaque is made. So it's very common disease of elastic arteries and large and medium-sized muscular arteries. Right. So elastic arteries and large and medium-sized muscular arteries. A form of arteriosclerosis caused by buildup of cholesterol plaques in tunica intima, right? So in that one, it's because the muscles are getting big, and here it's because the layer under the epithelial lining or smooth muscle lining, endothelium, sorry, lining, there's cholesterol plaque buildup, which is causing the obstruction in the flow. Right? So, caused by buildup of cholesterol plaque in the tunica intima, the internal layer, right, of the artery. Location: abdominal aorta, most common, and then you have coronary artery, then you have popliteal artery, then the carotid, and then the circus of Willis. So from abdomen, you go to the heart, then the knees, then the neck, and then the head. Okay. Abdo, heart, knees, and neck, then the head. Okay. Risk factors: modifiable hypertension. So modifiable ones are the ones you can take care of, right? So you can, if you have atherosclerosis, you can take care of your hypertension, tobacco smoking, dyslipidemia, because it causes increase in LDL and decrease in HDL, and diabetes. Then the non-modifiable you can't do anything about is age, male sex, postmenopausal status, and family history. Symptoms are angina, claudication, but can be asymptomatic as well. Yeah, so the angina one is the important one. It will come when we do angina. Progression, inflammation important in pathogenesis. Endothelial. Okay, so here we go. This is the progression. Progressing. Why am I having a hard time saying words right now? So this is the pathogenesis. It's gonna start with the endothelial cell dysfunction. So you get like a break or injury or something in the endothelium, right? Then the macrophages and LDL is gonna accumulate there, right? So you have normal artery with the lumen, endothelium, smooth muscles, okay? And then you have macrophages coming at the site of injury or damaged endothelium. And then you, along with the macrophages, you have LDL lipid laden macrophages coming there, right? With the fatty streak and foam cells. So then it makes fatty streak formation, right? This is an important step too. Then you get the fibrous plaque formation. So here you have the smooth cells involved as well. Smooth muscle cells. So smooth muscle migration happens and the fibrous plaque is formed. And the layer over it is going to form as well with the endothelium, and that's why it gets stuck there, right? So that's the plaque right there. You can make out that this is a intima, this is the media right here, the pink one, right? And then you have this layer, the externa. So right in the middle, right in the intima is where it's, or right under the intima, I guess. You can see the plaque. But if they ask you a question, it's going to be in the tunica intima. Okay. Okay, so we have accumulation, and then foam cell formation, then the fatty streak, then the smooth muscle cell migration involves prostaglandin derived growth factor and fibroblast growth factors, proliferation and extracellular matrix deposition, fibrous plaque, and then complex atheromas are formed, and calcification occurs. So calcium content correlates with risk of complications. For this, there's a diagram on UWorld for this. That's pretty helpful. This one right here. to go to that one then. Okay, we'll zoom into this and see if we can figure it out. Okay, we can comprehend this. Okay, so this is the lumen, right? This is the intima layer of the thing, and then this is the media. So we have endothelium dysfunction, right? So there is some kind of problem there. You have macrophages there coming in, as well as LDL, and then the oxidized LDL gets taken up by the macrophage, and then that when the macrophage and LDL gets mixed, it's called foam cell, right? So lipid uptake of macrophages. So foam cell, then the foam cell will, along with the growth factors. The growth factors are which ones? These ones, right? PDF and FGF. Along with that, and the smooth muscle cell proliferation causes the fatty streak, right? So that's the fatty streak right there. So fatty streak is macrophage, LDL. So LDL lane macrophages, the fatty streak, and the foam cell. So it's just the foam cell formation causing the fatty streak, and then the smooth. Okay, so fatty streak happens before the smooth muscle cell proliferation. Okay. You have extracellular lipid and necrotic debris, smooth muscle cell migration, smooth muscle cell proliferation, and cholesterol efflux, or HDL. Okay. Again, we'll do this one more time. Endothelial cell dysfunction. Then you have macrophage and LDL accumulation, and then when you have LDL lane macrophages, they are called foam cell. So foam cell formation happens, right? Then you get the fatty streak. I just need to make sure what this is. Appears when the presence of foam cells at the site of plaque formation expands. At this stage, a lipid core has been formed that will progress into a mature atherosclerotic plaque from additional influx of different inflammatory cell types and extracellular lipids. Okay, so you have intimal T cell puts out the cytokines to make this, and then you have this. Even though we read this much about it, they always figure out a question that has to do with this, and it's something we haven't came across yet. I hate that. Okay, smooth muscle cell migration involves PDGF and FGF. You have then proliferation of the smooth muscles and extracellular matrix deposition. Right, so all of this will cause fibrous plaque. Complex atheromas, calcification, and calcium content correlates with risk of complication. The first cell that comes is macrophage, okay, not monocyte. So macrophage, and then the LDL gets uptake into the macrophage. Okay, aortic aneurysm. Done with atherosclerosis. Aortic aneurysm, localized pathologic dilation of the aorta, may cause abdominal and or back pain, which is a sign of leaking, dissection, or imminent rupture. This is a buzzword for it. A patient who's suffering from back pain. Okay, so that when you have back pain, it can be three things. One, it can be pancreatitis. Second, it can be this thing, aortic aneurysm. Third, it can be ankylosing spondylitis when it's in the lumbar region. Okay, so localized pathologic dilation of the aorta may cause abdominal and or back pain, which is a sign of leaking, dissection, or imminent rupture. Also, heart attack in females would give you back pain as well. Normally you hear about it on the chest, but it can be on the back as well. But for that, they'll give you an ECG or like some kind of CKMB or troponin markers. Okay. Thoracic aortic aneurysm. So associated with cystic medial degeneration. So this is in the medial one, not the intima or externa. And that is being degenerated, right? Degraded, I guess. So risk factor include hypertension, bicuspid aortic valve, because normally you have tricuspid aortic valve, right? So when you have that, there's going to be more pressure, and so basically, okay, aortic valve, connective tissue disease, for example, Marfan syndrome. We did that, right? Also associated with tertiary syphilis, obliterative endarteritis of the vasa vasorum. And this is why in one of the questions they said that when a child was delivered, the umbilical cord had necrosis on it. It's because of syphilis. Syphilis will cause that. Aortic root dilation may lead to aortic valve regurgitation. Okay. So what's happening here normally? Try drawing it out. So when you have an artery like this, right, and there's like a breakage over there, and then you have a normal artery here. So this whole thing is a vessel. This is just one side of the vessel and the other side, and the blood flows through here, right? So sometimes when you have a little bit of a breakage or something here, the blood will go through here, and then every time the heart beats, a pulse comes and it pushes further and further, into the medial layer wherever it was leaking. So it'll keep pushing this, it will keep pushing that, and this will keep going in, and that's how you end up with this medial degeneration of aneurysms. Okay. Actually, I'm talking about dissection, aren't I? I'm not talking about aneurysm. Never mind. Okay. So ignore that. Okay, thoracic aortic aneurysm, again, associated with cystic medial degeneration. So remember that. This is the pathogenesis of aortic aneurysm. The risk factor includes hypertension, bicuspid aortic valve, and connective tissue disease, for example, Marfan syndrome, also associated with tertiary syphilis, obliterative endarteritis of the vasa vasorum. So what does that mean? Vasa is vessel, and vasorum is like around the vessel. So it supplies the great vessels, the capillaries or the capillary network or the artery network around the great vessels. So aortic root dilation may lead to aortic valve regurgitation. Okay, so if this leads over here, and then there are only two cusps of aorta, it's gonna cause this dilation over there, and that's how you get the valve regurgitation because of that. Because imagine this is affecting the layer here too, so that's gonna affect the structural position of the valve as well, causing the regurgitation, right? Abdominal aorta aneurysm. This is the one in the descending aorta. Right? It's associated with transmural, so all three layers, inflammation, and extracellular matrix degradation. Risk factors include tobacco use, increase in age, male sex, family history, may present as palpable pulsatile abdominal mass, arrows in A, point to outer dilated aortic wall. Rupture may present as triad of pulsatile abdominal mass, acute abdominal or back pain, and resistant hypertension. Okay. This is also a main giveaway if they give you back pain with a resistant hypertension. Most often, infrarenal distribution of vasa vasorum is reduced. So, what do we have? Ascending thoracic aorta is this purple thing, then the aortic arch, then comes the descending thoracic aorta, and then you have the abdominal aorta here. So there are two types of aneurysm. You can get a fusiform aneurysm, that's like that, and secular aneurysm like that. Okay, that's what it looks like on an X-ray. On a scan, not X-ray. Let's see a few more. Okay, so this is sclerotic. This is abdominal aortic aneurysm, right? So you can see the difference between the two layers. This is the one with the blood, and this is the muscles of the artery or aorta. Okay, right there. Yeah, they'll probably give you something like that, right? So it's easy to figure it out. Traumatic aortic rupture. So it's due to trauma and or deceleration injury. Most commonly at aortic isthmus. That's the proximal descending aorta, just distal to the origin of subclavian artery. X-ray may reveal wine mediastinum. Okay. But if they give you a wine mediastinum, it's probably a sign of emphysema, because that's what they use that terminology for. They'll give you other stuff as well, traumatic for aortic rupture, like hypotension, going into hypovolemic shock and stuff like that, and then they probably find a little bit of bleeding somewhere, and then they'll ask you, where could this rupture happen? And then you gotta remember that the most common spot is the aortic isthmus, right there, around there. Okay. So aortic dissection, that's what that looks like. A longitudinal intimal tear forming a false lumen. So this is what I was explaining over there. And you can see that's here, and then so ascending and the descending as well. So it's going like that, and it's traveling from here, and it's gotten bigger over here. So longitudinal intimal tear forming a false lumen associated with hypertension, bicuspid aortic valve, inherited connective tissue disorder, for example Marfan syndrome, can present with tearing, sudden onset chest pain radiating to the back, with or without markedly unequal blood pressure in arms. You have chest X-ray that can show mediastinal widening, can result in organ ischemia, aortic rupture, and death. So you have Stanford type A, and then you have, which is the proximal one. It involves ascending aorta. A involves ascending aorta. So if it involves that, it's type A. May extend to aortic arch or descending aorta. Blue arrow in A. Okay. So there's the descending aorta. May result in acute aortic regurgitation or cardiac tamponade. Okay. Treatment is surgery. Stanford type B distal involves only descending aorta below left subclavian artery. Okay, so I'll draw that over here now. So you have a whole artery, right? That's the external layer. There's the internal layer of the artery. Again, it's a damage over there, and then you have on side over here. And this is like the aortic valves over here into the left ventricle, right, into the heart. Okay, so when it pushes in, you have 3 cusps here, or maybe bicuspid because we had this thing. So maybe it got damaged over here, or there was somewhere a damage initially, and then the blood started pulling in over here. And then when you have like hypertension or something, or for any reason, the heart pumps harder, and then this keeps going inside and inside, and then that's where it pulls the blood. Okay. So what can you do to prevent this, right? You give beta blockers to slow this down, because what does beta act 1 do? Increase heart rate, increase contractility, and renin, right? So we'll block this. If we give beta blockers, so to decrease the heart rate and the hypertension rate. So when you slow down the heartbeat, what's going to happen? Even if this goes in, it's going to have a pulsatile action, right? Because it's pulling inside and there's blood here too, so it's going to create a little wave kind of thing. So you'll have this wave. So when you slow down the heart, before this wave comes back, if there was another wave, it would further damage this layer, right? So when you slow it down, this wave, before another thing comes, a pump, the wave is going to stop and it's going to disperse. So then there's not that much damage anymore. So we can give beta blockers, or another thing we can do is we just make this wider, right? So there's a lot more area for this to go in rather than going into this, because then there will be resistance here compared to this area. Because remember, you're dealing with 120 mmHg of systolic pressure. Although vasodilators don't really have that much effect on the great vessels, but it will have it on the vessels that great vessel supplies to, right? So it will decrease the resistance, so it can go easily through the artery. So that's why, to decrease the total peripheral resistance, you give vasodilators and beta blockers. In aortic dissection. Aortic dissection is known for what? Marfan syndrome. Okay. That stuff. Okay. Subclavian steal syndrome. This is also an important topic. Stenosis of subclavian artery proximal to origin of vertebral artery, hypoperfusion. Okay, so this is right vertebral artery right here. This is the left vertebral artery. We'll do this in near circle of Willis. We'll talk about the vertebral arteries there. But for now, this is the vertebral artery coming in, right? And it attaches to proximal left subclavian. So subclavian artery. But right before it, the attachment of that on the subclavian, there is a little bit of pinching over there. Or stenosis. So stenosis of subclavian artery proximal to the origin of the vertebral artery. So this is the origin of vertebral artery. So normally what's going to happen in artery, it goes into, right? It always goes into and away from the heart, right? Like that. But because of the stenosis, that's not happening. It's not going into the vertebral artery here to supply it. Instead, you're getting blood coming back into this from the other side of the stenosis and going into the system, right? So that's what the subclavian steal syndrome is about. It's stealing the blood from this side to supply this side of the body. So what's that going to do? Leave less blood for the brain, right? Normally it would have supply from here coming into the brain and from here into the brain, but because of this, it doesn't have enough supply in the brain, because when it comes up here, there's less resistance here because there's no well, there's literally no blood on this side, right? So rather than pushing into the brain, it comes in this onto the side of resistance, right? Okay, so I'll read that again. Stenosis of subclavian artery proximal to origin of vertebral artery. This will cause hypoperfusion distal, so that would be distal away from the core, to the stenosis. So this will cause reversed blood flow into ipsilateral vertebral artery. Okay. So instead of going this way, it's gonna cause this way, ipsilateral. So ipsilateral, the same side of the stenosis, on that side. Okay. So reverse blood flow into the ipsilateral vertebral artery. It's coming into the artery now, rather than going away from the artery. This will cause reduced cerebral perfusion, because now that it's coming from here to here, there's less blood going into the brain. So reduced cerebral perfusion on exertion of affected arm. Okay. So say this is on the left side, right? So the left arm's like doing stuff. So when it's doing stuff, it's going to require more energy. So it's going to pull more blood. So because of that, it will cause arm ischemia, obviously, because the blood's not going to be enough to take care of the oxygen demand. You'll have pain because of less oxygen in blood. You'll have paresthesia, vertebrobasilar insufficiency, so dizziness and vertigo, right? So more than 15 mmHg difference in systolic BP between arms associated. Okay, so this is important. So you'll get more than 15 mmHg of pressure difference in systolic BP between arms. So on this side you'll have like 120, and on this side you'll have like 135, right, of systolic. This is difference between the two sides of the arms. Okay, the coarctation is between the upper extremity and the lower extremity, the difference, and in this you have it between the arms. It's associated with arteriosclerosis and Takayatsu arteritis. This is also vasculitis. Okay, and we need to know what that is too. It's an easy one to remember though, because you can think of Takayatsu being like a samurai with a sword that, in a battle he got his arm cut off, so he has different pulses on both sides now. Okay, so Takayatsu is also called TAC, is a rare form of vasculitis disease involving inflammation in the wall of the large arteries in the body, the aorta, and its main branches. The disease results from an attack by the body's own immune system causing inflammation in the wall of the arteries. Okay. So it's associated with that arthritis. Which one? Subclavian steel syndrome. And also heart surgery. It could be because of the scarring, the stenosis happened or something like that. Okay. Just make sure that the steel syndrome, it steals the blood from the other side onto the side of the stenosis. So there will be less blood for the brain, so you'll have dizziness and vertigo. There will be not enough blood for the supply, right? So if it's going to the left arm, it's not going to have enough supply there. So you're going to have pain in that side of the arm. Most importantly, the blood pressure is going to be different on this one, because here it's going 120 mmHg on this side, right? And then over here it's going to get reduced because it's going through 1, 2, 3 turns, and that's going to reduce the thing. Pressure. Okay. Anginas. So ischemic heart disease manifestations. It's really easy to remember these if you remember the symptoms. Okay, so one of the symptoms is like the pain occurs on exertion. The other one occurs during rest. Okay, the one on the exertion, if it gets resolved with rest, it's gonna be stable. But the one where it occurs during rest is going to be unstable. Okay, and then you have vasospastic. That's that's a different thing altogether. So let's read about it. Chest pain due to ischemic myocardium secondary to coronary artery narrowing or spasm. Okay, so right here, you have a heart, okay, and you have an artery supplying this thing. Okay, and this is the main artery. And let me draw the one more time. Okay, so perfect. Chest pain due to ischemic myocardium. So these arteries are supplying blood to the myocardium. Secondary to coronary artery narrowing. So it could be that it's narrowed like this, right? So the blood can't go through to supply this area of the heart. Or spasm. It could be that this one's going spasming, so blood has a difficult time going into that artery, so it's just gonna avoid going into it, right? Just like a pipe that you move really fast with water coming out of it, and then you get slower water or reduced amount of water coming through it. Right? Although there won't be any necrosis. Okay. Stable. So usually secondary to atherosclerosis, you have atherosclerotic plaques over here. Okay. Stable. Usually secondary to atherosclerotic plaque. The symptoms are only going to occur if the occlusion it makes is more than 70% occlusion, right? Exertional chest pain in classic distribution. So this is the one with exertion, possibly with ST depression on ECG. Okay, so if you remember the ECG, it's gonna be like with a little bit of P wave, and then the P to Q, and then the Q wave, then the R, then the S, then the T, and T wave like that, and then the P wave again, right? So this area was the ventricular contraction or depolarization stage, right? And this T wave is the repolarization. So when they say ST depression, they're talking about this one. So instead of this, you'll have something like that. Okay, so that's a ST depression. Actually, let me just type it in here. Okay, so that's the ST segment depression. So why does that happen? That's basically because say the blood is traveling, right? The electrical impulse is traveling, right? And like normally what it does is it has to go through the whole thing, right? And that's what's causing this uprise and this. To go from here to here, it has to go through this whole path. But now that there is ischemia over here, it doesn't have to supply, it's not going to supply its electrical impulses there. So instead of going there, it's just going to go, like normally it would go like this, like it would supply all of this, and then it would end up here, right? But now, all it has to do is supply a little bit over here, and then over here, right? So that's a faster route it got from point A to point B, right? So that's a faster thing, or faster route, I guess, for lack of a better term, right? So that's why you get a depression, because it was going, and then instead of supplying the area that would make this go up like that, it just avoided that, so it just ended up over here altogether, and it was faster. The signal was faster. In this case, what's going to happen? It goes down here, and it's gonna get stuck here. So now it can't go through here or here, so there's no or nothing over there, right? So what it has to do is go around all the way and then figure out where it's gonna come back from, right? So it's gonna go all the way, make all those things, and then find a way here, and then it's gonna end up here, right? And that's taking a lot of place, so that's why you get the ST elevation on ECG. Okay, so this is what the ST elevation is, because it's taking a lot more time, right? So you don't get this whole depolarization over here, because it's wasted that much energy. So that's why you get the elevation. Hopefully that makes sense. Okay, so again, stable. Usually secondary to the atherosclerosis, more than 70% occlusion, exertional dyspnea, exertional chest pain in classic distribution, possibly with ST depression on ECG, resolving with rest or nitroglycerine. So if it gets resolved because of rest or drugs, like nitroglycerine, it's going to be stable angina, okay? This is common in, no, not this one. This one's common in younger patients. Okay. Vasospastic. So vasospastic, also known as, actually, we only have 6 minutes. Let me try finishing this. So vasospastic, formerly presmetal or variant, occurs at rest, secondary to coronary artery spasm, transient to ST elevation on ECG. Tobacco smoking is a risk factor. Hypertension and hypercholesteremia are not. Okay. So this is a risk factor that's important to remember for this. But hypertension and cholesteremia is not. Okay. Triggers include, because normally you would think it's because of atherosclerotic plaque, but it's not. Okay. So triggers include cocaine, alcohol, and triptans. Treat with calcium channel blockers, nitrates, and smoking cessation, if applicable. Okay. But remember, high cholesterol doesn't have a thing for this. Okay, so here we had ST depression. Let me just do that. ST depression on ECG. Here we have ST elevation on ECG, and it occurs secondary to coronary artery spasm. Right. Unstable thrombosis with incomplete coronary artery occlusion, with or without the ST depression and or T wave inversion on ECG, but no cardiac biomarkers elevation, unlike non-ST segment elevation in MI or STEMI. Increase in frequency or intensity of chest pain or any chest pain at rest. This is going to be the buzzword right here. That the patient was sitting and doing nothing and started experiencing some chest pain. Okay, that's what tells you that it's going to be unstable and not vasospastic or stable. Okay, now for stable, they'll tell you that he was mowing the lawn in the morning and then he started feeling chest pain. When they did an ECG, they found a ST depression on ECG. So then you just have to figure out that it's either stable or just stable or in non-STEMI, right? But for non-STEMI, they'll give you cardiac markers as well. Okay, so that's how you differentiate between stable and STEMI. For vasospastic, they'll give you a history of smoking, long-term smoking, and they might give you this to throw you off, but they will then ask you, so what should the treatment for this person be, right? So besides giving the drugs, what lifestyle change should they make? So they'll have like a better diet or go exercising and all that. It's going to be stop smoking. That's the one. For unstable, they'll give you ST depression and T-wave. If not, they will definitely give you that the person experienced chest pain while sitting around watching TV or reading a book or something. Okay. Okay. We'll come back after the break. Can you hear me, right? Yeah. Okay. Again, stable ST depression, chest pain on exertion, and it resolves with rest or nitroglycerine. Okay. And unstable chest pain during rest, vasospastic history of smoking. So stable angina, unstable angina, and STEMI and STEMI, right? So non-ST segment elevation myocardial infarction and ST elevation myocardial infarction, two different things. On pain, stable angina, it occurs on exertion. There won't be any troponin level elevation. That's the cardiac marker. It only happens when there is a myocardial infarction, so that's what we do for that. Infarction, none, and ECG changes, none. Okay, even though possibly it could have ST depression on ECG, okay? But that's not reliable, I guess, because they'll give you that he was exerting himself and then he felt chest pain, so that's stable angina. But then it resolved after 15 minutes of rest. Unstable angina, mild exertion or at rest. Okay. Again, no cardiac markers. Infarction, none. EC changes are that possibly it can have ST depression or T wave inversion. Right? Inversion because it repolarizes faster, because there's less area that it has to repolarize. That's why it's an inversion. Okay. ST and STEMI. So that's non-ST segment elevation MI again. Is because it's going faster to the point B from point A, because it has less work to do. So that's why depression. Okay. Troponin level is going to be increased because that's a cardiac marker for MI. Infarction. This is subendocardial. So subendocardial is when it's, just this part, or like it could be, anywhere, but not the whole thing. It could go even closer to the edge, but not the whole thing. That's still subendocardial, because that still means it can go from point A, from point A to point B faster, because it has less work to do. But if it covers the whole thing, what does that mean? This thing, that means it has to go all the way around and work, right? So then you're gonna get ST elevation instead, and this is called transmural. Transmural means all the layers of the heart: epicardium, myocardium, and the outer one. Okay, so this occurs at rest as well, just like this. Troponin marker is also elevated. So only way you can differentiate between the two is if there's ST depression, which means the electrical impulse goes faster because it's less work. But even if it doesn't apply here, it still has to do more work to find a place where it can reach point B. So that's why it's transmural. So that will be ST elevation. Okay, coronary steal syndrome. So coronary steal syndrome is different than subclavian steal syndrome, but the only difference is that it's in a different place, and something can influence it. So how does it get influenced, right? So that's what we're gonna learn. Distal to coronary stenosis, vessels are maximally dilated as baseline. Okay, let me draw that. So we have a vessel here, and there's a coronary vessel, so it's kind of like that. Right, so stenosis happened here, like that much. More than 70% occlusion, I guess. Okay. Administration of vasodilators. So this thing is also supplying this and supplying this. Okay, so the coronary has branches like this, and here in one of the branches it has, so it's gonna pull here, and then it's just gonna go into this or into this side. Okay, so distal to the coronary stenosis, vessels are maximally dilated at the baseline. So distal to it, over here, is gonna be dilated. Okay, not this, because this would be distal to the stenosis, and this would be proximal to the stenosis. Why? Because it doesn't have blood, so it needs more blood, so it's making room for more blood to come and decreasing any amount of resistance as much as it can, right? So administration of vasodilators like dipyridamole or rigadonosone dilates normal vessels. Okay, so obviously we would think, okay, so what if we just dilate this vessel, right? Wouldn't that just make everything easier? But when you give vasodilator, what else is gonna happen? These are gonna get dilated as well, right? Like that. This one would get dilated, but again, the stenosis is still gonna apply, right? So this will cause blood is to shunt towards well-perfused areas. So even though there is stenosis here, this is also decrease in resistance and decrease in the resistance times 2. And there's still going to be some amount of resistance here. So it's going to take a path of least resistance and go through this or this instead of going through here. Okay? So blood is shunted towards well-perfused areas. So ischemia and myocardium perfused by stenosed vessels. Okay. Principle behind pharmacologic stress test with coronary vasodilators. So blood is shunted towards well-perfused areas. This causes ischemia in myocardium perfused by a stenosed vessel. Okay, so what it's saying is that because of this, even though it was like this much, it was still getting perfused a little bit in this area, right? Because these also had like resistance before, some amount of resistance. So that allowed some blood to leak through here, from here, right? So at least a little bit was coming from here and perfusing. But now that there's no resistance here, there's nothing, making the blood go from here to here instead of just going here. It's easier for them. And they'll perfuse this area, they'll perfuse this area, and this area is going to now get, ischemic. Because hopefully that makes sense now. So this is called, coronary steal syndrome. They're stealing the blood from one vessel into the others when you give them vasodilators. And this is the principle behind physiologic stress test with coronary dilators, right? So they give you the dilators, then they make you do things, and then they check for, if it gives you pain or not. Because you're not going to get pain if you're just sitting around and you're at a doctor's office. You need to do the stress test. And that's how they figured out if there's a problem. Okay. Then you have sudden cardiac death. Death occurs within 1 hour of symptoms, most commonly due to lethal arrhythmia, for example, ventricular fibrillation. Associated with coronary artery disease, up to 70% of the cases. Cardiomyopathy, which is hypertrophic or dilated, and hereditary iron channelopathies like long QT syndrome or Brugada syndrome. Prevent with ICD, intracardiac device. Okay, so what comprises of sudden cardiac death? It's when the death occurs within 1 hour of symptoms. And It's mostly due to lethal arrhythmia like ventricular fibrillation. It's associated with CAD. Okay, chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic myocardial damage, myocardial hibernation, potentially reversible left ventricular systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. Okay, so chronic ischemic heart disease, it's just progressive onset of heart failure over many years due to chronic ischemic myocardial damage. This is a important concept right here, myocardial hibernation. So it's, what is it? So potentially reversible left ventricular systolic dysfunction. Okay, so the dysfunction, it can be reversible. So they'll give you a question about a person who's suffering from progressive onset of heart failure, and initially when they were tested or like a biopsy was done, the cardiac cells had a few, I don't know, it had a dysfunction, but after like 2 months it started functioning normally. So what is this concept called? It's called myocardial hibernation. It's going to be similar to that kind of thing, the kind of question. So potential reversible LV systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, which is a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. So it's different from that. Okay, myocardial infarction, most often due to rupture of coronary artery atherosclerotic plaque. This will cause acute thrombosis, right? Increase in cardiac biomarkers, CKMB or troponins. These are diagnostic. This is, the easiest concept to understand. Myocardial infarction. It's basically, instead of a stenosis, imagine this was a plaque, right? So this is the plaque in this artery, and this plaque, then maybe because of some friction or whatever, there was endothelium rupture, and the plaque, a little bit of it got loose, and then it traveled elsewhere. So most often due to rupture of coronary artery atherosclerotic plaque, this will cause acute thrombosis. This plaque will then further travel down into like the end of the artery and then cause symptom there. So this will, when you have myocardial infarction due to this or any kind of ischemia, that's long lasting, or you'll have biomarkers like CKMB and troponin. We'll learn about that later. And if you have these, that means you have suffered from myocardial infarction, because this is how you diagnose it. So you have non-ST segment elevation or ST segment elevation myocardial infarction. Okay. Infarct location. So if you have lower ST, that means it's not all the way, right? So it's going to be subendocardial location. So layers involved are subendocardium, inner 1/3, especially vulnerable to ischemia. So this is where it happens. When I said it can go up to there, that wasn't true. Okay. It's only going to happen in the subendocardial layer. ECG changes, ST segment depression. Then you have STEME, infract location here is transmural, all 3 layers. Layers involve full thickness of myocardial wall. ECG changes are going to be ST segment elevation, and you're going to have pathologic Q waves. So this is what the pathologic Q wave looks like. Normally it's lower than the S, right? as the depression, I guess. Right? And this is elevation, depression, elevation. So let's just say pathologic Q waves are the ones in red. And yeah, okay, got it. So in myocardial infarction, what happens after the thrombus occludes the supply, right? So commonly occluded coronary arteries are left anterior descending artery, right coronary artery, and then at the end you have circumflex artery, right? A branch of left coronary artery, not anterior descending, but right. So symptoms: diaphoresis, nausea, vomiting, severe retrosternal pain, pain in left arm and or jaw, shortness of breath, and fatigue. Okay, this is because of what? Phrenic nerve, I guess. 0 to 24 hours. So within 24 hours, what will you see in myocardial infarction? You'll see wavy fibers. So that's what it is, right? So you get dark mottling, pale, tetrazoleum stain, occluded arteries right there. You have wavy fibers, 0 to 4 hours, and then you have early coagulative necrosis. So this happens within 4 to 24 hours, okay? The necrosis occurs at that time. Then you get cell content released into blood, okay? So when you have that, that's going to cause reactions, obviously. Then you have edema and hemorrhage. Reperfusion injury occurs. This is free radicals and increase in calcium influx. Hypercontraction of myofibrils, dark eosinophilic strips. Right. So eosinophil is always the first one that comes. So see if they have. Here you can see the fibers, I guess, right? No, it's not right. Yes, this is a better one. So you'll see wavy fibers like that, right? Necrotic myocytes that are being distorted by a pull of coagulated. But what I want you guys to see is eosinophils. I guess that's eosinophil as well. Okay, just pay attention when you get a question in UWorld, what this looks like, and like save the photo so you know what to look out for, because it's very important that you can distinguish between them. Because what they will do is they'll just give you a photo like this and they'll ask you what stage of myocardial infarction is this person in, and you need to know these stages, because the one we saw like this is not eosinophil, it's neutrophil. Okay, so if you see like a little bit of dots right here, and you can still make out the wavy fibers, right? So that's going to be 0 to 4 hours. Okay. So what can happen because of these? You can get ventricular arrhythmia, heart failure, or cardiogenic shock. Okay. Then what happens after eosinophils? You get neutrophils. So in 1 to 3 days, you have extensive coagulative necrosis. Tissue surrounding the infract shows acute inflammation with neutrophils. Okay. This is complication is post-infarction fibrinous pericarditis, and you have redness in that area. Okay, that's what's going to cause it's called the hyperemia. Okay, so post-infarction fibrinous pericarditis. Important. First, you get wavy fibers, and coagular necrosis starts, and reperfusion injury happens here, which is free radicals and increase in calcium influx, and you have hypercontraction of myofibrils, dark eosinophilic strips, and then 1 to 3 days you have neutrophils, and this continues. Also remember the complications; they test you on that too. So what is this person at risk of between 0 to 24 in the initial stages of MI? They're at risk of having ventricular arrhythmia, heart failure, and cardiogenic shock. Here they have it's post-infarction fibrinous pericarditis, and then within like the first week or the second week, right? So after neutrophils come what? Macrophages. Then granulation tissues at the margin. Okay, so you have hyperemic border, central yellow-brown softening. Okay, and at this point you can't make out any fibers, right? Not the wavy fiber, not the straight fibers either. None of them. It's just everything is just haphazardly placed. Okay, free wall rupture, tamponade, pulmonary muscle rupture, mitral regurgitation, interventricular septal rupture due to macrophage mediated structural degradation. This leads to left to right shunt. So LV, pseudoaneurysm, aneurysm, risk of rupture. So this is the important one right here, pseudoaneurysm. There's a risk of rupture here between the first and the second week after 3 days. So since it's soft and stuff, how are you going to remember this? So macrophages come in. That you gotta remember, free wall rupture is during this period of time. It can cause tamponade. That's just fluid in the spaces between the layers of the heart, pericardial space. Papillary muscle rupture. Okay, these control the valves, right? They're the foundation of the valves. So you can get mitral regurgitation. Then interventricular septal rupture can occur as well. So between the two ventricles, this is due to macrophage as well. Okay, so macrophage mediated structural degradation. So this can cause left to right shunt, so the blood to go through it, the septum. Okay, and LV, pseudoaneurysm, risk of rupture. So when does this go away? After 2 weeks to several months. Okay, when you get the scar over there. So the scar is going to look gray and white. It's not going to be red anymore or yellow brown. Okay. This is what the scar looks like. You can't make out any muscle fibers here. All you see is like a blank slate of pink ocean, right? With a little bit of dots in the middle. Okay, so you can get Dressler syndrome, heart failure, arrhythmia, true ventricular aneurysm, and risk of mural thrombus. They didn't get what Dressler syndrome is. This is an important one. So, it's the inflammation of the space surrounding the heart. Pericarditis. It's believed to be an immune system response after damage to heart tissue. Okay. So the first thing you can get in the complication is reperfusion injury, then the free radicals, then the dark eosinophilic strips for this one. Over here you can, post-infarction fibrinous pericarditis. Then here you have free wall rupture on every side. On left ventricular wall, you can have it in the septum, or you can have it in the muscles that control the valves. And here you have Dressler syndrome and immune response. Okay, you can have heart failure with arrhythmias, true ventricular aneurysm as well. So you have a risk of pneumothrombus, contracted scar, completed after 2 weeks to several months. Eosinophil strips, neutrophils, macrophages, then the collagen fibers. So how do you diagnose it, right? So what is troponin or CKMB? That's what we're going to learn about here. So in the first 6 hours, in ECG is the gold standard. If a person comes in with chest pain or pain in their arm and back or jaw, anyways we do ECG for that. So next thing you can do is cardiac troponin 1 rises after 4 hours. So you can do troponin levels, you can check that. So it rises after 4 hours, peaks at 24 hours, and is increased for 7 to 10 days in your body, okay, after heart attack. More specific than other protein markers. So this is troponin. The levels rise up to here, and then it goes down and like that. Right, so you're pretty good until over here at least. And even if there's a minor level, there is a threshold. So if it's above that line, it's valid. Then you can have CKMB increase after 6 to 12 hours, which peaks at 16 to 24 hours, and is predominantly found in myocardium, but can also be released from skeletal muscle. So just like in rhabdomyolysis, you have creatinine, right, kinase leaking into your urine. You can pick it up and test for it over there. Here, if it's the heart muscles, it's going to be CKMB. Okay. So it increases after 6 to 12 hours and peaks in at 16 to 24 hours. Why is this important? It's useful in diagnosing re-infraction. So say a person already had infraction, he comes in and then he says while he's under your care that he's feeling this or he felt this last night and stuff. Then you'll do this again, CKMB, to check for re-infraction following acute MI. Because levels return to normal after 48 hours. Okay. So right where that line crosses, below the threshold, that's when it starts. Then it's not considered anymore. So if there's another rise after that, that means there's re-infraction. Okay, so troponin, and you can detect it up to 10 days. And then for CKMB, you can detect it up to 2 days. ECG is the gold standard. ECG changes can include ST elevation for STEMI or transmural infract, or ST depression, that's N-STEMI, subendocardial infract, hyperacute peaked T waves, or T wave inversion, and pathologic Q waves or poor R wave progression, evolving or old transmural infract. Okay. Now the fun stuff. ECG localization of STEMI. So infract location and leads with ST segment elevation or Q wave. If you're the kind of person that thinks they would never get this, that's okay. You can just memorize this. That's all you need for step 1. You don't have to worry about the leads or where it goes and all that stuff. You just memorize this right here, and that's what they'll give you. They'll tell you that MI in leads 1 and AVL, right? So that's going to be your lateral. Or they'll tell you that there's detection of MI, ST elevation in the leads from V3 to V4, right? So that'll be your anterior apical and distal LAD, okay? But for people who can pick it up, I'll just go over it real quick. Okay, so you put so imagine this is the heart, like a person, you cut through him on a coronal plane, and then you have sternum here, so this would be your anterior side, right? So if you just imagine this on yourself, the sternum, and right behind it is the heart, and this is the right side. So on the right side of your sternum you have V1, okay, and the left side you have V2, and then just keep going, V3, V4, and now you're at your sides, or your lateral sides. You have V5 and V6 over there. Then this is where normally it ends in, like, as long as, like, if you have done internship or any kind of rotations in a hospital. Sometimes if you are at a fancy hospital, they could have V7, V8, and V9 going all the way back, okay? So if something is detected, ST segment elevation, it just means the electrical impulse taking time to reach these leads, and if it reaches them faster, you're going to get elevation. If it reaches them slower, you're going to get a depression, okay? That's what it means. Okay, and then you have these leads. So AVR, AVL, and AVF. F is for foot, L is for left, okay, and R is for right. So foot, if AVF is involved, it's always going to be something inferior. It could be anteroinferior, it could be lateroinferior or something, I don't know. But inferior is going to be involved, like inferior side of the heart. So between AVR and AVF, so if you just like pull out your arm, that's your AVR, the right arm, and then your foot, and between that is going to be 3, and then if you pull out your left hand, and between that and your foot is going to be 1 near the arm and 2 near the foot, okay? So that's how that is. Now that we know that, what does that mean? Normally we just look at the second lead, right? Because that's the one that's closest to the heart, with the right ventricle right behind it, right? So you get the maximum, optimum results with that one in that lead. So you have your P wave, QRST, PQRST, PQRST, and it has around 30 and 0.5, so that's how many beats. So first one was 300, then 150, then it was 100 for 3, right? And then for 4 it was like 75, 60, and 50. Okay. So it's normal. It's less than 100 heartbeat. Then you have the first one, right? So that's this side. So first, second, third. So first, second, third is right there. This is all your inferior side, right? Because AVF is involved. So 2, 3, and AVF is going to be inferior. So if we look here, inferior side is applied by marginal branch of right coronary artery, right? Let me go back and bring that up. It was in anatomy. Okay. Okay. So the inferior side is supplied by the AMA. AMA is the acute marginal artery. It's the branch of right coronary artery. So inferior right coronary artery. So that's 2, 3, and AVF, right? So AVF is your inferior one. That makes AVL the lateral one, right? So the lateral AVL. So if you have AVL involved in anything, you're gonna have lateral. But what else is lateral? So is V6 and V5, right? And 1 and AVL. So you're gonna have that in green. So 1 AVL, 5 and 6. If you have any kind of abnormality in the ECG in these leads, it tells you that it's somewhere on the lateral side, right? So lateral is left circumflex artery. Okay, so that's this thing right here, and that thing right there, it turns into obtuse marginal artery as well. Okay, and it's a branch of left coronary artery. So left circumflex artery, lateral. If you have ST elevation or something on lead 1 and AVL. L for lateral, L for left. Okay. And here you have 5 and 6. Again, anterolateral. So anterior side, remember that's left anterior descending artery. So it could be that, because since it's also a branch of left coronary artery or the left circumflex artery, so it's coming from there as well. Okay, so it could be a thrombus here coming from here, and then it will affect here, or it can be a thrombus here, and that's still gonna give you a problem in V5 and V6. Okay, so we just finished 3 of those. So if you have a problem in V5, V6, it's your lateral sides. So LAD or LCX, or it could be lateral. So why am I not making too much of a difference, or why are both of these green? It's because they both are supplied by left coronary artery. Okay, that's the most important thing to remember. They won't ask you where did this thrombus come from, and you're not gonna say left circumflex or something. You're gonna say it came probably from left coronary artery, because that's the one it's branching out of, right? So that's where it came from. Then they can ask you, okay, so they checked via angioscopy or whatever, and that the thrombus is in left anterior descending artery, but the left coronary artery was found to be clear. Like, so how did that happen, right? Or sorry, posterior descending artery, right? The inferior side. So how did that happen? And RCA was cleared. Like, it wasn't because of RCA. So it's because of either codominance or the left dominant heart, right? So it's being supplied by left coronary artery or left circumflex artery, like that. So know the difference between that. Okay, so we did anterolateral, so that's left descending or left circumflex. We did the lateral and we did the inferior. Now we will do V3 and V4. So we have V3 over here between the sternum and the lateral, right? So it's right under the so V4 would be right under the apex, the mitral, the heart apex, and between that and the sternum you'll have V3 and V2. So V3 is right between V2 and V4. Okay. If you have done ECG, you know this already. So V3 and V4 is right there, the oranges, and this is on the interior side, right? So it's going to be the interior and apical, because that's the apex or the apical region of the heart, where you can feel the heartbeat with your apex beat, right? So distal LAD, this area is supplied by left anterior descending artery. That's why it's antero. Okay, and V3 and V4, that's where you'll see it. ST segment elevation. So if you see it over here, there's a problem with this area of the heart, basically the anteroapical area of the heart. Then V1 and V2, right there and there. Left anterior descending artery, anteroseptal, left descending artery. So V1 is on the right side of the sternum and V2 is on the left side of the sternum. So anterior side and the septal sides. Okay. So again, this is left anterior descending artery. So left anterior descending artery is supplying the anteroseptal, anteroapical, anterolateral, and lateral. Okay. The inferior side is supplied by the RCA, and the posterior side, as the name implies, is pushed by posterior descending artery. This is your V7 to V9. So V7, V8, and V9. This is your scapula. Then you have ST depression in V1 and V3 with tall R waves. Okay. So you might pick it up with these as well if there's a infraction over here on this side. with tall waves over here, because it's taking so much time to go around from here to here, right? So that's why it's the tall wave. Okay, that was ECG. Normally they'll just give you all of this, and all you have to focus on is the lead 2, the second lead, and that will most probably tell you what the problem is, anyways, because they'll tell you which area it was. You might have to figure out which area is supplied by what. Most of the areas are supplied by left coronary artery. Only the inferior is RCA, right? The PDA is also a branch of RCA, right? But it could be a part of LCA as well, depending on which dominance it is. Okay, narrow complex tachycardia. For this, atrial fibrillation, I think this is the one book. Oh, there's a. So, there was, okay, we'll just go through it. Atrial fibrillation, irregular rate and rhythm. This is the buzzword for atrial fibrillation. Okay. 2 I's in irregular, and 2 I's in fibrillation. Okay. We don't talk about this one. So 2 I's in this and 2 I's in that. Irregular rate and rhythm. Okay. 2 R's as well, but that applies to the other one. Rate and rhythm with no discrete P wave. That's the most important one. You can't make out which one is the P wave, right? Because they all look up and down and different sizes, and that could be T wave or P wave, but you can't be sure. So no discrete P wave. This whole thing is a buzzword right here. If you hear anything from here or like this sentence, it's gonna be atrial fibrillation. Okay, so common risk factors include hypertension and coronary artery disease, may predispose to thromboembolic events, particularly stroke. Management is rate and rhythm control, cardioversion. Definitive treatment is ablation of pulmonary vein ostia or left atrial appendage. Consider anticoagulation based on stroke risk. Right. So why this? Remember when we were doing anatomy of heart, I told you that this is where the atrial signal goes to on the left side. Right. When we were doing this. Right there. So from SA node, it goes to the other atria over here. So that's where it goes. And that's what causes the atrial fibrillation. So we deal with that area. So that's why definitive treatment is ablation of pulmonary vein ostia. So right there, that's where pulmonary vein comes in. Or left atrial appendage. Consider anticoagulation based on stroke risk. So this is also important because after atrial fibrillation, a person who suffers through it after a few days or months, they suffer from stroke. Why? It's because during fibrillation, the blood was being stagnant in the chambers, and when the blood is stagnant, what happens? Clot form, right? So there was some clotted blood, and now that it's on this side, it doesn't go through the lungs, where embolus can, cause more problems. So this will go into LV and through aorta into the coronary, like carotids, then coronary, cerebrals, and it can cause ischemia or stroke over there, right? The most common site is what? It's between, I think, anterior cerebral artery and the middle cerebral artery. We'll do that in neuro, circle of Willis, but if you want to look it up. Okay, so you have to consider anticoagulation based on a stroke's risk because of that. Okay, so may predispose to thromboembolic event, particularly stroke. So when you're looking at an ECG, the boxes between the RRs are going to differ in all the region, like all the sections of all the RR sections, basically. Okay, so RR1 will not equal to RR2, which won't equal to RR3, won't equal to RR4. Irregular baseline, absent P waves. Then you have multifocal tachycardia. Okay. Multifocal atrial tachycardia. This is irregular rate and rhythm with at least 3 distinct P wave morphology. Here, the P waves are distinct, right? You can tell which one's P wave here. Here, you couldn't tell it. Okay. For tachycardia, you should just remember that you can just read the boxes between them, and it's going to be 3 or less boxes between RR. Okay. So this is one box right here. The 5 small boxes. You don't read the small boxes. You read the big boxes. So that's one box and a half. Okay. So like that. So even if it was 2, it's still 150, which is more than 100. Okay, so irregular rate and rhythm with at least 3 distinct P wave morphologies due to multiple ectopic foci in atria. It's associated with underlying conditions such as COPD, pneumonia, and heart failure. Okay. Sorry. Okay, so P waves will be short, tall, inverse, whatever in this. It's because the AV node is getting its signal from another place other than the atria SA node. That's what it means. So due to multiple ectopic foci in atria. Okay. Then you have atrial flutter. The flutter is rapid succession of identical consecutive atrial depolarization waves causing sawtooth. Okay, if you see this, it's going to be a flutter. That's the easiest one to figure out from an ECG. Sawtooth appearance of a P wave. So if you ever seen someone work a saw in cutting a wood, the saw blade, this is what it looks like. So that's what they mean by sawtooth. Treat like atrial fibrillation with or without the catheter ablation of region between tricuspid annulus and IVC. Okay. What's over there? So tricuspid is right here, and IVC is around here. So I guess that's where like majority of the ectopic comes from, I guess. Just remember that this is where you do it, because they might ask you that. Proximal supraventricular tachycardia, most often due to a re-entrant tract between atrium and ventricle, most commonly in AV node, commonly presents with sudden onset of palpitations, lightheadedness, and diaphoresis. This is an easy one to guess from a question stem. Okay. Treatment, terminate re-entry rhythm by slowing AV node conduction. For example, vagal maneuvers, right? It's called vagal maneuver, but it's actually you doing the carotid sinus thing. Or you can give IV adenosine. Electrical cardioversion, if hemodynamically unstable, definitive treatment is catheter ablation of the reentry tract. Uh, and this is the most important one because they'll give you ECG, and on the lead 2 you'll see this happen, and if you see this happen, it's Wolf Parkinson White syndrome or WPW syndrome. Most common type of ventricular pre-excitation syndrome, abnormal fast accessory conduction pathway from atria to ventricle, bundle of bypasses rate slowing AV node. This will cause ventricles partially depolarize earlier, which leads to the characteristic delta wave with wine QRS complex and shortened PR interval. Okay. May result in re-entry circuit and supraventricular tachycardia. Treatment is procainamide and avoid AV nodal blocking drugs. So what's happening here is that since the AV node, before it can go and do this, there's another another thing. Hold on, I think I have a photo for this. Okay, right there, right? So AV node can do this and do that, right? So SA node goes to the AV node, and that goes to the bundle of His, and then through the ventricles. But in re-entry, it's this thing. So it goes like that, and it goes from another place, and then it excites someone over there as well. So this causes early excitation. So there's early excitation, so the PR interval between will be short. However, since it also get excited by this AV node, it takes some time to repolarize, right? Because otherwise it's going to get fatigued. So while it's repolarizing, if you do another one, it's just going to take a little longer time to cause contraction. So that's why you're going to have a wider QRS wave. Okay. So results in re-entry supraventricular tachycardia. Even though it's happening as soon as it's relaxed, repolarized, there will be wider QRS, so wide QRS complex and short PR interval for WPW. You gotta remember that one, and you gotta remember ectopic foci. Okay, 4 minutes. I can discuss more about this. SVT, you gotta know how to figure it out. So here there's only one box, so that's 300 beats per minute, right? Now you see ST elevation, the T wave and P wave are overlapping each other, so you can't differentiate it between them. Then you have multifocal atrial tachycardia. So you have P, but the P wave is not the one that's causing the QRS anymore. It might at some point, but mostly it's coming from another place, not SA node to the AV node. Okay. Fibrillation, RRs are different. Everything is different. You can't make out P wave. Here you can make out P wave, but you have a sawtooth, and the RR is equal to RR2 and RR3. Here the RRs are different as well, but you can make out P wave. Here again, one box, 300. You do vagal maneuvers and IV adenosine. I guess that's why people pick vagus nerve, because it's called a vagal maneuver, but it's actually glossopharyngeal that takes the afferent fiber to the brain into the solitary nucleus, right? Then WPW syndrome, delta wave. Okay, I'll take a break. Cardias, right? Arrhythmia and description and ECG findings. Ventricular tachycardia VTAC. Typically regular rhythm. Rate is more than 100. QRS is more than 120 milliseconds. Most commonly due to structural heart diseases, for example, cardiomyopathy or scarring after myocardial infarction. High risk of sudden cardiac death. That's the one with death after 1 hour of cardiac symptoms. So yeah, there's like one and a half box there. Right, so 1.5 box there, so it's more than 100 anyways. Then we have torsade de pointes, torsade de pointes. So this is what the ECG would look like, and if you were to draw imaginary blue and imaginary pink line around it, it would look like this, like a helical DNA, right? So it's not called helical type DNA, it's actually called torsades de pointes, right? Polymorphic ventricular tachycardia, shifting sinusoidal waveform. Many progress to ventricular fibrillation. Long QT interval predisposes to torsades pointes. Caused by drugs, decrease in potassium, decrease in magnesium, and decrease in calcium. Right? So what would that look like in an ECG? So they would give you this, and then they'll ask you, or they might tell you that it's this, right? So it's big and small, right? So small and big. So if you were to draw a line like that, that's what it would look like. Or like this too. So this was his torsade de pointes as well. So learn to recognize that. Right? So if you would draw a line like that, similarly, it would be this. So they'll ask you, what would you see on ECG in torsade de pointes, or because of these drugs, you would see a long QT interval. That's what they're looking for. Okay. It's caused by drugs and also decrease in potassium, magnesium, and calcium. This is twisting of points. Treatment is magnesium sulfate. Drug-induced long QT, right? So long QT is because of A, B, C, D, E, F plus NO. Okay, so A for arrhythmias or antiarrhythmics, right? 1A and 3, or arsenic. B for biotics, antibiotics, macrolides, and fluoroquinolones. This is important because you give these a lot, right? It's pretty common to prescribe these, so know about that one. Antipsychotics like haloperidol, chloroquine, antidepressants for D, and diuretics as well, like thiazides. Antiemetics like ondansetron, and antifungal fluconazoles, Navier protease inhibitors, and opioid methadone. It's quite easy to remember, so remember these just like you would remember cytochrome P450 inducers and inhibitors. So this is also important to know. Ventricular fibrillation. Okay. Know the difference between the two ECGs. Okay. It's important to know the difference between, because they look a lot similar. So here, disorganized rhythm with no identifiable wave. Okay. And treatment is fatal without immediate CPR and defib. Okay. Conduction blocks. So for conduction blocks, in the old book they had this mnemonic that you could have used. So if the R is far from P, then you have a first degree, right? So first degree AV block, that's prolonged PR interval. So this is the PR, right? The start of P wave and, the R, I guess. So the start of P wave and R is long, but it's equal to each other sections of PR. Okay, So prolonged PR more than 200 milliseconds. Treatment is none required. It's benign and asymptomatic. Okay. You still have the this. You have a little U wave over there, then P wave again. Okay. Then longer drop. Then you have a Wickenbach. Okay. So second degree AV block. Uh, this is Mobitz type 1, also known as Wickenbach. Progressive lengthening of PR interval until a beat is dropped. Okay, so here PR1 is going to be lower than PR2, which is going to be lower than PR3. So PR3 is more than PR2, more than PR1. Right. So, and then you don't have ventricular depolarization at all after this. So P wave is there, but absent QRS, right? So longer drop, then you have a Wickenbach. Okay. If some P's don't get through, then you have Mobitz 2. So Mobitz type 2, that's drop beats that are not preceded by a change in PR interval. May progress to third degree block as it usually indicates a structural abnormality such as ischemia, fibrosis, or sclerosis. Treatment is usually a pacemaker. Okay, so if you see PR interval there, PR interval here. Here you see a P but no QRS, right? But this one is equal to this, so the P's are equal. Here it was less than this, and which was less than this, right? So again, if some P's don't get through, then you have Mobitz 2, right? So drop beats that are not preceded by a change in PR interval. May progress to third degree block. So we'll read about that, as it usually indicates a structural abnormality such as ischemia, fibrosis, sclerosis. Know these. Again, if the R is far from P, then you have first degree. Longer drop, then you have a Wickenbach. If some P's don't get through, then you have a Mobitz 2. And if P's and Q's don't agree, then you have a third degree. So third degree is a complete or AV block. Here you have the distance between P and P is the same as is R and RR complexes, right? However, RR does not correspond to the P's and the P's don't correspond to the R's, okay? So P waves and QRS complexes rhythmically dissociated. Our atria and ventricles beat independently of each other. Atrial rate is more than the ventricular rate, may be caused by Lyme disease. Lyme 3, right? LYM3. Treatment usually a pacemaker for this as well. That's the easy one to understand, because P is equal to P, so you can just count the boxes between them. So 1, 2 and a half. Again, 1, 2 and a half. 1, a half, 1, 2, 1, 2 and a half, right? So if you keep going like that, and this one has like 3, 3, 3, so 9 and a half, again 3, 3, 3 and a half, so 9 and a half again. But QRS is not going to be after the P wave, it's going to be by itself. Why? Because when you have a block like that, between SA and AV nodes, ventricle actually beats on its own due to signaled by his bundles. Okay, so let me write that out. In case of AV degeneration, else from his bundles? Okay. Is there anything else that I should be adding? No, that pretty much takes care of that. Okay. Then you can have bundle branch Brock. Remember, like in the heart, it goes to bundle branches. Interruption of conduction of normal left or right bundle branches, the vesicles. Affected ventricle depolarizes via slower myocyte to myocyte conduction from unaffected ventricle, which depolarizes via the faster His-Purkinje commonly due to ischemia or ischemic, for example, MI, or degenerative, for example, cardiomyopathy or infiltrative disease changes. That's just that. Nothing to explain there. Premature beats, arrhythmia description and ECG. Arrhythmia description ECG. Okay. So premature atrial contraction. When you have this, there's an extra beat arising from ectopic foci in atria instead of the SA node. So often secondary to the increased adrenergic drive, for example, caffeine consumption. Benign but may increase risk for atrial fibrillation and flutter. Narrow QRS complex with preceding P waves on ECG. They'll give you a good history for this so you can figure out that it's this and not, WPW or something like that. First of all, you have to figure out it's in atria and not the ventricles, right? You have the beat here, and you have it here, here, and here, and here. So what you're having is, normally the P wave is lower than the R wave, right? I mean S wave, T wave, sorry. Right, so the P wave here is smaller than the T wave, right? But say there's a synergistic, right? There are two P waves, or two SA node, or two P waves, which is atrial depolarization. So it's happening because of SA node and the ectopic node. You will have a P wave that's the same height as the T wave, right? So that's why it's up there. It's the same height as that. It's not smaller. So that's how you know that it's an extra beat when you're looking at a ECG like that. You gotta compare the P waves. Like here, P wave is smaller than T, P wave is smaller than T, and all of them, that's what you see, right? That's P wave smaller than T as well. These are P waves again. T only happens if there is QRS, right? So you don't see it everywhere. So if T wave follows a QRS complex, but if there's no QRS complex, you can just assume that it's a P wave. Okay. Again, same thing here, smaller and smaller, and everything except for this. It's even higher in this one, and higher in this one, same height as this one. So that's extra beat arising from ectopic foci in atria instead of the SA node, often secondary to increased adrenergic drive, benign but may increase risk of atrial AFib or aflutter. Narrow QRS complex with preceding P wave on ECG. Premature ventricular contraction, ectopic beats arising from ventricle instead of the SA node. So you have a shortened diastolic filling time and decrease in stroke volume compared to a normal beat. Prognosis is largely influenced by underlying heart disease. You'll have a wide QRS complex and no preceding P wave on ECG. When you don't have a P wave, you know that the QRS that's happening is because of something else other than the SA node uh, signal, right? So you have there's a P wave right there, and then you have QRS, and then you have T wave, and there's no P wave, and there's a sudden QRS, which is even greater response than this one in amplitude, right? I mean, P wave, normal, P wave, normal, but then somewhere in the middle there's a ventricular depolarization without the signal from SA node. So that's called premature ventricular contraction. So you have premature atrial that will have a higher P wave than a T wave, and in premature contraction that will have a QRS complex without the P wave. Okay. If notice how this is also looking like a shorter PR interval, but it's not a PR interval, right? Because this is a T wave, not a P wave. So don't confuse this with WPW. Hereditary channelopathies, arrhythmia description, Brugada syndrome, and you have congenital long QT syndrome. Okay. So Brugada syndrome is autosomal dominant, most commonly due to loss of function mutations of sodium channels, pseudo-right bundle branch block, and ST segment elevations in leads V1 and V2. So that's going to be a transmural one, right? In V1 and V2, so that's sternal lead. So this is going to be your anterior septal, anteroseptal ones, right? So this is autosomal dominant, most commonly due to loss of function mutation of sodium channels, pseudo-right bundle branch block, and ST segment elevation in lead V1 and V2 on ECG. Treatment is prevent sudden cardiac death with intracardiac device. Okay. Yeah, the way I have it in my mind is like this looks like Bermuda. So Bermuda Triangle, it loses everything, and it's an ocean. Ocean is salty. So SA node, Na or sodium channels, right? Because ocean is salty, so sodium channels get lost in the Bermuda Triangle. That's how I remember it. For congenitally long QT syndrome, it's caused by mutation in KCNQ1, right? It starts with K. Okay, so the way I remember this one is, okay, I'll tell you how I remember this one. So first of all, let's look up puppies. You see 3 puppies, okay? One of them is Jarvel, one of them is Launch, and the other one is named, let's do these ones are cute. Right, Jarvel, Launch, and Nielsen, okay? And see how their ears are down? So remember this photo, okay? And these are canines, right? So canines, so K. So loss of function mutation of potassium channels, this is important. Loss of function mutation for potassium channel causes the congenital long QT syndrome, okay? Why puppies? Because they're cute. This is a cutie, this is a cutie, this is a cutie, okay? And they're canines. So QT syndrome, canine, loss of mutation for K channels. Affects repolarization, and it includes, do this one. So Jarvel, Lange, and Nielsen syndrome, okay? Jarvel, Lange syndrome, Nielsen syndrome. So the ears are down, autosomal recessive. The ears are down, so that's sensory neural deafness. That's why I keep pointing to the ears, because this is the one that has sensory neural deafness. So they'll say in a question stem that a person has long QT syndrome, and there's a deafness in one of the ears or both the ears. Which channel from these would be mutated, or loss of function mutation happening in which channel? So it's the K channels, potassium channels, right? So it can be either of these three things that you need to connect to, either the K channel or the QT, long QT syndrome, or that it's going to have, if it's autosomal recessive, it's going to be sensory neural deafness. Again, last time, let's look at these puppies. They're so cute. They're cuties. Okay. The another one is like a, Romano, an Italian guy, and Ward, American guy. Not cuties, but for me, maybe for you. So Romano Ward syndrome, autosomal dominant, okay, but they're pure of heart, so pure cardiac phenotype. They don't have any deafness because their ears don't, drop like a puppy. So no deafness for that. So Romano Ward syndrome and Jarvo Lange Nielsen. That's Jarvo. That's Lange. That's Nielsen syndrome. Their ears are down. Sensory neural deafness. QT syndrome and K channels. Next, sixth sinus syndrome. This happens in older people. Okay. This is age-related degeneration of SA node. ECG can show bradycardia, sinus pauses, sinus arrest, and junctional escape beats. Okay. They might give you this, so you need to know what this ECG for this would look like. So a QRS, that's the SD, okay. That's a P wave, but no QRS. P wave, no QRS, and then here's a slight P wave, maybe. There's a QRS, right? QRS, P wave QRS, P wave QRS, and then again, it differs with the increase in SD segment. So age-related degeneration of SA node. ECG shows bradycardia. This is the most important sign. If they give you that this person is like over, 70, 80 years old and has bradycardia, the first thing you should think of is this sixth sinus syndrome, because this is in older people who have SA nodes degenerating. Then you have sinus pauses, right? So there's a pause over there. Maybe sinus arrest, so maybe a whole complex doesn't take place, or junctional escape beats. Okay, a P wave is there, but then there's nothing after it. Cool. Myocardial infarction complications. So complication time frame, findings, and notes. Cardiac arrhythmia, first few days to several weeks. It can. This is basically the complications we did up there. So that's what, now they're just, going into it. So cardiac arrhythmias, first few days to several weeks. Can be supraventricular arrhythmia, ventricular arrhythmias, or conduction block. This is due to myocardial death and scarring. Important cause of death before reaching to hospital and within the first 48 hours post-MI. So if a person comes to the hospital and then he dies due to MI, it's probably because of an arrhythmia, right, or a conduction block. It happens due to the due to the scarring. So this is cardiac arrhythmia. Okay, now we are doing peri-infarction pericarditis. This can happen between 1 to 3 days. Findings are pleuritic chest pain, pericardial friction rub, and ECG changes and or small pericardial effusion. So there's a question about this one. The question stems about a guy who has a chest pain, but then he feels better when he leans forward. Okay, that's pericardial friction rub. But then there's also this another guy who has chest pain and then he leans forward, but it still hurts. So what can it be? It's a muscle pain. It's due to chondritis. It could be because of rib pain or intercostal muscle pain or something like that. It's not because of the heart then. Okay. If they mention leaning forward, it's between these two. That's why. ECG changes and or small pericardial effusion. It's usually self-limited. Okay, papillary muscle rupture, 2 to 7 days, can result in acute mitral regurgitation. Again, papillary muscles support the valves, so acute mitral regurgitation. It can lead to cardiogenic shock and severe pulmonary edema. This is more common in the posteromedial than anterolateral. Papillary muscle rupture. Okay, as the posteromedial has a single artery blood supply, which is posterior descending artery, right? Because that's the inferior side, not the inferior, but like the one that's on the back, right? And it's only supplied by either one RCA or LCA, right? Depending on the dominance. Whereas anterolateral, although RCA is the most common one, whereas anterolateral has dual LAD and LCX, circumflex or anterior descending artery. Interventricular septal rupture, this is due to the macrophages, right? So it can happen between day 3 to 5, that's when macrophages show up after the neutrophils, which was after eosinophilic strip with the wavy fibers. Right? Symptoms can range from mild to severe with cardiogenic shock and pulmonary edema, macrophage mediated degeneration, ventricular septal defect causing a left to right shunt, increase in O2 saturation, and increase in pressure in right ventricle. You have ventricular pseudoaneurysm. This is due to the free wall rupture. Right after free wall rupture, actually, this is the last phase, I think, between week 1 and 2 is 3 to 14. So yeah, 3 to 14, second last phase, free wall rupture. That causes LV pseudoaneurysm. Okay, so pseudoaneurysm, 3 to 4 days. May be asymptomatic. Symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus. Rupture can also create cardiac tamponade. So free wall rupture contained by adherent pericardium or scar tissue. Right, so that's that thing right there can happen. Oh yeah, that's the papillary muscles right there, and that's the damage, I guess. What was it? Papillary muscle rupture. Okay. So yeah, that's what it looks like, a tree, doesn't it? With branches and then like this whole thing. This is the valve. Okay, and here's the aneurysm from the free wall rupture. So what that just means is that this rupture caused the blood to leak into the outside of heart, but the last layer of the heart, it couldn't break through it, so now it's just filling up, and the last fiber or the layer of the heart is actually keeping it contained. But that's the aneurysm. So it does not contain endocardium or myocardium, right? It only contains the ectocardium, or I don't know what it's called, but the outer cardium of that. Pericardium, I think, right? Then you have more likely to rupture than true aneurysm. Okay, ventricular free wall rupture can happen between days 5 and 14 as well. The free wall rupture, see this thing right here. Cardiac tamponade, acute form, usually leads to sudden death. Left ventricular hypertrophy and previous myocardial infarction protect against free wall rupture. Okay, so if there was a hypertrophy here, that can help protect against free wall rupture. Or even previous MI, because then there's scarring over there, which is stronger, I guess. Then you have true ventricular aneurysm. This can happen anywhere from 2 weeks to several months. So similar to pseudoaneurysm, symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus. Rupture will lead to cardiac tamponade, outward bulge with contraction, dyskinesia, associated with fibrosis. Post-cardiac injury syndromes of weeks to several months again. Fibrinous pericarditis due to autoimmune reaction. This happens because of Dressler's, so also called Dressler's syndrome. Cardiac antigens released after injury can causes deposition of immune complex in the pericardium, which causes the inflammation. Okay. There's type 3 hypersensitivity as well, right? You have acute coronary syndrome treatments. So for unstable angina or non-ST segment elevation myocardial infarction, anticoagulations, for example heparin, antiplatelet therapy, for example aspirin, plus ADP receptor inhibitor, for example clopidogrel, beta blockers, ACE inhibitors, statins, symptom control with nitroglycerin with or without morphine. Then you have STEMI, ST elevation myocardial infarction. In addition to above reperfusion therapy, most important percutaneous coronary intervention preferred over fibrinolysis. If right ventricle affected, for example right coronary artery occlusion, support venous return preload to maintain cardiac output, for example IV fluids, or avoiding nitroglycerin. Right. Okay, so again, unstable angina and NSTEMI. Right. This was the one with pain during rest, right? And this is the myocardial infarction because of subendothelial infarction, right? So that happens because of some kind of thrombus usually, right? So it could be blood thrombus or platelet thrombus. So you give heparin or you give aspirin, plus the ADP receptor inhibitors. These are clopidogrel. You can give beta blockers. Why? Because when you give beta blockers, what happens? There's decrease in heart rate and contractility, right? This causes decrease in what? The oxygen demand, right? So when you have decrease in oxygen demand, that's not gonna, that will help with decreasing the exacerbation because of that. Then you have ACE inhibitor, right? To decrease the blood volume. Hypertension, statins to control the atherosclerotic plaque, in case that's also a reason, right? So symptoms control with nitroglycerin with or without morphine to decrease the blood volume again and preload. Because if the preload is low, then what's going to happen? You won't need that much contraction. There's not going to be that much more, wall stress in addition to what it's already going through. So STEMI is in addition to about so you give all of this as well as you also do the reperfusion therapy, which is the most important because you don't want percutaneous coronary, you don't want, what do you not want? Dressler's or something like that happening over there. So percutaneous coronary intervention preferred over fibrinolysis, right? Also, you don't want the toxic buildup to spread throughout the whole heart, right? Through the coronary vessels. So you don't want that, basically. So what they're saying is it's better to do this one. This one, percutaneous coronary intervention that's going from, outside and then dealing with it mechanically, than dealing with it via drugs. Because basically, if you give fibrinolysis, what's going to happen? You have a thrombus between the artery, right? So fibrinolysis will break this up, right? But when you have broken this up, right, like that and like this can still travel to other places and like smaller vessels and then cause blockage in the smaller vessels, right? So that's why you don't prefer fibrinolysis. There, this vessel is blocked. Right, so that's why you don't prefer fibrinolysis. That's why we prefer for going in and mechanically removing it. Okay. If right ventricle is affected, for example, the right coronary artery occlusion, support venous return, preload to maintain cardiac output. Okay, so you can give IV fluids and avoiding nitroglycerine. Okay, because you want fluid coming in and supporting that area in the right ventricle. Okay, cardiomyopathies, dilated cardiomyopathies. So these are the only two you need to know about, and I think that's all that's given anyways. Restrictive as well. Okay. But these two are the main ones. So dilated cardiomyopathies. This is the most common cardiomyopathy. 90% of the cases, often idiopathic or familial. For example, due to mutation of TTN gene, encoding the sarcomeric protein Tintin. Right? Remember the cartoon Tintin? Adventures of Tintin. This cartoon. It doesn't help in any way to remember this. Just want to bring it up. Other etiologies include drugs, for example, alcohol, cocaine, and doxorubicin. Remember this one? Doxo and donrubicin, or don something. They create free radicals because ruby is like a stone, and that resembles free radical kind of thing. So those two drugs and cocaine and alcohol can cause dilated cardiomyopathy. What else? Infection. For example, Coxsackie B, the hand-foot-mouth disease, and also Chagas. Remember, Chagas make everything big. They make the esophagus big, they make the heart big, they make the colon big. Right? So you have megaesophagus, you have mega colon, and dilated cardiomyopathy as well because of Chagas. You have big tongue as well in Chagas. Ischemia. For example, coronary artery disease, systemic conditions, for example, hemochromatosis, sarcoidosis, thyrotoxicosis, and wet beriberi. This is peripartum cardiomyopathy as well. Okay, so all of these things can cause dilated cardiomyopathy. Findings: heart failure. You'll hear S3. S3 is because of what? The preload mixing in with the afterload. That's the sound it's going to make. And that the sound is designated as S3. Systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance on heart on chest x-ray. Okay. This is pretty easy. They'll just give you a specimen like this, and if you see it like that, you know it's dilated. But for that, you also should know what a normal heart dissection looks like. Okay, so that's what a normal heart looks like. Right, you can see how the chambers are small. The chambers are small here and here. And it's pretty tight, right? It's keeping the border pretty tight. See how the interventricular septum is right there, and look at its thickness, and look at the thickness of the left ventricle wall, right? There's a difference. You can make a difference because of that. So, okay. So, other etiology, we did that. Heart failures, S3, systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance on heart on chest x-ray. Treatment is sodium restriction, ACE inhibitor, ARBs, beta blockers, sacubitril, diuretics, mineralocorticoids, receptor blockers, for example, spironolactone, digoxin, ICD, and heart transplant. Dilated cardiomyopathy leads to systolic dysfunction. This is the cause of death usually, or cause of heart failure. Uh, Displays eccentric hypertrophy. So the sarcomeres are added in series. So that's just basically this is sarcomere, that's a sarcomere, that's a sarcomere, that's a sarcomere, that's a sarcomere. That's it's being added in series. Okay. Over here, it's gonna be added in parallel. So a sarcomere is gonna be added here. So here, this is the muscle fiber, right? Like that. Over here, the muscle fiber is like this and like this, right? So another one's gonna be added here, right under it. So this is gonna get bigger, and then another one's gonna be added in this under here in parallel, and it's gonna get bigger. That's why you get a bigger, layer of the wall, like that, right? So that's why you have a thick wall over here. Okay, there's something called Takayatsubu or Takotsubu cardiomyopathy. So we'll learn about that as well. Okay, so displays eccentric hypertrophy, sarcomere added in series compared to athletes' hearts, where LV and RV enlargement facilitates increase in stroke volume and increase in cardiac output. Right, so this you can figure out if it's like from the history as well. Stress cardiomyopathy, also called Takayatsubu cardiomyopathy. It's also known as the broken heart syndrome. This is usually the reason why you would hear like, okay, so there was a couple who've been married for like 80 years, and then the wife died, and then 2 days later the husband died as well, or maybe even the same day. So it's because of broken heart syndrome. The ventricular apical ballooning, likely due to increase in sympathetic stimulation because of the stressful situation. So what will that cause? It will cause decrease or increase in firing. It will cause decrease in firing, right? So right here, so decrease in stretch receptor and decrease in baroreceptor firing will cause sympathetic response. So the heart will then you know give off sympathetic chain, and then it will cause the blood vessels to vasoconstrict, pushing the blood into the heart. But then after it's in the left ventricle, since there is increased total peripheral resistance, it's going to have to work a lot harder, right? But that causes dilation and eventually heart failure because ejection fraction is not preserved. Okay. So hypertrophic cardiomyopathy. Okay, 60 to 70% of cases are familial autosomal dominant, most commonly due to mutations in genes encoding sarcomeric proteins such as myosin binding protein C and beta myosin heavy chains. Causes syncope during exercise and may lead to sudden death in young athletes, for example, due to ventricular arrhythmia. This is important, and it's also important to know the difference between hypertrophic cardiomyopathy and between inherited cardiomyopathy. So the one with the inherited one, you'll see a larger ventricular septum compared to the left ventricle wall. That will also have a hypertrophy, but you'll have hypertrophy more in size in the interventricular septum compared to this, right? Also, you'll have a smaller right ventricle compared to the one where it's only hypertrophy due to increase in blood volume. Okay. So Okay, let's read this again. Cases are familial or inherited, right? Autosomal dominant, most commonly due to mutation in genes encoding sarcomeric proteins. This is a born. This is a pathogenesis, or yeah, such as myosin binding protein C and beta myosin heavy chains. Okay. It causes syncope during exercise and may lead to sudden death. For example, in young athletes due to ventricular arrhythmia. So remember, myosin binding protein C and beta myosin heavy chains. Mutations that make these. Findings is S4. This is because it makes the ventricular wall firm that causes the sound. Systolic murmur may see mitral regurgitation due to impaired mitral valve closure. Treatment is cessation of high intensity athletics, use of beta blocker, or non-dihydrogen calcium channel blockers, for example, verapamil. ICD if high risk, avoid drugs that decrease preload, for example, diuretics, vasodilators. Diastolic dysfunction ensues, displays ventricular concentric hypertrophy, that's just this, sarcomeres added in parallel, so like that. Often septal predominance, myofibrillar disarray, and fibrosis. Classified as hypertrophic obstructive cardiomyopathy when left ventricular outflow tract is obstructed. Asymmetric septal hypertrophy and systolic anterior motion of mitral valve will lead to outflow obstruction, which will cause dyspnea and possibly syncope. Other causes of concentric left ventricular hypertrophy, chronic hypertension, and Friedreich's ataxia. So, yeah. Other than these causes right here, right? And young athletes. Restrictive. So if there's a young athlete that dies, it's usually because they had this hypertrophic cardiomyopathy. That's the reason. Restrictive infiltrative cardiomyopathy. Okay, so this is when they have fibrosis. So post-radiation fibrosis or Loeffler's endocarditis. That's the one with eosinophils. Rare restrictive cardiomyopathy caused by abnormal endomyocardial infiltration of eosinophils with subsequent tissue damage from degranulation, eventually leading to fibrosis. Okay. Endocardial fibroelastosis, thick fibroelastic tissue in endocardium of young children, amyloidosis, sarcoidosis, and hemochromatosis. So basically, the outside wall is going to, or even like the inside of the wall, in between the layers, which would be infiltrative, gets fibrous. So there's no muscle to function like a heart, right? So that's called restrictive cardiomyopathy. Diastolic dysfunction ensues. Can have low voltage ECG despite thick myocardium, especially in amyloidosis. So Loeffler endocarditis is right here. Okay, associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates in myocardium. Cool. Now we're on to heart failure. This is the test you check. So heart failure, that's the test we do. Like I said, you press it for like 30 seconds and check to see if it makes a dentation. We don't do this test to determine heart failure. We just determine to see if it has if the patient has pedal edema or not. Right. So clinical syndromes of cardiac pump dysfunction. This leads to congestion and low perfusion. Symptoms include dyspnea, orthopnea, fatigue. Signs include S3 heart rate sounds, rales, jugular venous distension, JVD, and pitting edema. So that's the pitting edema, right? Why do we do this? Because this means there's some kind of congestion happening, right? Which is causing buildup of pressure in the vessels in the legs. So why legs? Because uh, that's the one that has to work the most to bring blood from the legs to the heart, right? So, and it doesn't have valves in the veins either to help it push it up, right? So what happens is due to increase in the vessels, the interstitial hydrostatic pressure causes the leakage of fluid outwards, right? And that's the reason you get edema in the feet. Systolic dysfunction, heart failure with reduced ejection fraction, increase in end diastolic volume, and decreased contractility, often secondary to due to ischemia and or myocardial infarction or dilated myocardiopathy. Okay, so systolic dysfunction is heart failure with reduced ejection fraction, right? That just means that it's not pushing out the amount of blood that it normally does, so the cardiac output is decreased. So ejection fraction is reduced. Okay, normally it's around like, let's see, how much is it? Like 65, I think. 55 to 65. Okay, so 50 to 75 is the normal ejection fraction range, right? So anything below that is going to be, not preserved, not considered preserved. So borderline ejection fraction can range between 41 to 50. So normally they'll give you like a value that's 25 or 30 or 35. Okay. Okay. So increase in EDV, that's end diastolic volume, the amount of volume right before systolic starts. Okay. And decrease in contractility will cause systolic dysfunction. Diastolic dysfunction is heart failure with preserved ejection fraction. Okay. And you have normal EDV. Okay. Because why? Okay. And because the systolic functions normally, so the ejection fraction is preserved there. So the cardiac output is normal because of that. There's decrease in compliance, right? That's what it is. That means the wall is stiff. So there's increase in end diastolic pressure. So instead of 80, you'll have like 110 or something. Often for diastolic blood pressure. Often secondary to myocardial hypertrophy. Okay. So right heart failure most often results from left heart failure. Okay. Why is that? Because say you have this heart here. This is left atrium. Right atrium and right ventricle. Right atrium and right ventricle. Okay. This is coming in from the lungs. This is going out to the aorta. Over there. This is going into the lungs. This is the SVC and IVC. Okay. So when you have left heart failure, what that means is that it's not able to pump out the blood as much as it used to, and it's not able to do that, right? So what's that going to lead to? It's going to lead to buildup of the blood, which will, cause backlog of more blood in left atrium, which will cause pulmonary congestion because of the backlog of blood into the lungs, and lungs, will get congested. So you get pulmonary congestion. You can find heart failure cells there, and all this stuff. And dyspnea, orthopnea, all that stuff can happen because of this. What will this cause? Backup of blood here, and you can get Eisenmenger syndrome happening now because of increased pressure. So the right ventricle needs to work harder, so you can get all of these things happening there. What will this do? This will cause backup blood in here, right, into the right atrium, right? Then right atrium, if it pushes blood into the SVC as well, the backlog over there, or backup of blood over there, so that will cause superior vena cava syndrome, right? Increase in jugular venous pressure as well. You'll see that syndrome. Yeah. And if it goes down from IVC, it's gonna cause backup of blood in the hepatic or the liver, right? Now, liver is special because liver also has a portal vein, right? So portal vein, if that one also gets congested, what's gonna happen? Um, Portal vein has like 4 anastomosis, so wherever it has those sites are gonna feel the pressure as well, right? So that's why you get esophageal versus, because that's where the first one is. The second one is like uh, in the around the umbilicus, so you'll see like umbilical veins forming the medusa, right? uh, you can get like perforated or hemorrhagic, uh, like you can puke out blood and because of this if your esophageal versus bleeds, right? Perforates or ruptures. Then like there are other two that we'll talk about in GIT, but because of that there's also going to be you know backup of blood in the legs, and also there's all of this will increase the blood pressure. Increase in blood pressure is hypertension, and hypertension does what to the kidneys? It will cause the renal arteries to uh, basically form bigger muscles in the vessels. I don't know how to put it, but basically the blood flow is gonna get you know the artery is gonna get bigger, but the area the blood flows through is gonna get smaller, right? So that's how you get the arterial stenosis, renal arterial stenosis, due to hypertension in heart failure. Okay, and then your kidney becomes ischemic, and then your organ failure there. Okay, so that was a wrap up of that. Okay, so my heart. So right heart failure often results in from left heart failure. Uh, Cor pulmonale. This is just the part of heart failure along with the uh, pulmonary congestion. So it refers to the isolated right heart failure due to pulmonary causes, right? So for this, they'll say that the ejection fraction is normal. The left atrium has normal pressure as well, right? If they say normal pressure in left atrium, then it's not because of heart failure, okay? Because heart failure is the reason you would have increased blood pressure in left atrium. But if they tell you it's cor pulmonale, that means it's normal here. The pressure is normal. The PC pulmonary wedge pressure or whatever, right? The wedge pressure is normal for LA. But you have increased pressure in right heart, so right ventricles, right? So right ventricle because of pulmonary causes. Okay, it could be anything. It could be edema, it could be embolism or whatever. Okay, so ACE inhibitors, ARBs, anything that decreases hypertension, right? So ACE inhibitor, ARBs, angiotensin receptor, neprilysin inhibitors, beta blockers, except in acute decompensated heart failure, because you need the heart to pump over there. And aldosterone receptor antagonists decrease mortality and heart failure, REF. So that's this one. Reduce ejection fraction, heart failure. So aldosterone receptor blockers, right? So ARBs. No, that's angiotensin. So aldosterone receptor blockers decrease mortality in heart failure with reduced ejection fraction. So remember this point right here. That's important. Loop and thiazide diuretics are used mainly for symptomatic relief. Hydralazine with nitrate therapy improves blood symptoms and mortality in select patients. Hydralazine is safe to give in pregnancy as well, I think. Okay, so there's a whole mnemonic for that that we'll see in the pharmac section of this chapter. Okay, so left heart failure. Because of left heart failure, again, this thing over here, you get orthopnea, shortness of breath with supine because there's increase in venous return from redistribution of blood, immediate gravity effect, exacerbates pulmonary vascular congestion. Okay, so increase in venous return from redistribution of blood, immediate gravity effect. So, say you're sleeping, right? So your lungs are like this. Okay, when you're sleeping, it's just imagine you're sleeping and the whole body's over here. What happens to the blood supply here, right? It's going all over, right? It's going to distribute here, 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 and here equally, okay? And if you have backup of blood over here, right, backup blood here, and because of congestion, what's going to happen to this areas? There's remember the arteries are being pushed inwards now because of the outside congestion, right? Because there's already fluid leaking through it because of the heart failure. Okay, so before when you were standing, your lungs were like this, and all the fluid that leaked from the capillaries was pulling down here. Okay, so you don't feel that dyspnea while you're sitting or standing, but as soon as you fall asleep, all this fluid is now going to roll around and throughout the lungs from here to here to here to here, and that's why you can't sleep because you have difficulties breathing while you're sleeping. So that's why people prop up and put like two pillows in their head, under their head, and they sleep diagonally. So when they sleep diagonally, all the blood again pulls down here. So you have this much area that's capable of breathing. But when you're sleeping, all of the fluid is going to press every single artery there, right? So that's what shortness of breath when supine means. When you're sleeping, you have shortness of breath. Because there's increase in venous return from redistribution of blood, immediate gravity effect exacerbates pulmonary vascular congestion. Per example, nocturnal dyspnea, breathless awakening from sleep, increase in venous return from redistribution of blood, reabsorption of peripheral edema, etc. Okay. So when you sleep, what else happens? Your legs are now, laying down. So all of this now fluid that was here is now gonna seep back into the vessels, and then that's going to increase your venous return, right? So that's why the venous return from the redistribution of blood gets reabsorbed, and then that causes increase in venous blood volume in the right atrium, right ventricle, then the lungs, right? So the lungs is where you'll have increased congestion, basically. So breathless awakening from sleep, increase in venous return from redistribution of the blood. Oh, didn't realize that. Sorry about that. I didn't hear it. Okay. So shortness of breath when supine, increase in venous return from redistribution of blood, immediate gravity effect exacerbates pulmonary vascular congestion. We did that, we did this. Breathless awakening from sleep, increased venous return from redistribution, reabsorption, and that, we did that. Okay, now we're on to pulmonary edema. Similar concept, increase in pulmonary venous pressure. Right, venous pressure is this thing right here, that one coming into the left atrium, right? So increase pulmonary venous pressure. Remember, the artery is the one going from the right ventricle into the lungs, and the venous one is the one coming into the left atrium. So increase in pulmonary venous pressure will cause pulmonary venous distension and transduction of the fluid. Okay, transduction is just going into the outside of the vessel kind of thing. Presence of hemosiderin-laden macrophages. These are the heart failure cells. Okay, you should know what these look like, because don't confuse it with the lipofuscin, age-related pigmentation, right? So this is hemosiderin-laden macrophages. They'll give you some kind of indication that it's, in the question, that it's some kind of a heart problem, because then you also gotta remember what is hypofuscin. Remember, so that looks like this. Okay, so it looks similar to the heart failure cell, right? The hemosiderin. So that's lipofuscin, and yeah. So just figure out how to spot the difference between the two. Most of it, majority of the time, you'll figure it out from just the question itself. But yeah, pulmonary edema, if it's because of heart failure, you'll find these there. Okay. Why? Because when this happens, there's breakage of, I don't know. Also, hemosiderin also causes pigmentation in the legs. And that will cause cellulitis kind of appearance, right? This causes depigmentation over here. Okay, so yeah, wherever it goes, it causes pigmentation. It's because of destroyed cells leaking out hemosiderin, and then that hemosiderin gets deposited wherever it can get. And majority of the time, it's going to get deposited down here in the legs, and that's why you get pigmentation because of that. Okay, now we're dealing with the right heart failure, this part of the heart. So congestive hepatomegaly, increase in central venous pressure will cause increase in resistance to portal flow, right? We already talked about that. Because of this, it's gonna cause backup of blood in IVC, which will cause backup of blood in the liver, which will cause increased resistance to the portal flow. Rarely, also, okay, we'll talk about that in GIT. I don't want to add too much and overwhelm you guys. So, leads to cardiac cirrhosis, okay? Associated with nutmeg liver, mottled appearance on gross examination, gross exam, okay? So, right heart failure can cause congestive hepatomegaly. It can cause jugular venous distension because of, again, if it goes up in SVC, right? Superior vena cava, because that gets tributaries of jugular veins, right? And the head and neck. Right? Peripheral edema is, why do you get peripheral edema? It's because of increase in venous pressure, which causes fluid transduction. We talked about that already. Okay, so let's just look at this graph real quick. Decrease in cardiac output will cause what? Increase in the sympathetic tone. When that increases, what happens? You get beta 1 and alpha 1 action. Okay, beta 1 action causes increase in heart rate and increase in contractility. Increase in contractility will cause increase in stroke volume. Increase in heart rate will maintain cardiac output. So will stroke volume, right? What's alpha 1 action? It's vasoconstriction, right? So you have vasoconstriction, increase in arterial tone and maintain blood pressure, increase in venous tone, increase in venous return to the heart, or preload. Okay. So vasoconstriction, increased arterial tone will maintain blood pressure and maintain the cardiac output. Eventually, this is what we want to do, right? And because this is what basically means if the ejection fraction is maintained or not. So that's what everything is about. Okay, so alpha 1 vasoconstriction, increase in venous tone. This will cause increase in venous return to heart, or also called the preload. Okay. Remember what preload was? It's the amount of blood that gets poured into the left ventricle. That's how we read it. But this is preload of the heart. That means the amount of blood poured into the heart. Okay. Increase in renin-angiotensin-aldosterone system, right? Because there's decrease in cardiac output. The brain's gonna think that there's not enough blood volume, so to increase the blood volume, it's gonna increase reabsorption of the water, right? So increase of water happens because of reabsorption of sodium, while it excretes potassium out. That's aldosterone's thing, and aldosterone causes a reabsorption of sodium and excretion of potassium. Okay. So through that system, and also angiotensin 2 is known to cause vasoconstriction. Okay, so don't forget about that. So via angiotensin 2, it's going to cause that. Antidiuretic hormone does exactly that. It prevents diuresis, right? So also it acts on V1 receptors as on the vessels, causing vasoconstriction as well. Okay, so these two, remember. So that will cause increase in venous tone. Increase in venous return will cause stroke volume to increase, which will maintain the cardiac output. On this side, you have angiotensin 2, aldosterone, and ADH acting in the renals, or V2, right, to reabsorb more water. These will absorb through the sodium, and this will absorb through the collecting tubule principal cells of the renal, and it will cause via aquaporins. That's what the word, yeah, aquaporins. So it doesn't rely on sodium ions. This will just bring in the water without the sodium. These ones bring in the sodium. Okay. Increase in circulating volume, which will increase venous return to the heart, and stroke volume will then maintain cardiac output. If you don't understand this concept right now, you will once we do renal, which is I think next. So we'll figure it out then. Okay, but for now, just remember, if there's decrease in cardiac output, you get beta 1 alpha 1 action. Okay, and that's to preserve ejection fraction or maintain cardiac output. Okay, so what would that look like? This is the diagram that you will find when they're asking about it, and we did in physio, we did that in physio somewhere. Right there. Where'd it go? I think I skipped it. Somewhere here. That's weird. Where did it up there? Am I just going over it? I probably passed it like twice. Okay, there we go. So this thing right here, right? So if you remember this from yesterday, that's what you're talking about. Okay, so reduced ejection fraction is the systolic heart failure one, right? Systolic dysfunction. Where was that? Systolic heart. Wow, I'm so bad at navigating this. Okay, there you go. Systolic dysfunction, heart failure. Obviously, it's under heart failure. Okay, so that one was with reduced ejection fraction, and diastolic's the one with the preserved one, because the systolic works great. Okay, so what are you going to see when they give you a diagram like this? You got to figure out the contractility So that's this thing right here, this line, right? And you can see compared to this line, this one is further away from this point, right? And that's how you figure out if the contractility is reduced. Okay. Okay. And then the compliance is the same here. Okay. So if you go like this and you make a like this graph right here, the compliance is on the same line. Okay, so there is no difference in compliance with the systolic one. Okay. However, in the preserved one, the compliance is reduced, right? It's gone up like that. You're not gonna get reduced compliance is like that, I guess. Okay. Just remember this graph because I'm not able to explain it right now, but yeah. This is weird. Okay, so I guess this line you can just think of it like that. If the distance between this and this is reduced compared to the black diagram, so that's from here to here, you can, I guess, say that the compliance is reduced because of that. So you can try it out like that. Okay, they didn't give us compliance here, so it's hard to figure out how that is. You'll figure it out in UWorld eventually. Okay, so pressure, so contractility is reduced in systolic, right? Because systole is basically ventricular contraction, so something's wrong with the contraction, so contractility is reduced. That's why you have reduced ejection fraction or the cardiac output. Okay, so the graph, the stroke volume is from here to here, right? So this distance is from here to here, and we can tell that it's similar. So the stroke volume is the same. It's just the contractility that's reduced. Okay. We put a line across like that. The afterload is increased a little, right? Obviously the end diastolic volume from here to here is increased, right? Because this is like the middle part. This is end systolic volume, this is end diastolic volume. So end systolic and end diastolic both are increased in this, which is why the stroke volume is preserved, right? However, the ejection fraction is still reduced. Okay. Over here we have similar stroke volume. However, the afterload is a little increased, but the end diastolic volume is almost the same as is end systolic volume. Just the compliance is reduced. Okay, that's preserved. Again, preserved is the diastolic one, and reduced is the systolic dysfunction. Okay. You'll be given a chart like this and told that this person has heart failure, and this is the chart that they got from the test. And then you have to figure out which one is it. Is this systolic or diastolic dysfunction? It's pretty easy to figure out, right? Just look at the compliance and you're good to go. Because here the compliance is the same, right? It's similar. This line and this line is the same distance between the two, so the compliance is there. However, the contractility is not. Okay, high output heart failure. So this is where you have, okay, uncommon form of heart failure characterized by increase in cardiac output. High output state is due to decrease SVR from like SVR, that's systemic vascular resistance, right? So decrease in systemic vascular resistance from either vasodilation or atriovenous shunting. Okay, AV shunting is, again, it's when the blood goes from atria to the veins without passing through the capillary network. Why? Because capillary network is the one that has increase in area cross section, right? So it reduces the pressure. However, here it's going to increase because it's going directly into the from one big vessel to another big vessel. Causes include severe obesity, advanced cirrhosis, severe anemia, hypothyroidism, wet beriberi. That's the one with the hypertension. Paget's disease of or Paget disease of bone presents with symptoms and signs of pulmonary and or systemic venous congestion. Okay, shock, inadequate organ perfusion or and delivery of nutrients necessary for normal tissue and cellular function. Initially may be okay. Initially may be reversible, but life-threatening if not not treated promptly. Okay, so there are 4 types of shock. You need to know this chart because it comes in many systems, right? So for hypovolemic, it can come in hemat, cardiac is this, obstructive, it can be lungs, and you can have distributive and like micro as well as neuro. So this is how you figure out what kind of shock it is. Okay, so hypovolemic shock caused by hemorrhage, right? It's leakage of fluid or volume of blood. Okay, so you have low blood or low volume of blood, so you go into shock because shock is inadequate organ perfusion and delivery of nutrients, right? So hemorrhage, dehydration, and burns. Mechanism is volume depletion. The skin, it's not gonna, it's gonna be cold and clammy actually, right? Then you have central venous pressure, right? So right heart preload. Preloads the amount of blood poured into the right heart, so right atrium, via SVC and IVC. That will decrease. Then you have left atrium, right? So if preload is decreased, obviously the blood coming from the lungs is going to be decreased because it receives blood from right heart, right? Then if there's low preload, then you have obviously low cardiac output. Okay. Now remember when we read in hypoxia, vasoconstriction happens in the lungs, but everywhere else there's vasodilation. However, in hypovolemic shock, don't confuse it. In the systemic vascular resistance, it increases. Why? Because since there's low blood, the brain tells what? In decrease cardiac output, what's going to happen? The brain's going to, sense it, and it's going to send out sympathetic signals, right? So sympathetic signals are going to do what to the vessel? It's going to vasoconstrict. So vasoconstriction is going to cause what to the systemic vascular resistance? It's going to increase it. Okay. Then we have SpO2. That is what? I think that's just okay. So mixed venous content. So how much oxygen is going to be in the veins, venous side? Because oxygen gets picked up from the arteries and then it goes into the vein, right? So you would imagine that since all the organs are being deprived of oxygen, as soon as it comes, it's gonna pick it up. So by the time it reaches the veins, it's not gonna have as much oxygen as it used to normally, right? So it's gonna be decreased. Okay. Sorry. Cardiogenic shock. Myocardial infarction. It's caused by myocardial infarction, heart failure, vascular dysfunction, or even arrhythmias. Mechanism, left heart dysfunction, right? That's the mechanism, because this horrible diagram I made, remember that. Okay. Then again, blood's not reaching organs, so it's going to be cold because it's not able to bring in the core heat into the other parts of the body. Okay. The right heart preload is going to be what? It's going to increase. Okay. This is central venous pressure. It's going to increase as well. You can just imagine, like, it's trying to pour into the heart, but the heart is already backed up, right, because of the left heart. dysfunction. So left heart is going to cause backup of, oh god, I'm doing this again. Backup of left atrium into the lungs, backup into the right ventricle, and then right atrium. So it's going to cause backup in this IVC and SVC, and if it's doing that, then it's going to do it to all over the place. So central venous pressure is going to be increased, right? That's how that is. Again, it's the left heart dysfunction, so pressure is going to increase in the left atrium as well. Cardiac output, however, since it's a left heart dysfunction, it's not able to perform its duty, right? So the cardiac output is going to be decreased. Systemic vascular resistance, again, it's being deprived of hypovolemic, so it's being deprived, right? Again, cardiac output is decreased. It's going to send signals to the brain. Brain's going to think we don't have enough blood in the vessels and stuff like that. So again, sympathetic response. Sympathetic response is going to cause what to the arteries. It's going to cause vasoconstriction, right? Again, same thing here. Mixed venous content. By the time blood gets to the veins, it won't have any amount of oxygen left. Okay. Now obstructive shock. These are your cardiac tamponades or pulmonary embolism or tension pneumothorax. Okay. This is a physical obstruction in the flow of the blood. Okay. That's what this is. So flow of the blood can be impeded by the embolism in the lungs, right? After it goes from the right ventricle before it comes into the left atrium. Or it can be because of cardiac tamponade. That's this thing right here, fluid in the heart layers. Didn't tell you that here, but pericardial space, I guess, right? So in the pericardial space there's fluid, so it's pressing into the chambers, and it's preventing preload and all that stuff, or it's affecting that. So, and then you have tension pneumothorax. Tension pneumothorax is again pressing onto the lungs, so it's being impeded. The blood flow is being impeded in the lungs. Okay. Mechanism is right heart dysfunction. Okay. So left ventricle and left atrium are not affected. They are going to have normal amount of pressure in them, but pressure is going to increase in the right ventricle and right atrium, and central venous pressure, right? Because SVC, IVC, and all that. So that's going to increase. Left atrium, heart preload. What is this? Okay, it's increased in cardiac tamponade, but it's apparent. Okay, it's apparent because it's relative to a normal. It should be normal, but the pressure is not created by the blood. It's created by the outside border. Okay, what does that mean? I'll try it out. So you have right atrium over there. Left atrium over there, and you have left atrium here. Left ventricle here. Okay, and now this is the heart, right? So it goes like that. So now the cardiac tamponade is when you have blood in the layers of this, right? So when it's filled up like that, it's going to keep filling up and whatever, for whatever reason, and wherever it's coming from, it's probably coming from the aorta or something, right? The leakage is coming from there. This thing is going to build up. It's going to push this way, and it's going to push downwards as well, right? Into the thing. So when it's pushing downwards, this thing can, go into it and build up the pressure because of that. It's not that the blood is coming in and then pushing into the walls and creating the pressure. That's not what's happening. What's happening is it's the cardiac tamponade pushing it. So that's why it increases in cardiac tamponade. Otherwise, it's normal. Okay. And then you have cardiac output, which is going to be decreased because, again, normal pressure or lower. Right? So decrease in cardiac output. If you have decreased cardiac output, it goes to the brain. Brain signals sympathetic response, and then you get increase in vasoconstriction, causing SVR to increase. Okay, and again, they're being deprived because of decreased cardiac output, so mixed venous content is going to be decreased. Okay. All of these will cause skin to be cold and clammy. Okay, hopefully I was clear about those things and you'll remember it now. Distributive shock, sepsis, and anaphylaxis. This causes what? Systemic vasodilation. Okay, because remember, sepsis causes what? Increase in neutrophil. Neutrophils do what to the permeability? It increases and it causes vasodilation, right? So that vasodilation causes what? It causes warmth, right? Vasoconstriction causes cold, and vasodilation will do the opposite. So it causes warm and dry skin. Central venous pressure, what's happening to that? It's causing vasodilation, so obviously it's going to be reduced. In left heart, preload will be reduced because there's decrease in venous return because of vasodilation, right? Then you have cardiac output. Cardiac output is going to be increased because you have decrease in systemic vascular resistance, so there's no resistance whatsoever. So whatever the heart puts out is gonna just gobble it up. And then you have in SVO2, it's increased. This is mixed venous content because it's vasodilated. It's getting enough oxygen, I guess. So that's the important one you gotta remember. This is the only one where it's increased. Okay. And then you have CNS injury. So now your sympathetic is not gonna work, right? So even when you have cardiac output decreased, you have decrease in SVR because you have CNS injury, so it's not functioning great. So systemic vasodilation, again, warm and dry. Your vasodilation, so decrease in venous return, so decrease in this CVP and decrease in left atrium. Cardiac output is decreased, so it should cause sympathetic response in the brain, but brain is not at work today, so decrease in SVR. And mixed venous content, so normal or increased because it's still vasodilated, so it could be increased or it could be normal. Okay, cardiac tamponade. So what is cardiac tamponade, right? So you see a right ventricle here, and then you see left ventricle here, and you see this space right here, the pericardial space, is filled with fluid. Okay, because this is the outer layer of the heart. So between the outer layer and the inner layer, there's this pericardial space which is filled with fluid. So compression of the heart by fluid, for example, blood or effusion, which causes decrease in cardiac output. Equilibration of diastolic pressure in all four chambers, finding is Beck triad. Hypotension, distended neck veins, distant heart sounds. Increase in heart rate, pulses, paradoxes. ECG shows low voltage QRS and electrical alterons. This is important because with this you can just figure out what it's cardiac tamponade, but also because they might not give you the ECG, but they just tell you that there's electrical alterns, or they can, something like that. So why does this happen? It's because of this fluid. When the heart beats, you can imagine there's like a wave happening into it, right? So the wave is going to push into the wall and all that. So it's going to cause a swinging movement. So due to swinging movement of the heart in large effusion. Okay. Echocardiogram shows pericardial effusion, like that. Systolic right atrial collapse. So when basically what that means is when this is pushing, left ventricle is pushing or contracting, it's gonna push the pericardial space as well, and this pericardial space then goes into the other side and onto the part where there's right ventricle, and basically the right ventricle is going to collapse because of the pressure of this fluid being pushed by left ventricle. Because remember, before this it was just pushing into whatever the empty space was, right? But the empty space here is less resistant than the systemic vascular resistance available, right? So that's why it's going to push into this area as well compared to this. So first it's going to push into this, and then it's going to push into the other side, I guess. You don't have to know all that. Just remember that there's electrical alterance. So what is electrical alterance? You see how the R wave here is over here on this line? It's on this line. Sorry. Okay, on this line, right? But if you move over here, it's a little down. If you move here, it's a little up. If you move over here, it's down, right? So the change in R wave amplitude is what that means. Electrical electrons. So it shows low voltage QRS. Okay. Also, there's this. When I told you about the leads and how it does it. So you have V1 here, and the electrical impulse comes towards this lead, right? So when it comes towards the lead, it goes up, and when it goes away from this lead, it goes down, okay? So it goes down from here, right there, okay? And then, again, it's going from here to here, and then after it reaches here, then it disperses into other areas of the heart, and then it picks up over there. For if you're looking at V5 compared to V5, this is coming towards V5, so it's gonna have a positive wave, and then it's going away from V5 from like over here after it turns, right? After it turns in this direction, like this direction, it goes down. Okay, so that's how ECG works. So echocardiogram shows pericardial effusion. So pericardial effusion. We did that. Okay, diastolic artery collapse. So how would you treat this? You just put in a needle and suck up all that fluid. So pericardiocentesis, or you can do a surgical drainage. The buzzword here is pulsus paradoxus, but they don't say pulsus paradoxus, they describe this. So how will they describe it? That there is a decrease in amplitude of systolic BP by more than 10 mmHg during inspiration. So they'll say that, they might just say this outright, or they might say that during inspiration, the blood pressure is 130, and then during expiration, the blood pressure is 115, right? So that's more than 10. That means there's pulsus paradoxus. Increase in venous return. This is because of increase in venous return during inspiration. Remember the diaphragm, it pushes into the, diaphragm, it pushes outwards, creating negative pressure into the lungs, which causes increase in venous return because it's like a suction effect. So this causes increase in renal ventricular filling, which causes interventricular septum to bow towards left ventricle. This is due to decrease in pericardial compliance. Decrease in pericardial compliance, that just means this thing can go further this way. Make that red as well. Right, so it can go further this way. So when this thing pushes this way, or when it contracts, it's gonna also contract this way a little, right? Because the fluid here is busy going this way. So when it's going this way, there's less pressure on the pushing this way onto the interventricular septum, right? So I don't know why I'm going into this much detail. You don't need to know it, so I'll just move on. Interventricular septum bows towards left ventricle due to decrease in pericardial compliance. Decrease in left ventricle ejection volume, okay, and then that causes decrease in systolic blood pressure. It's seen in constrictive pericarditis. So this is important. If they tell you that there's pulsus paradoxus, Uh, it can happen, of course, in cardiac tamponade. However, it also happens in constrictive pericarditis, obstructive pulmonary disease like croup, obstructive sleep apnea, asthma, or COPD, right? Uh, then you also cardiac tamponade that we just did. So PCO is like the word for it, but you can just remember it by itself. So pericarditis and obstructive pulmonary disease. So obstructive ones are the croup, OSA, asthma, and COPD. Okay. On to infective endocarditis. So this can be due to bacterial and non-bacterial causes. So we'll learn about that as well. Okay. Infection of the endocardial surface of the heart typically involves more than one heart valve caused by bacteria more than fungi. Okay, majority of the time. Forms in acute is classically S. aureus, high virulence, large destructive vegetations on previously normal valves, rapid onset. Normally, it's gonna be due to a person who abuses drugs, so IVD, right, intravascular drug abuse. So you see that yellow pigmentation, that's the S. aureus. On the tricuspid valve, that's one cusp, that's second cusp, and that's the third cusp. And they split it in half, so that's 1, 2, and 3, 2, and 1. Okay, classically S. aureus, high virulence, large destructive vegetation on previously normal valves. Okay, so classically it's going to be that. If they don't give you any other cause other than they tell you that this person used to abuse drugs and back then, it's going to be S. aureus. Unless they tell you that this person went in to have dental procedure done, then it's going to be subacute, classically virulent streptococci, low virulence, smaller vegetations on congenitally abnormal or diseased valves, right? So remember, S. aureus produces dextran, and the dextran attaches to the aggregational aggregated platelets. Why do you have platelets there? It's because you will have platelets wherever you have damaged, right? So if you have damage in the heart valves, right? So diseased heart valves, you'll have platelets there, and then Virtins makes dextrans, so on itself. So dextran then attaches to the aggregated platelets, and then now you have Virtins on your heart valves. Okay, so smaller vegetations on congenitally abnormal or diseased valves. Sequelae of dental procedures, gradual onset. Presents with fever, most common new murmurs, vascular and immunologic phenomena. Vascular phenomena, septic embolism, petachi, splinter hemorrhage. They'll give you one or two of these, right? They'll say that there's a linear line in the nails, and they tell you, you know, it's endocarditis. That's like the number one thing. There was a story about this, you know, manicurist or pedicurist, you know, those people who do the nails for the guys. The pedicurist was doing like nails on this one woman, and she noticed this line, so she went home and looked it up on Google because she was concerned about the line. She had never seen it before. So she looked it up and she found out that it's because of infection in the heart. So like in the middle of the night, she calls up her client and tells her that this is what she found and she should get it checked. So she went to the hospital the next day, and lo and behold, she was suffering from an infective endocarditis, and it wasn't symptomatic yet. So she saved her life. Okay, back to this. Splinter hemorrhage, linear hemorrhagic lesions on nail bed. Genway lesions. These are painless, flat, erythematous lesions on palms and sole. Okay, why does this happen? It's because the vegetation, it goes through the circulation, and it causes microthrombitis. Okay, it's just thrombus, so it's obstructing the flow of blood. That's why you have these lesions on palms and soles. And obviously they're going to be tender, Well, no, sorry, they're not tender. Sorry, my bad. They're painless. Okay, because why? Because usually they're gonna have like collateral circulation, I guess. That's why it's not painful. Immunologic phenomena: immune complex deposition, glomerulonephritis, Osler nodes, painful, raised, villous lesions on the finger and toe pads, things like that. Rot spot, you should know what that is. Retinal hemorrhagic lesions with pale centers. However, they will give you this splinter hemorrhage. That's the buzzword for endocarditis. Okay, especially if they tell you that's because of drugs. Okay, because here, mitral valve most common, more than aortic valve, and tricuspid valve involvement is associated with injection during drug use. Don't try drugs. Okay. Why tricuspid? Because that's the first valve that the bacteria comes across, right? Because it comes from SVC and IVC and then into the right atrium, and first valve it comes across is tricuspid valve, so it attaches there more commonly. Because once it goes into the lungs, yeah, it acts like a filter sort of thing, right? So common associations: prosthetic valves, so S. epidermidis. Remember that's novobiosin sensitive. GIGU procedures, enterococcus. Then you have, enterococcus. Then colon cancer, S. galacticus, formerly as bovis. This is the one where if you find these in lungs, chances are you have colon cancer. Gram negative, HEC organism, that's Haemophilus aggregatibacter, formerly known as Actinobacillus. Cardiobacterium, Echinella and Kingella. Then you have culture negative Coxiella bartonella, that's cat scratch disease, and that's Q fever one, with amniotic fluid, animal's amniotic fluid. Injection drug use. So with that, firstly, if they don't give you any other clues other than telling you that it's just this person used to abuse drugs, it's going to be SREs. If they tell you that the culture makes bluish greenish pigmentation, it's going to be this. And if they tell you he has HIV, it's going to be this. Okay, or like oral thrush or something like that. I don't know. Not for endocarditis though. Endocarditis, it's usually something serious if you have fungal infection, right? Endothelial injury. So formation of vegetation consists of platelets, fibrin, and microbes on heart valve. Right. Valve regurgitation, septic embolism, systemic circulation in left-sided endocarditis, pulmonary in right-sided. Diagnosis requires multiple blood cultures and echocardiography. Okay. So then there's also non-bacterial thrombotic endocarditis, which is also called merantic endocarditis. Rare and non-infective vegetation typically arise on mitral or aortic valve and consists of sterile platelet-rich thrombi that dislodge easily, usually asymptomatic until embolism occurs. Okay. So again, vegetation typically arise on mitral or aortic valve for non-bacterial thrombotic endocarditis and consists of sterile platelet-rich thrombi. Okay, it's sterile because it doesn't have any bacteria in it, so there's no infection. Platelet-rich thrombi. This is the reason why that lodges in easily, right? So this is the reason why there's thrombus. Usually asymptomatic until embolism occurs. So you won't notice it until it lodges into like a small capillary somewhere and it causes, symptoms. Associated with hypercoagulable state. Hypercoagulable is just, you have a lot of clotting factors in your system, including platelets, which causes that. In advanced malignancies, so associated with hypercoagulable state and seen in advanced malignancy, especially pancreatic adenocarcinoma, okay, or SLE. This is also called Liebman-Sachs endocarditis. Remember this word because that's the one for non-bacterial. They'll give you they'll give you a list of reasons of why there's endocarditis, and then what you get out of it is that there's no bacterial infection anywhere. Like the neutrophils is normal, and eosinophils are normal, and all that stuff. Um, so then, in the option, you have to look for Liebman-Sachs endocarditis, right? Because that's the one that's non-bacterial thrombotic endocarditis. Okay, and it happens because of either thrombi, platelet-rich thrombi, or because of hypercoagulous malignancy, like pancreatic adenocarcinoma or SLE. Rheumatic fever, a consequence of pharyngeal infection with group A beta hemolytic streptococci. So beta hemolytic ones are the pyogens and agalacti, right? Late sequelae include rheumatic heart disease, which affects heart valves, right? So that's the pyogen one, right? Late sequelae including rheumatic heart disease, which affect heart valves, mitral more than aortic, more than tricuspid. High pressure valves affected the most. Okay. So yeah, that's the way to remember this. Rheumatic heart fever, right? Rheumatic fever. So early valvular regurgitation, late valvular stenosis. Okay, early valvular regurgitation. Okay, so initially you're gonna get regurgitation through these valves, and later you'll have stenosis. It's associated with Ashkoff bodies. These are granulomas with giant cells. You need to know what these look like. And it's basically these things over here. Blue arrow. Right. So right there. But more importantly, let's see what it looks like. Okay, that's a diagram. So that thing right there. It's hard to figure out in a photo. It's hard to figure out in the photo, but let's see. Okay, so like that. What's easier to figure out is like the Ashkoff body is gonna have these little cells. They're called actinoshav or anitoshav cells. I've never read this word out loud, so right now I realize I've been saying it wrong in my head. But Antishokov cells, right? So these are enlarged macrophages with ovoid, wavy, rod-like nucleus, right? I call it the caterpillar cell because it looks like caterpillar, and that's what they're called as well. Okay, so that wasn't special. But I'll show you what they look like. It's not anti, it's anit. Okay. So these things right here. Okay. Let me do it. Yeah, so see how it looks like a little caterpillar inside the cell? And those. And they're found in a larger giant cell, which is called the Ashkoff body. Okay, but if you start seeing these kind of cells, it's rheumatic fever. It looks like that thing, right? Cool. I think that justifies it. Okay, so it's associated with Ashkoff's bodies, granuloma with giant cell. And Anichakov cells, enlarged macrophages with ovoid, wavy, rod-like nucleus, red arrow in A, right there. increase in anti-streptolysin O or ASO, and there is increase in anti-DNase B titers, right? So if they tell you there's increase in ASO titer, that only happens because of S pyogenes, and it's because of rheumatic fever. But if they tell you that it's that anti-lysin streptolysin O is normal or negative, the titer, that means you shouldn't think of rheumatic fever or strep pyogenes. You should move on from that thought of process, right? Even though it seems like this would be the answer, don't pick it if they tell you this is negative or normal. They don't really give you titer for this though. Anti-DNase B titer. Immune, because that's non-specific basically. That's why. Immune-mediated type 2 hypersensitivity, not a direct effect of bacteria. Antibodies to M protein cross-react with self-antigens, often myosin, which is called molecular mimicry. Quickly, I went over this in micro as well. What happens is once your body develops antibodies to the M protein on the bacteria, the antibodies, after it clears off the infection, it goes looking for M protein everywhere in the body, right? So whatever resembles this, which are myosin, right? So in the heart valves, on the myosin and the heart valve is where they find that. So they resemble the structure for M protein. So that's why it's called molecular mimicry. So now the antibodies that were created to fight off M protein are going to attach to the myosin on the cardiac cells, and this will cause your rheumatic heart disease. Okay. Treatment prophylaxis is penicillin. So these are the symptoms that you come across. Migratory polyarthritis, that's joint. Remember, this is for this as pyogenes, but also there are septic arthritis and reactive arthritis, right? So you have to remember about that too. Septic arthritis is S. aureus and gonorrhea and streptococcus. Reactive arthritis is because of Campylobacter, E. coli, Salmonella, Chlamydia, Yersinia, Shigella. Right. There's also monoarthritis just happening at one place. That could be because of septic or septic arthritis, arthrosis, rheumatic disease like this one, and crystal arthropathy. Then there's migratory arthritis, right? So that's because of gonorrhea as well, but they'll give you that there's a diplococci seen on culture or like under a microscope or something. But also this, and then there's also one that's migratory thrombophlebitis, I think, and that's due to malignancy or cancer. Okay, so joints, migratory polyarthritis, carditis, nodules in skin, erythema marginatum. This is the bullseye one that you see due to Lyme's, but right, so it looks like a bullseye like that. Okay, bullseye right there. Okay. Then you have Sydenham chorea. These are involuntary irregular movements of limbs and face. Okay, so if you have all of these things in a question stem, it's going to be rheumatic fever because of strep pyogenes and group A beta hemolytic. Right. Sorry, group A, yeah, they give you that. Okay, so that's going to be strep pyogenes. So if they remember, group B is the A-galacti one. Okay. Syphilitic heart disease. So tertiary syphilis disrupts the vasa vasorum. So the vessels that supply the big vessels like aorta. So vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilation of aorta and valve ring. So this is what I was talking about when they deliver a baby and the umbilical cord is necrosed. It's what could be the cause of this. It's going to be treponema pallidum, right? Because that's the one that causes syphilis. So tertiary syphilis disrupts the vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilation of the aorta and valve ring. May see calcification of aortic root, ascending aortic arch, and thoracic aorta. Leads to tree bark appearance of aorta. Let's see if there's a photo for that. They're not going to show you the photo for this instead, but that's what it looks like. Can result in aneurysm of ascending aorta or aortic arch, aortic insufficiency. Acute pericarditis. This is inflammation of the pericardium. Okay. This thing right here. So inflammation of the pericardium commonly presents with sharp pain. This is the one where I told you that the patient is trying to lean forward and it makes them feel better, right? So, and if you were listening to it, it's going to have a friction rub. You'll hear a friction rub. Okay. Inflammation of the pericardium commonly presents with sharp pain, aggravated by inspiration, and relieved by sitting up and leaning forward. Often complicated by pericardial effusion between yellow arrows in A. So this is the pericardial effusion. So this can happen because of this. Or wait, often complicated by pericardial effusion. Yeah, okay. Presents with friction rub. ECG changes include widespread diffuse ST segment elevation. Okay. Again, elevation happens because the signal had to travel all the way around. Right? So now it's just, if it's going from here, point A to point B, now it has to travel along this one, right? Instead of just going straight to this. Try to make sense of it like that. ST segment elevation and or PR depression. PR depression is the start of atrial depolarization to the start of ventricular depolarization. Okay, so depression in that area. Causes include surgery, cardiac causes. So surgery of heart, connective tissue disorder, cardiovascular events, for example, acute MI and Dressler syndrome. Autoimmune, for example, SLE and rheumatoid arthritis. Radiation, renal failure, uremia. Right. Idiopathic, most common, presumed viral. Infections, for example, Coxsackie B and neoplasms. Okay. So when they tell you that patient is sitting up and leaning forward, that means there's pericarditis. So then you have to figure out what's the reason for it. They might tell you that neutrophils are increased or lymphocytes are increased or something like that. You can figure it out from that. If they tell you the blood was normal, right, but there was increase in proteins, it could be autoimmune. If they tell you that there's some kind of malignancy, it's because of neoplasm. If there's increase in creatinine and everything else is normal, it's going to be because of this. Maybe increase in BUN as well. Not normal, but BUN and creatinine are increased. That's going to be this. For idiopathic, it could be. It's none of these, basically. None of these, so it's going to be the most common cause is idiopathic. Okay, so we just assume that it's viral. Treatment. Oh yeah, and cardiovascular event, so acute MI or Dressler. For Dressler, you will see, immunoglobulins near the heart, okay, because that's the complex settles where this is, and then it's going to cause reaction, which is called the Dressler syndrome. This is different than the autoimmune causes, which is SLE and rheumatoid arthritis. Treatment is NSAIDs, colchicine, glucocorticoids, dialysis. NSAIDs because of leukotrienes, it decreases the inflammation as well. Colchicine because it reduces the, what does it reduce? What's the MOA of colchicine again? Isn't this okay? So action tubulin disruption. This leads to subsequent downregulation of multiple inflammatory pathway and modulation of innate immunity. Okay, so it's anti-inflammatory. That's why you give it in the cow. Glucocorticoid corticosteroids suppresses immunity again for this, right? And inflammation is anti-inflammatory. Dialysis because of uremia, so we gotta filter out the blood to get rid of the waste products. Myocarditis. Inflammation of the myocardium leads to global enlargement of heart and dilation of all chambers. Major cause of sudden cardiac death in adults less than 40 years old. Presentation is highly variable, can include dyspnea, chest pain, fever, arrhythmias. Persistent tachycardia out of proportion to fever is characteristic. Multiple causes. So it could be basically anything and everything, right? They'll give you that it was gram positive, gram negative, or DNA or RNA virus or something like that, right? So viral, for example, adenovirus, this is the DNA virus. Coxsackie, that's the hand, foot, mouth disease, right? Found in what class of RNA, if you can remember? Purge, I think. Parvovirus, B19, that's DNA virus. HIV, right, that's retro. And herpes, right, HHV6, that's Rosella one. Human herpes virus, so that's the Rosella one. Okay, the fever comes first and then it gets resolved and then you get the rash. Lymphocytic infiltrate with focal necrosis, highly indicative of viral myocarditis. Okay, if you have lymphocytic infiltrate with a focal necrosis, always think viral for myocarditis. Okay, again, lymphocytic infiltrates with focal necrosis is viral cause of myocarditis. Okay, parasitic threats, for example, Trypanosoma cruzi. Okay. That's the one that looks like the hat. And then you have Toxoplasma gondii from the cat. Contaminated and pregnant ladies should stay away from cat. You'll see ring formation and hydrocephalus in a baby, one of the torch syndromes. So you see hydrocephalus, if you remember the little Gandhi photo that I had. Calcification, the eye. Head lenses, so that's for retinal something. Ring lesions as well. Then sunspots for calcification, and the big head was hydrocephalus. Bacterial, Borrelia burgdorferi, that's the Lyme disease one. Mycoplasma pneumoniae, that's the walking pneumonia one. Coronary bacterium diphtheria, that's the bullneck one. Also it looks like the safety pin or clubs. I forgot. It's one or the other. Actually, let's check it out so we don't forget it. Yeah, so it looks like clubs, dumbbells. Okay, dumbbell one. Toxins. For example, carbon monoxide and black widow venom. Okay. This is due to burning house furnace and all that stuff, heating and all that stuff. What does it do? It causes leakage of protons, causing no, not this one. What was this one? I'm losing my biochemistry. Okay, we'll just move on. Rheumatic fever, drugs, the doxorubicin and cocaine, they cause dilating myocarditis, dilated myocardiopathy, cardiomyopathy, sorry. Yeah. Autoimmune, for example, Kawasaki disease, that's the strawberry tongue one. Sarcoidosis causes vitamin D. It happens in middle-aged women usually, and predominantly it happens in like blacks. SLE, that's systemic lupus erythematosus, as well as polymyositis, and so this was butterfly rash, right? Or malar rash. For this, it's going to be weakness in the hips or shoulders kind of thing, and croton nodules, or you'll see a shawl-like rash for poliomyositis or dermatitis. Also, you'll find anti-Joe and anti-Me Too for these. Okay. Complications include sudden death, arrhythmia, heart block, dilated cardiomyopathy, heart failure, mural thrombus, and systemic emboli. Mural thrombus is it affects all three layers with systemic emboli. Okay, got through that. Cardiac tumors. The most common cardiac tumor is a metastasis. For example, melanoma. Okay. So most of them are metastasized and come here and make it. The most important one is myxomas. Okay, remember I showed you the video for this. So it's the most common primary cardiac tumor in adults. Arrow in A. Okay, so that arrow right there. And it happens in left atrium all the time. It won't happen anywhere else. So if you see any kind of formation of a ball or something and it's moving, it's gonna be myxoma. But if it's not moving and it's somewhere attached to the anywhere else other than the valves, it's gonna be because of thrombus. Okay. So 90% occurs in atria, mostly left atrium. Myxomas are usually described as a ball valve, right? So obstruction in the left atrium. So what happens is when blood comes in and these valves open up, there's a forceful suction right into the left ventricle. So this ball is gonna go and attack and block that little opening, and that's why it causes obstruction in the left atrium, associated with multiple syncopal episodes, because then the blood is not reaching the brain, right? The head. Interleukin 6 production by the tumor. So it produces IL-6, that's the acute phase reactant, leads to constitutional symptoms. For example, fever and weight loss. Remember, that's the one that causes cachexia, are responsible for all that stuff, weakness, cachexia and all that. May auscultate early diastolic tumor plop sound, mimics mitral stenosis. Murmur and symptoms worsen in upright position, improve when laying down. Histology is gelatinous, so this is important. Histology is gelatinous material, myxoma cells immersed in glycosaminoglycans, also known as GAGs. Okay. Adults make 6 mixed drinks, so remember that, and most importantly, remember the makeup of it. Gelatinous material, so immersed in glycosaminoglycans. Okay. And then you have rhabdomyomas, most frequent primary cardiac tumor in children. It's associated with tuberous sclerosis, type 1 and type 2. Remember, they have that. Histology, hematose growth, and most common in ventricles. Causal signs, paradoxal increase in okay, that's a cosmal sign, right? So just like the paradoxal pulse, you have to remember pulses, paradoxes. Just like that, you also got to remember cosmal. It's right next to it, so don't mix up the two, because on a test you might mix up the two. So this is paradoxal increase in JVP, okay, on inspiration. That one was increase in systolic blood pressure during inspiration. This one is increase in jugular venous pressure. Normally, inspiration causes negative intrathoracic pressure because of diaphragm pulling downwards and causing negative pressure in the lungs. So that those lungs are gonna create a suction in the right heart. Okay, so negative intrathoracic pressure, which will cause increase in venous return. There will be increased amount of blood coming into the right atrium. Okay, and this will cause decrease in jugular venous pressure. Now, if there's impaired right ventricular filling, you'll have right ventricle which cannot accommodate increase in venous return during inspiration, right? So then you'll have blood backing up into the vena cavas, and this is what's called the cosmal sign, right? May be seen with constrictive pericarditis, restrictive cardiomyopathy, and right heart failure, and massive pulmonary embolism, right atrial ventricular tumor as well. Okay. Just know what this is and where it happens. It does not happen in the left heart. Okay. It could be around the heart. It could be on the right side of the heart. It could be in the lungs, right atrial or ventricular tumors, but not the left side of the heart. Why? Because left side doesn't affect the GVP, right? Hereditary hemorrhagic telangiectasia, also known as Oslo-Weber-Rendu syndrome. This is autosomal dominant disorder of blood vessels. I think this is the one where you have decrease in immunoglobulin A, G, and E, right? Because of the age that we talked about. Actually, let's go look at that real quick. Ataxia. Right there. So decrease in hemoglobin A, hemoglobin G, and hemoglobin E. Right. There's increase in EFP. Okay. Lymphocytic cellular atrophy and increase in risk of lymphoma. The way I told you guys to remember this is that this thing is it's on the skin, and skin ages, right? So, and it happens because of exposure, ages because of exposure to rays. So it was X-rays exposure, right, which increases the sensitivity to radiation. Okay, back to 323. Okay. Hereditary hemorrhagic telangiectasia. So what is that? Findings are blanching lesions, telangiectasias on skin and mucous membrane, recurrent epitexis, AVMs, or also known as atriovenous malformations, for example, in brain and lungs and liver. GI bleeding, and hematuria. Okay. Cardiovascular pharmacology. Okay. So now we're on pharmac section of the CVS. You have hypertension treatment. For primary hypertension, you just give whatever decreases the blood volume. Right. So you have thiazide. You have ACE inhibitors. You have angiotensin 2 receptor blockers. So those both are part of the RAS system. So it's blocking the RAS response. Then dihydropyridine, calcium channel blockers. You have hypertension with heart failure. Then you give diuretics, ACE inhibitors, ARBs, beta blocker compensated heart failure, and aldosterone antagonist. Okay. You give diuretics in this. You give diuretics in this, but thiazide one. Here you also give ACE inhibitor and ARBs. Here you give ACE inhibitor and ARBs. You give beta blockers in heart failure, but only for compensated heart failure, right? You can't give it in decompensated one. Why? Because it's not preserved ejection fraction. Right. So aldosterone, you also give aldosterone antagonist. That's also part of, I guess, this right here, because it does the same thing. Blocks the RAS response. So when you block the RAS response, what's going to happen in hypertension? So when you block the RAS response, what's going to happen in hypertension? You're going to get ANP and BNP, right? Atrial natriuretic peptide and brain natriuretic peptide. And what do they cause? They cause, they try to lower the blood volume, and they only get released when there's high blood volume going through the atria and ventricles. So now you're not going to get that aldosterone escape mechanism or response, right? Because you're blocking the aldosterone antagonists. Okay. Beta blockers must be used cautiously in decompensated heart failure and are contraindicated in cardiogenic shock. In heart failure, ARBs may be combined with the neprilyl inhibitor and sacubitril. Okay. Hypertension with diabetes mellitus, ACE inhibitors, ARBs, again, RAS system, calcium channel blockers, thiazide, diuretics, and beta blockers. Okay. This is just hypertension with diabetes. Nothing about the heart. So, ACE inhibitor and ARBs are protective against diabetic nephropathy. So remember that. These are your prils, and what was the other one? We'll look into it. Okay, so these are protective against diabetes, and normally people who have diabetes do suffer from hypertension. Why? It's because of the hypofiltration that happens, right? So it's going to cause that. It's going to cause renal artery to get arteriosclerosis around that as well. And yeah, beta blockers can mask hypoglycemia symptoms. Okay. What's hypoglycemia symptoms? That's when you're feeling dizzy and they seem like they're drunk, but they're going into hypoglycemic coma or whatever. Hypertension and asthma is you give ARBs, but you can't give ACE, right? Because of bradykinin inhibitor as well. That's because ACE breaks down bradykinin. So if you give ACE inhibitor, then there's going to be rampant action of bradykinin. Okay, so ARBs, calcium channel blocker, thiazide diuretics, and cardioselective beta blockers. Cardioselective ones are which ones? That's A2M, was it? I'm trying to remember. Yeah, A2M, I believe that's right. So all the lols that start, the first letter starts from A to M. Those are the cardioselective. Everything after M, so N to Z are both cardio and beta 2 selective. Avoid non-selective beta blockers to prevent, so that would be N to Z. Avoid non-selective beta blockers to prevent beta 2 receptor induced bronchoconstriction. Avoid ACE inhibitors to prevent confusion between drug or asthma related cough. Hypertension, so the cough is from the bradykinin, sorry. Hypertension and pregnancy. New moms love hugs. This is the way you should remember it because that helps. No, wait, new moms. There was another one actually, not this one. But anyways, now I just remember it. So nifedipine, methyl-dopa, labetalol, and hydralazine. They're all safe to be given for hypertension in pregnancy. Now, cardiovascular agents and molecular targets. So the calcium channel blockers. There's dihydropyridine over there. Okay. And there is ANP, BNP over here, and nisituride. Here we have nitrates. That's this whole mechanism here. We have GQ agonists, right? So that's, remember the diagram that we looked at. This diagram, right? Right. So GQIP3, which goes to sarcoplasmic reticulum, and then the calcium then goes on to activate MCL or medium light chain kinase, right? Calmodulin complex, or it can come from here, L-type voltage gated channel, and it does the same thing. When it activates MLC kinase, what happens? It phosphorylates the myosin P and causes contraction. Myosin and actin, so they need to be phosphorylated to cause contraction, right? So that when there's phosphatase available, then the P goes away and that causes relaxation. Okay, so let's go through this. Okay. Look at that while we read. So we have calcium channel blockers: amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, right? Dihydropyridines act on vascular smooth muscle, and then you have non-dihydropyridine. These are diltiazem and verapamil. Okay, so they act on the heart. So the place where you might get confused is which one was acting on the heart and which one was acting on the system, right? So I guess you can remember it like non-die. So you would die if it was on the heart. So if you want to prevent dying, so non-die, it's going to be non-dihydropyridine on the heart. Okay, and these are your diltiazem and verapamil. Dil also means heart in Hindi, so I don't know for the you non-Hindis if that would help, but yeah. And then you have verapamil. Okay, Vira means like warrior as well. So warrior have like big hearts kind of thing. Just a way to remember that they're non-dihydropyridine and they act on the heart. Okay, and all these other ones they act on smooth muscle, the dipines. So their mechanism is similar. So mechanism, they block voltage gated L-type calcium channel. So that thing right there, and smooth muscle. causing decrease in muscle contraction, right? That vascular smooth muscle. So amlodipine will have same effect on smooth muscle as nifedipine, but then also they both have greater effect than diltiazem and verapamil. That's why they're not given in smooth muscle for smooth muscles, right? Over here and hypertension. So vascular smooth muscle, okay. And then for heart, verapamil has a greater effect than diltiazem, which has a greater effect than amlodipine, which is similar to nifedipine on heart. Okay, so L-type voltage-gated calcium channels. Remember that. That's the important one. Okay, dipines act on that. Clinical use, dihydropyridine. So dihydropyridine is not the heart one. So except nimodipine. Nimodipine is the one that they use for SAW, I think. Is that given? Yeah, SAW. So the way I remember this, for you folks in India, Nimo is like Namo, right? And Narendra Modi, and he stays with Amit Shah for SAW, or subarachnoid hemorrhage. That's how I remember nimodipine for SAW. For other people, I don't know how you're gonna remember that, but remember that nimodipine is for SAW, and this is very important because they test you not only in this but also in neuro or CNS. Yeah. Okay. So dihydropyridine, except for nimodipine, it's used for hypertension, angina, including vasospastic type, Raynaud phenomena. Dihydropyridine mainly dilates arteries, okay, and it's given for hypertension and angina. You have nimodipine for subarachnoid hemorrhage. It prevents cerebral vasospasm. You have nicardipine or clevidipine. This is hypertensive, used for hypertensive urgency or emergency. So urgency is when there's no end organ damage, and emergency is when there's damage. Dihydropyridines, non-dihydropyridines, so these are your heart ones, is given for hypertension and angina and atrial fibrillation or flutter. The adverse effect is gingival hyperplasia. Dihydropyridine will cause peripheral edema, flushing, and dizziness. Non-dihydropyridine, cardiac depression, AV block, hyperprolactinemia, and verapamil, that's the important side effect, and constipation. Okay, hydralazine. Mechanism is it increases GMP, right? So CGMP would be right over there. Okay. So I don't see hydralazine anywhere, but it increases CGMP. Okay, so it increases CGMP, which leads to smooth muscle relaxation, right? So when you have this, it causes increase in MLC phosphatase activity. So myosin and actin will lose the P or phosphate group, which causes relaxation. Okay. Hydralazine vasodilates arterioles more than veins. Okay. Afterload reduction. There's reduction in afterload but no effect on the preload. Clinical use: severe hypertension, particularly acute, heart failure with organic nitrates, safe to use during pregnancy, frequently co-administered with beta blocker to prevent reflex tachycardia. Sorry. So basically, What would this do? So when you give a hydralazine, what's going to happen? There's going to be decrease in the vasoconstrictions, right? So decrease in afterload and all that stuff. But when you do vasodilation, what happens? Sorry, I think I said the wrong thing somewhere up here. So when you do vasodilation over here, vasodilation, there is decrease in venous return as well, because if there's pulling of blood in arterioles, there's not enough pressure for that to increase blood in veins either. So it's gonna have decrease in veins, which will decrease venous return. So that will decrease preload as well. Okay, so when you have decrease in preload, that will decrease the afterload as well, right? That's why there's afterload reduction. So when that happens, decrease in cardiac output again goes to the brain, signals the brain, and the brain sends sympathetic signals. So when you have sympathetic signals on the vessels, it's going to try to cause vasoconstriction, but that's not going to happen because there's high activity of MLC phosphatase, right? So even though there would be MLC kinase activity, this one's going to overpower it. So there will be net vasodilation, and also it's going to activate the beta receptors. So to prevent that, because that would cause the reflex tachycardia, you give beta blocker for that. Adverse effect: compensatory tachycardia, contraindicated in angina and coronary artery disease. We talked about that. Fluid retention, headache, angina, and drug-induced lupus. We talked about it in angina portion. Why you shouldn't give vasodilators, right? Because of the coronary scale syndrome. Then you have a hypertensive emergency. So treat with labetalol, clofidipine, phenylidipam, nicardipine, and nitroprusside. So nitroprusside is short-acting vasodilator. It has an equal artery and venous action. There's increase in cGMP again. It causes MLC phosphatase to activate via direct release of NO. Okay, so nitric oxide. Nitric oxide comes from L-arginine. Okay, that's important to know. So they'll be like, okay, which amino acid activity is increased if there's vasodilation. So that's going to be L-arginine, because vasodilation primarily happens because of three things, and one of them is nitric oxide. Nitric oxide synthase is activated by calcium, and calcium is activated by these things: acetylcholine alpha agonists, alpha 2 agonists, right? Bradykinin and cytokines. Because remember, alpha 1 is the vasoconstrictor, not alpha 2. Then histamine and serotonin and shear stress. Okay, it can cause cyanide toxicity. Releases cyanide. Phenylidopam. Phenylidopam or dopamine. There are dopamine D1. D1 was excitatory, right? But it decreases stuff. So dopamine D1 receptor agonist, coronary, peripheral, renal, and splenic vasodilation. Okay, so it activates the vasodilation kind of thing. Okay, decreases blood pressure and increases net uresis. Also used post-operatively as an antihypertensive. Can cause hypotension, tachycardia, flushing, headache, and nausea. Nitrates: nitroglycerin, isosorbide, dinitrate, and isosorbide mononitrate. They all have nitrate in them, and nitrate, you just think of nitric oxide, and what does nitric oxide do, right? Vasodilate. So vasodilate by increasing nitric oxide in vascular smooth muscles. So this leads to increase in cGMP and smooth muscle relaxation. This has more action on the veins than the arteries, and this will cause decrease in preload in the right atrium and right ventricle as well, right? Clinical use: angina, acute coronary syndrome, pulmonary edema. Remember, again, this is a vasodilator, so coronary steal syndrome will happen there. Adverse effects: reflex tachycardia, because remember, similar thing to up there, hydralazine. You'll have decrease in cardiac output, so that will cause the brain to think that no, we need to cause vasoconstriction and activate the beta 1 receptors on heart, so we can block that with beta blocker. Methemoglobinemia, hypertension, flushing, headache, Monday disease, and industrial nitric exposure. So what happened back in the day when this is why people hate Mondays, because throughout the week they have been exposed to nitrates, and they're used to vasodilation in their body. But when they go home during the weekend, the exposure is gone, right? So then the body recalibrates itself. So when they come back to work on Monday, they have vasodilation, which causes headache and all that stuff. So that's why they hate Monday disease, because the tolerance that they built up during the week is all gone by the weekend, in the weekend, or during the weekend. Okay, so Monday disease and industrial nitrate exposure, development of tolerance for the vasodilating action during the work week, and loss of tolerance over the weekend. So then they have tachycardia, dizziness, headache upon re-exposure. Tachycardia because of reflex tachycardia. Okay. And when you have increased tachycardia, already there is decrease in venous return, decrease in preload, and whatever blood was trying to come in, tachycardia, due to increase in heart rate, it's not going to fill up the whole chamber either. So there's even less blood going to the head. So that causes headache upon re-exposure. Contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDE5 inhibitor use. Right, that's your Viagra one. So sildenafil. This is why you get those warnings on the news, or like ads, sorry, not news, but ads where they tell you that if you had erection for longer than 4 hours, you should go see a doctor. It's because of this. If it's given with heart medicine, which is usually nitric oxide. Okay. Because remember, what this does is it relaxes the vessels in the thing, in the penis, and that causes the erection, and that's what the function is for this. But and also this causes vasodilation as well, nitrates, right? So now there is no opposing action basically, and that's why what this can cause is not vasodilation, vasoconstriction. Okay, vasodilation, right? I'm just trying to figure this out in my head. So there's increased vasodilation in this, so there's going to be ischemia because of some reason. We'll come at it in repro, I guess. But basically, there are chances of ischemia, and you don't want to do that. So that's why you have to go get it trained, basically. Anti-anginal therapy. Goal is reduction of myocardial oxygen consumption, MVO2, by decreasing one or more of the determinant of MVO. Okay. So that's mean venous oxygen saturation or whatever. And diastolic volume, BP, heart rate, and contractility. Okay, so anti-anginal therapy components are end-diastolic volume. Nitrates will decrease it. Beta blocker will have absolutely no effect, or they will increase it. But if you give both of them, there will be no effect, or it will be decreased, because then you don't have reflex tachycardia, right? So then, wait, I'm reading this wrong. End-diastolic volume, okay, I'll just go read through it. End-diastolic volume, nitrates is decrease, beta blockers, no effect or increase, and both together it decreases the end-diastolic volume. Oh, right, yes, because it's anti-anginal, right? So we want to reduce what? We got to reduce the oxygen demand, right? So the goal of reduction of myocardial O2 consumption, that's what that is. Sorry. Wow, I was zoned out during this. By decreasing one or more of the determinants of myocardial O2 consumption. End-diastolic volume, BP, heart rate, or contractility, all of these. Okay, so end-diastolic volume, you decrease it by decreasing the preload with nitrates. Beta blocker, no effect or increase in 1. Beta blocker does what? It blocks B1, which is known for increasing heart rate and contractility. So when you use both of that, it won't have any effect, or it can be decreased on end-diastolic volume. Then blood pressure, again, it decreases, decrease in systemic vascular resistance. Beta blocker will act on B2, which is the vasodilator as well, so decrease blood pressure. Beta contractility, nitrates will increase this because of reflex tachycardia, right? Why does that happen? Again, decrease in cardiac output will cause, why decrease in cardiac output? Because of the decreased preload. It will send signals to the brain, so brain comes back to give sympathetic response to the beta 1 receptors on the heart, right? And that will cause increase in heart rate and contractility. Sorry, that one. And beta blocker, we can block that, so decrease in beta 1, and then you have little or no effect on contractility if you give both of them. Heart rate increase, again, same logic there with nitrates, same logic there with that, and same logic here. It won't have any effect, or it can be decreased in heart rate. Ejection time, decrease with nitrates, increase in beta blockers. Okay, nitrates, it's not going to affect whatever blood volume is coming in, it's going to be the same. It's not going to hurt the function of the heart rate, but here it hurts the function of the heart. So ejection time is going to be increased because now the heart rate is decreased and contractility is decreased. When you give both of them, there are no effect. Then you have myocardial oxygen consumption. With nitrates, it decreases because decreased preload again, right? So decreased stretch on the wall of the heart. With beta blockers, there's decrease in that as well, because decrease in contractility and heart rate, and then with both, it has a synergistic effect. Okay, so verapamil is similar to beta blockers in effect. Okay, we don't have it here. Pindolol, that's not cardioselective, right? Because that's N to Z. So pindolol and acebutolol, that's a cardioselective, are partial beta agonists. Okay, that should be used with caution in angina. Okay. We have like 1, 2, well, just 1.5 page to go. So let me just make another link, and acebutolol are partial beta agonists that should be used with caution in angina. Renalizine and sacubitril. So renalizine mechanism, it inhibits the late phase of inward sodium current, thereby reducing diastolic wall tension. Okay. Again, renalizine mechanism inhibits the late phase of inward sodium current, thereby reducing diastolic wall wall tension, and oxygen consumption. It does not affect the heart rate or blood pressure. Clinical use is refractory angina, and adverse effect is constipation, dizziness, headache, and nausea. This affects the late phase of inward sodium current. It's talking about the funny, funny channels, right? No, inward sodium current, thereby reducing diastolic wall tension. Yeah, it is talking about that. Okay, right. So it's talking about the funny channel in the pacemaker, I guess, because that way, because it takes time to regenerate the potential, uh, the diastolic wall tension will be reduced because of that, and oxygen consumption is reduced as well. Okay, sacubitril, that's mechanism, is a neprilysin inhibitor. So it prevents degradation of bradykinin, natriuretic peptides, angiotensin II, and substance P. Bradykinin in the lungs, natriuretic peptide in the heart, the angiotensin II, right? Uh, that's RAS system, and substance P. They all this will cause increase in vasodilation and decrease in extracellular fluid volume. Clinical use is used in combination with valsartan, right? That's an ARB, to treat the heart failure, reduced ejection fraction, or the systolic dysfunctional heart failure. Adverse effects: hypertension, hyperkalemia, cough, dizziness, contraindicated with ACE inhibitors due to angioedema. Both drugs increase bradykinin. Now we have lipid lowering agent. Okay, so for this, you gotta remember that it prevents breakdown of bradykinin, natriuretic peptide, angiotensin, and substance P, because they'll test you on the mechanism of this and how it reduces or increases vasodilation, and when you would use it. This is an important drug. Lipid lowering agents. So HMG coenzyme A reductase inhibitor, atorvastatin, and simvastatin. Okay, so first let's look at this diagram so you understand what we're talking about. So we have acetyl coenzyme A. This is formation of or synthesis of cholesterol. So acetyl coenzyme A, HMG coenzyme A with the HMG coenzyme reductase, which becomes mevalonate and then cholesterol. With LDL coming in from the LDL receptors, that also makes cholesterol. Okay, so then the cholesterol, also you have ApoE receptor with the chylomicron remnant coming in to make cholesterol, and you have HDL here acting on the cholesterol as well. The cholesterol then becomes VLDL, synthesizes VLDL in the liver, and that VLDL gets thrown out of the liver into the blood, and then the VLDL can have FFA released from it to become LDL again, which gets taken up again by the liver, or the FFA goes into the adipose tissue, and if there's lipolysis in the adipose tissue, then again there's free fatty acids in the blood, like that. The chylomicron separates three ways. One goes into the liver, the remnants, whatever's left over after the free fatty acid, and HDL. Okay, actually not HDL. It combines with HDL, the chylomicron, and then it travels everywhere, supplying its receptors. Okay, so that takes care of that, and then you have intestinal lumen. In the intestinal lumen, you have cholesterol, free fatty acid, and bile acids, and all three of these things will make you a chylomicron, and the chylomicron then goes through the lymphatics into the blood. Okay, so we're gonna attack some of these sites. reduce, cholesterol. So lipid lowering agents. Let's put it down here. HMG coenzyme reductase inhibitor. So that's atorvastatin and simvastatin. This is the first drug usually given to reduce lipids. Okay, these are your statins. So lovastatin, pravastatin, simvastatin, atorvastatin, and rosuvastatin. What do? They stop cholesterol. Okay, so S for stop. How do they stop it? HMG coenzyme reductase. Okay. Remember, there's also HMG coenzyme lyase and all that other stuff, synthase as well. This is reductase. It will decrease the LDL, right? Because if it doesn't make cholesterol, you won't have VLDL. You don't have VLDL, then you don't have LDL. Okay. It increases HDL, right? Because now HDL doesn't have to bother giving up its markers to cholesterol, so then it can give it up to other stuff as well. Triglyceride decreases. Mechanism: it inhibits the conversion of HMG coenzyme to mevalonate, a cholesterol precursor, which decreases the intrahepatic cholesterol, increases LDL receptor recycling down here, and also increases LDL catabolism. It decreases in there's a decrease in mortality in patients with coronary artery disease. So this drug, the statin, decreases mortality in coronary artery disease. Okay. Adverse effects or problems: hepatotoxicity. This is the number one. And then there's this myopathy. Remember, myopathy, because it happens in two things. Okay. It happens in this and also gym fibrosal. Right. So the fibrates, gym fibrosal or fibrates. Myopathy is the number one adverse effect for it. So they might tell you that, okay, so fibrates was given with something else, and it caused CK to rise in urine or something like that. So CK gets leaked out of muscles. So when you have myopathy, you'll have increase in CK. So you were given with fibrates, you were given statins. Okay. So hepatotoxicity, increase in LFTs, myopathy, especially when used with fibrates or niacin. Remember that as well. Niacin is B3. Okay. Bile acid resins, that's cholestyramine, cholestyramine, and cholestyramine. Okay. So bile acid is right here, and that gets inhibited. So when you don't have that, that's an interesting mechanism for that. So let's just go over it. Decrease in LDL. Okay, you don't have chylomicron. You won't have free fatty acids. Sorry, wait. How does that happen? LDL. So chylomicron. Okay, so chylomicron, no cholesterol, no VLDL, no LDL. Okay. So decrease in LDL will cause increase in HDL and increase in triglyceride as well, because of bile acid. So the mechanism is that prevent intestinal reabsorption of bile acids. So liver must use cholesterol to make more bile acid, right? So that's how it happens. So when you see, cholestyramine or cholestyramine or cholestyramine, I think of this Indian dish called chole. It kind of like looks like chole. So they all increase, cholesterol or bile acid. I guess I don't know, but I remember this because of chole now. So chole is just chickpeas, so it won't help you. So just figure that out. How you gonna, if you see this drug, you gotta remember that it's bile acid resin inhibitor. Okay. So adverse effect for this is GI upset, decrease in absorption of other drugs, and fat soluble vitamins. Okay. Then you have ezetimibe. That's also, it decreases LDL, obviously. So if there's decrease in LDL, you have HDL increase. Uh, Triglyceride, it has no effect, or it can decrease it. The mechanism is that. So where's that? It's right here. Reabsorption of cholesterol. Prevents cholesterol absorption at small intestine brush border. Okay. So if it doesn't take in cholesterol, you won't have cholesterol, and it'll have to be made from other stuff. Right? And then you have rare, yeah. So adverse effect is rare increase in LFTs and diarrhea. Okay. Lipid lowering agents is fibrates, again, Jim fibroso, right? The way I remember it, that as Gem, but I read it like Jim, right? Not Jim, it's Jim. Who's Jim? So it's Jim Bro. Okay. So since there's gym, you go to gym to make up muscles. So that's how you remember that there's myopathy, muscle pain, or destruction of muscles kind of thing. So there's decrease in LDL, obviously. If there's decrease in LDL, you'll have increase in HDL. Okay, but the most important thing here is that you're burning triglycerides at the gym. Okay, that's the only one that has like severe decrease in triglyceride. Okay, so that's the main effect of this. How does it happen? Mechanism is that activates PPAR alpha, and it upregulates LPL, increase in triglyceride clearance as well. Activates PPAR alpha, which induces HDL synthesis as well. Okay. So party at the gym. Okay. Party at the gym and bezafibrate and phenofibrate. Don't really have to remember that because this is the one that usually shows up. But if you see fibrate, just remember that Jim fibrosol is also a fibrate. And then you can connect all of this with that. There's party at the gym, so it activates PPR alpha, upregulates LDL, increase in triglyceride clearance because you burn triglyceride at the gym. Okay, and it also induces HDL synthesis. You have muscle pain at the gym because you work out a lot, so myopathy, increase in risk with statins, cholesterol gallstones, via inhibition of cholesterol 7 alpha hydroxylase. Okay, so that's the adverse effect of it. Niacin, you give niacin, it will decrease LDL. Wait, yeah, niacin. Right, niacin is B3, right? Why am I losing my head? Yeah, it is B. Okay. Which one is it? B3. Okay, thank God. Not losing my head. LDL, HDL, and decrease in triglycerides. So it inhibits lipolysis. Okay. Hormone-sensitive lipase. Oh, this thing. Okay. In adipose tissue, reduces hepatic VLDL. Let me just go back to that real quick, if I can. So hormone sensitive lipase, so it prevents this. Okay. Okay. So it inhibits lipolysis. Hormone sensitive lipase, it inhibits this thing in adipose tissue, because this is adipose tissue. Reduces hepatic VLDL synthesis. Okay. There's flushed face, prostaglandin mediated, decreased by NSAIDs or long-term use. So it will cause hyperglycemia, and hyperuricemia. Okay. Okay, so those are the adverse effects. This one is not really tested, so that's why I didn't remember this. But what was tested for this back in chemistry was like they tell you that this person has ketones and he's going through DKA or something, so he has high ketones in the urine. But this person is still making glucose even though he's not been given any glucose. So how is that possible? It's because of glycerol kinase. That's how. Because glycerol kinase converts TGL to glycerol, and glycerol then causes gluconeogenesis in the liver. Okay. You have pesky K9 inhibitors. K9 again, those cutie dogs. But over here they're gonna bite and rip open the LDL receptors breakdown basically. So they won't let it break down basically. They protect the LDL receptors. Okay. So here there's decrease in LDL again. So that's over here. pesky 9. We didn't look at niacin, sorry. So adipose lipolysis. So niacin, so it's going to prevent the lipolysis of FFA. Okay. Yeah. Okay. So for pesky canines is elirocumab or evolocumab. These obviously they sound nothing like dogs, but you can think of them like Pokemons. So Pokemon are pesky canine Pokemon. So it decreases LDL. They bite them and then they reduce it. So if you have decrease in LDL, you will have a rise in HDL, and then you'll have triglycerides decrease. Inactivation of LDL receptor degradation will cause increase in removal of LDL from bloodstreams. Myalgias, delirium, dementia are the adverse effects, and other neurocognitive defects. Okay. For this, you can imagine like the wires that which one was it? The one that's usually, oh yeah, it was a nematode, I think. So a nematode in the dog that enters the human body will cause myalgia, delirium, and dementia, and all these things and symptoms, right? So, or you can just not bother with the dog analogy at all, and just remember that this is where it affects this. And then there's inactivation of LDL receptor degradation, which causes increased removal of LDL bloodstream. And at the end you have fish oil and marine omega-3 fatty acids. They'll increase slightly in LDL. Okay. However, it causes increase in HDL as well, slightly, and it decreases triglyceride at high doses. It's believed to decrease FFA or free fatty acids. It's not in here. Yeah, it's not. So niacin affects here and here. Okay. So believed to decrease free fatty acids delivery to liver and decrease activity of triglyceride synthesizing enzymes. Nausea, fish-like taste. Okay. And we're done with lipids and hypertension drugs. And now we're on to arrhythmics. Wait, not yet. We have glycoside, cardiac glycoside. So digoxin. This is an important drug. The mechanism is direct inhibition of sodium-potassium ATPase, indirect inhibition of sodium-calcium exchanger. So it will increase intracellular calcium, which will cause positive inotropy, stimulates the vagus nerve, and decreases HR, right? So remember this thing while I was explaining this and doing a horrible job at it, and I drew you a circle with like a little receptors, and then I told you that there's like a sarcoplasmic reticulum with more calcium in it. So calcium's gonna come in, it comes in, attaches, and then it attaches to receptor on this, causing release of more calcium out of the sarcoplasmic reticulum. So that thing right here, it's showing here. So why do we do, inhibit sodium potassium ATPase? So you have sodium calcium exchanger right here and sodium potassium ATPase over here. So digoxin comes in, it inhibits this, it inhibits that. Potassium doesn't come in and sodium doesn't go out, right? So when you have enough sodium here, you're not gonna have sodium coming in from the sodium calcium exchanger, right? So if sodium doesn't come in, calcium inside stays inside, and this calcium is then gonna attach to this receptor right here, this calcium here, and then this calcium here. So this calcium attaches to this receptor, and this calcium then gets released outside, right? Similar to this. So then you have increase in intracellular calcium, and the calcium then increase in TNC calcium binding, which causes an increase in cardiac contraction. Not sure what that is, but end result is that there's increase in cardiac contraction because of the whole myosin actin, phosphorylation and all that stuff. So clinical use is heart failure, increase in, because it increases contractility, atrial fibrillation, decrease in conduction at AV node and depression of SA node. Adverse effects, cholinergic effects, nausea, vomiting, diarrhea, blurry yellow vision or when glow, arrhythmias, and AV block. This is an important one. Blurry yellow vision, remember that, because that's unique to this digoxin. All of this you will find in like majority of all the drugs, one of these at least, right? So arrhythmias and AV blocks can lead to hyperkalemia, which indicates poor prognosis. Okay, why hyperkalemia? Because it's staying outside now, right, in the extracellular fluid, which indicates poor prognosis. Factors predisposing to toxicity: renal failure, decrease in excretion, hypokalemia, permissive for digoxin binding at potassium binding site at sodium potassium ATPase, drugs that displace digoxin from tissue binding sites and decrease in clearance, for example, verapamil, amiodarone, and quinidine. Antidote is slowly normalize the potassium and cardiac pacers. Also anti-digoxin Feb fragments, so that's just anti-monoclonal antibodies against the digoxin molecules, and then also Mg, because you'll have electrolyte imbalance as well, magnesium. Okay, now we're on to antiarrhythmics, and for this I'm gonna tell you to watch Dirty Medicine. That's, you go to Dirty Medicine antiarrhythmics. So this one right here, he does a very good job at explaining this, and I won't be able to justify it. So, and this is how I remember those drugs. So watch that video. It's sent on the group as well. So yeah, that's it.